सूर्य ब्रह्म शिव विष्णु गजानन जिन चरणों को सेवते हैं। सूर्य ब्रह्म शिव विष्णु गजानन जिन चरणों को सेवते हैं। हम शिशु है अज्ञानी माता जिन चरणों का प्यार दे।
On the dais, we have Professor Uma Singh as Chief Guest, Professor Navneet Kumar as Chief Coordinator of NatCon, Professor Punita Dr. R.K. Verma as Organizing Secretary of the workshop. Now, I invite the Chief Organizing Secretary of 68th NatCon, Professor Punita Manik ma'am, who is currently the Head of Department of Anatomy at our university. I humbly request her to welcome all our delegates and to introduce us to the workshop.
Good morning and greetings of the day. It is an honor for me to welcome the chief guest of today's function, Professor Uma Singh, who is currently leading our university as Dean Academics, as well as the head of the Department of Obstetrics and Gynecology. She's an excellent clinician, a wonderful academician, and possesses a magnetic aura around her. Words fall short to express her persona. We are indeed honored by her gracious presence. We welcome you, ma'am. I am pleased to welcome Professor Navneet Kumar, who has been currently serving as principal of the Autonomous State Medical College at Basti. Despite his commitments and busy schedule, he has always been with us, guiding us at all times. We welcome you, sir. We are delighted to have a galaxy of luminaries with us this pleasant winter morning. Dr. Sarabpreet Singh, Director, Fertilis Academy, a senior consultant at Artemis Hospital, joins us from Gurugram. Dr. Mona Sharma, Additional Professor in the Department of Reproductive Biology, AIIMS, New Delhi. Dr. Rajendra Singh, Senior Principal Scientist in Male Reproductive Biology, CDRI, Lucknow. Dr. Praveen Kumar Pandey, Consultant Urologist and Renal Transplantation Surgeon at Sahara Super Speciality Hospital, Lucknow. Dr. Amita Pandey, Professor from the Department of Obstetrics and Gynecology, KGMU. And Dr. Jyoti Chopra, Professor from the Department of Anatomy, KGMU, Lucknow. I warmly welcome you all. On behalf of National Conference of Anatomical Society of India, I also welcome our chairpersons and moderators for the session, delegates, and each one of you who have joined this pre-conference workshop of the 68th NatCon of ASI 2021, which will focus on various aspects of male fertility. Infertility is a medical issue with intense socio-cultural impacts. With changing times, male infertility has been recognized as a significant contributor to infertility. Etiologies vary widely, from congenital to acquired to idiopathic. Scientific advancements have led to the widening of diagnostic and therapeutic horizons beyond the basic semen analysis. Today's deliberations will focus on the whole spectrum of issues covering basic physiology, semen analysis, genetics, and lab work related to IVF. I look forward to great learning during the course of the day. Thank you all.
Very wise words from Professor Punita Manik ma'am. Now, it is my proud privilege to invite our chief coordinator of this national conference, Professor Navneet Chauhan sir, who has been currently serving as the principal at Autonomous State Medical College of Basti, to shower his blessings.
Respected chief guest of this workshop, Professor Uma Singh, Head of Department of Ops and Gynae, Dr. Punita Manik, Chief Organizing Secretary of the conference, Dr. Archana, in charge of Cytogenetic Lab, Dr. R.K. Verma, the Organizing Secretary of this conference, eminent delegates, participants, and ladies and gentlemen. This workshop on the in vitro fertilization and mainly focusing on the male infertility. As we know, the male infertility is related with mainly with this sperm. So this started with the reproduction, assisted reproduction. So there are various topics which cover in this workshop. If you see the sperm is single cell. This formed by the modification or rearrangement of the cell organelle. These cell organelles, they perform at their best level to create a new generation. This is one of the greatest evolution. After the intelligence, this is the greatest evolution of the human body. This sperm travels through the many ducts, and at the last moment, it pushed by the seminal vesicles and the prostate, and in form of the semen. So semen analysis, this also included in the workshop. The various pathology we related with the semen analysis. And this semen and the sperm, they may have some cause which leading to the infertility. So if you see the cytogenetics, genetics of this sperm, this is very amazing. The same sperm, just having maybe have the X chromosome or Y chromosome. So this is one of the surprising thing. And the haploid cell, which is a part of the human body, but it is having the different constitution. So genetic analysis of this sperm, this also included in this. And then we will see the overall work of the male infertility. The various aspects will be taken in this. This thing in the male infertility, this most happening things, these are the demonstrated digitally by the video or by the other digital instruments in front of you in this workshop. So with these words, best wishes for the speakers and participants, and I hope this workshop will be fruitful to all of you, and my best wishes with this you. Thanks, thank you very much.
Very well said by sir. Further, we call upon our today's chief guest, Professor Uma Singh ma'am, who is the Dean Academics and Head of Department of Obstetrics and Gynecology at our university, to enlighten us with her words of wisdom.
Good morning, dear friends. It's a matter of great pleasure that today starts the 68th National Conference of Anatomical Society of India. This conference is being organized by the Department of Anatomy of King George's Medical University. On the first day, a pre-conference workshop is being organized today, that is on 27th January 2022. And it's a great pleasure that this workshop is on overview of in vitro fertilization with focus on male infertility. It's really nice that anatomy is now progressing forward and doing a workshop on applied anatomy, and that too on an aspect which is very clear, very dear to a lot of people. I, as Dean of King George's Medical University, and more than that, as head of the Department of Obstetrics and Gynecology, am very excited because this workshop is being organized by the Department of Anatomy, and also there is a collaboration of Department of Obstetrics and Gynecology. I'm happy to note that the topics are varied on in vitro fertilization. There is an overview. Then there would be specialists of different field speaking on different aspects of male infertility, covering varied aspects, the embryology aspect, the development aspect, the clinical aspect, and then in the end are going to do the demonstration also. It is amazing that a workshop can be organized on virtual platform also, even though it takes a lot of planning and lot of concepts to be developed to impart same amount of knowledge on virtual platform. But I'm very happy to note that the organizers have done a great job in converting what was physically planned first into this online virtual platform. I wish all the success to this workshop. I wish that all the participants are immensely benefited, and this would bring all the laurels to the organizers. This workshop is being coordinated by Dr. R.K. Verma, and the organizing chairperson of this conference, Dr. Punita Manik. All of them deserve congratulations and best wishes for this workshop. Thank you.
Very well said. Now, we release the e-booklet. Edited by Dr. Sarappreet Singh, Dr. Mona Sharma, and Dr. R.K. Verma. The manual of pre-conference workshop with the title Overview of in vitro fertilization with focus on male infertility. And this workshop is organized by the Department of Anatomy in collaboration with the Department of Obstetrics and Gynecology, King George's Medical University, UP, Lucknow. And this is supported by the Fertilis Academy. The delegates can visit the website for further details. The copy of this e-booklet will be sent to you all at your email ID in 2 to 3 days. Now, I am inviting the organizing secretary, Dr. R.K. Verma sir, who is currently the additional professor of anatomy at our university, to propose the vote of thanks.
A warm and graceful morning to all. It is my privilege to propose a vote of thanks and acknowledge the contribution of those who worked really hard to make this event possible. I, Dr. Rakesh Verma, on behalf of organizing team of pre-conference workshop of 68th NetCon of ASI, extend my sincere thanks to Almighty for making today's event grand success. I feel great honor in extending my thanks to our esteemed chief guest, Professor Uma Singh, Dean Academics and Head of Department of Obstetrics and Gynecology of King George's Medical University, Uttar Pradesh, who took time out of his busy schedule and enlighten us with her words of wisdom. Thank you, ma'am, for gracing the occasion. I now acknowledge our sincere gratefulness to Professor Navneet Kumar, our Chief Coordinator of 68 NetCon of SI, for his guidance and suggestion for successful planning of this event. Thank you, sir, for all support and blessing. I wish to acknowledge in charge cytogenetic lab, Professor Archana Rani, for constant guidance and support. I also extend our heartfelt thanks to Chief Organizing Secretary of 68 NetCon of SI, Treasurer of Anatomical Society of India, and Head of Department of Anatomy, Professor Punita Manik, for unconditional support for the cause. Thank you, ma'am. I owe to our esteemed expert faculty, the Director, Fertility Academy, Dr. Sarpreet Singh, and his team, Mr. Sehgal, Dr. Rajendra Singh from CDRI Lucknow, Dr. Mona Sharma, additional professor from AIMS, New Delhi, Dr. Praveen Pandey, consultant urologist from Sahara Super Specialty Hospital, Professor Amita Pandey, Professor of Gynecology, KGMU Lucknow, and Professor Jyoti Chopra, Professor, Department of Anatomy, KGMU Lucknow, chairpersons and moderators for accepting our invitation, for sharing knowledge, and making this event a platform where our more than 250 participants will be able to carry some useful tips with them. I also like to express our appreciation to our delegates for their enthusiastic participation from all corners of our country, of making this event a huge success. This pre-conference workshop is a result of continuous effort, organizing team, our faculty members and residents under the able guidance of all members of advisory committee. I thank you all. Our sincere team, Mr. Kapoor and his team, IT cell of KGMU, in charge Kalam Center and its staff for supporting us all the way. Jai Hind. Dear participants, please switch on your video and remain connected for a short while as we are taking the screenshots. Thank you again. Thank you very much. Audience, please open your video for a moment. On the screen, we can see Professor Sanjeev sir. Welcome. Dr. Sarpreet Singh. Most welcome, Dr. Sarpreet. Other delegates are requested, please open her video. All the delegates requested, please switch on your video, by which we can capture this moment, precious moment. Thank you very much. Now we are going to start session of the workshop. For that, I invite Dr. Nikhil, please continue.
वीडियो यहाँ से वीडियो नहीं आ रही, इसको कनेक्ट करना। Very well. So let's begin with the sessions. Audio is recorded. I see many delegates have just joined. My screen is visible. Ritesh, my screen is visible. My screen is visible. I see many delegates have just joined. Indeed, it's a winter morning for all of us. So, for all those who have missed, on behalf of the organizing committee of the 68th National Conference of the Anatomical Society of India, which is being organized by our Department of Anatomy, I, Dr. Nikhil Agarwal, who is working as a senior resident in this department, have the privilege to welcome all the delegates to share their knowledge with our large family of anatomists all over the globe. So we'll begin with the activity sessions for the workshop. First of all, let's welcome Dr. Sarabjit Singh, who is Sarabpreet Singh, who is MD from AIIMS, New Delhi. He is currently working as a senior consultant and chief embryologist at the Artemis Health Institute since 2009. IFS and ESHRE certified senior clinical embryologist. Convener IFS SIG clinical embryology from 2018 to 2020. His areas of interest being cryobiology and male infertility. Here are certain banners which we have showed for all the delegates. Here it displays the services and the courses offered with hands-on courses, virtual classrooms, which all the delegates can have a look at. Welcome, sir. So please unmute yourself. So the team is just selecting your name and helping you to unmute.
Yeah, thank you so much. Sorry, I forgot your name.
Sir, Dr. Nikhil, sir. We're working as a senior resident here in this department. Yes, sir.
So I think after a lot of efforts, the time has come to begin this workshop.
Definitely, sir.
Yeah. So good morning, respected seniors and faculty members, dear colleagues and delegates. Greetings to Dr. Uma Singh and other dignitaries on the dais. I can see Dr. Sanjeev Jain, who was my teacher during my MBBS days. A warm greeting, sir. And at the outset, I would like to thank the organizers, especially Chief Organizing Secretary, Dr. Punita Manik, who is a very respected teacher and organizing chairperson, and my dear friend, Dr. Rakesh Verma, who has worked very hard towards a seamless execution of this workshop. And thanks for inviting us to this wonderful platform. It's indeed an honor and a privilege to be amongst all of you and conducting this workshop virtually. The theme is Overview of In Vitro Fertilization with a focus on male infertility. We are privileged to have amongst us Dr. Amita Pandey, Dr. Jyoti Chopra, Dr. Praveen, Dr. Mona Sharma, and Dr. Rajinder Singh. All of them are extremely renowned professionals in their respective specialties. Our esteemed faculty members will share their knowledge and experience. Dr. Amita is going to speak on an overview of assisted reproduction techniques. It is difficult to understand any subject till we understand the basics. So Dr. Chopra will be discussing the structure and physiology of sperm. Dr. Mona will carry on by speaking on semen analysis, which is the cornerstone of infertile males evaluation. These will be demonstrated virtually post-lunch by Mr. Sehgal and his team. My dear friend Rajinder Singh, he will be speaking on genetics of male infertility, a subject that is widely ignored by our practitioners. In the end, Dr. Pandey will enlighten us on how to work up an infertile male. And finally, we conclude the session by having a overview of what happens inside an IVF lab, which I'll be taking up. Special thanks to Dr. Mona Sharma, who has worked extremely hard to bring out the manual. And I would also like to thank Mr. Sehgal from Infotech, New Delhi, for supporting us in this endeavor. I sincerely hope that this workshop will be of great utility to all the delegates, and best wishes to all. With this, we declare the workshop open. Dr. Rakesh, you can take over.
Thank you, Dr. Sarpreet, for your kind words. Now we're going to start our session. Dr. Nikhil, please take the seat and convey the workshop.
Thank you, sir, for your kind words. So for the first session, let's welcome Dr. Rashmi Banhotra, who is the additional professor in the Department of Anatomy, AIIMS Rishikesh. She has a teaching experience of more than 14 years. Her publications are 25 plus. Scientific presentations in the international and national conferences, which are 30 plus. She has participated in more than 40 workshops and CMEs. Her research interests include cytogenetics, medical education, gross anatomy, histogenesis, and she has been the member of committees, the website committee, annual report committee, library committee of the AIIMS Rishikesh. Ma'am, I want to welcome you. Dr. Rashmi, ma'am, if you can hear me, please unmute yourself. Dr. Rashmi, ma'am.
Hello.
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 Welcome. Good morning.
The host was not allowing us to unmute, no?
Yes, ma'am. We have done that.
Okay. So good morning, everybody. Am I visible to you?
Ma'am, your video is not yet visible to us.
Okay, but I've already switched on the video. Okay. Good morning to everybody. Good morning to the organizers, and thanks for the welcome. And I hope this workshop will be a very fruitful one, considering the topics that are going to be discussed. And we are hoping to learn a lot from you all. Good morning.
Ma'am, please welcome our chairpersons and proceed with the session.
Okay.
Ma'am, is my screen visible to you?
Yeah, I would like to welcome our chairpersons. First of all, I'm going to we are welcoming Dr. Sabita Mishra, who is Director, Professor and Head of Department of Anatomy, Academic Officer, Maulana Azad Medical College, New Delhi. She is Coordinator for NBE in Anatomy and has teaching experience of 30 years. She is Chairperson of BIS, that is Bureau of Indian Standards for Anatomy and Forensic Sciences. Welcome, ma'am. Good morning. Good morning, ma'am.
Good morning. Good morning, everyone.
Yeah. Ma'am, I hope everything is going on well on your side.
Yes, and I'm
I'm still to I'm like I'll be reading your it has you have a vast experience in various fields, so I'll be carrying on with your introduction. Good morning, ma'am.
Good
And
morning,
now,
good morning, everyone.
now we would like to welcome Dr. Aribam Jayashree Devi. She's Professor, Department of Anatomy, Regional Institute of Medical Sciences, Imphal. She has teaching experience of 25 years and has been guide and co-guide of PGT. She has 33 articles published, mostly on organs of fetus, gross histogenesis, radiology, and genetics. She has attended national and international CMEs, workshops, conferences, presented papers, posters, and chaired sessions. And she is member of organizing. She was member of organizing committee 62 NatCon in 2014, held in Imphal. Welcome, ma'am. Peer review of reviewer of Curious Journal of Medical Science, and other notable things are national workshop on assessment methods for learning evaluation in basic medical sciences, training course on educational science and technology in medical education, workshop on transplant immunology organized by DVT Healthcare, laboratory for HLA tissue typing and transplant immunology, and workshop on stereology. Welcome, ma'am.
Thank you so much.
Now,
Thank you so much.
good morning, ma'am. Welcome. Now, third chairperson for this session would be Dr. Mridula Chandrakala. She is additional professor and head, associate dean research in AIMS, BB Nagar, Telangana. Her qualifications are BBS MD from Dr. NTR University, and basic and advanced courses she has done are MET, basic course in research methodology, CISP, ACME, and FIMA Fellowship 2019. She has 55 national and international publications to her name, and she's editor of BD Chaurasia Textbook of Anatomy and has authored more than 8 books. Welcome, ma'am. Good morning, ma'am. Now we would like to introduce Dr. Amita Pandey, Professor, Department of Obstetric Gynecology, King George Medical University, Lucknow, UICC ICRETT Fellowship from UPENN, Philadelphia, USA. She is visiting professor, Weill Cornell Medical Center, New York, and has more than 100 index publications in international and national journals. She has contributed to several maternal health guidelines for Government of India. Welcome, ma'am. Good morning.
स्क्रीन शेयर कर दो, इसमें से मैं ऑफ कर रहा हूँ, ठीक है?
Good morning, ma'am.
Good morning to everyone.
Very good morning to all of you.
I think we can proceed for the session.
Yes, yeah. I'm just trying to share my screen so that
Okay,
it is visible to everybody. Is my screen visible to all?
It's getting started, ma'am.
Full screen. I am sorry, there is a little confusion. Please bear with me till we are able to fix up this problem and share my PPT. Stop sharing.
Stop. Screen is being paused. Stop sharing. शेयरिंग शुरू से कर। कौन सी वीडियो वाली है? अब दिख रहा है? हाँ अब आ गई। कर ऑडियो जा रहा है? हितेश?
Am I audible to everybody? Am I audible?
Yes, you are.
It is not full screen.
मैम इसमें कर दिया, इसमें आ रहा है। एक मिनट, it will take 1 minute.
Okay, so a very good morning to all of you. And at the outset, I would first like to thank the organizers of this conference for giving me this wonderful opportunity to be a part of this pre-Congress workshop and interact with all of you. I have been asked to introduce assisted reproduction before this very important workshop. Now, as we all know, infertility is a very distressing problem. I think my slides are not moving. Just give me a minute. Just give me a minute, please. The slides are also not moving. Amita Natkon. Please bear with me, friends. There is some problem and the slides are not able to move. Amita Natkon.
We're just connecting.
We are just connecting. Shall I go there? Okay.
No, it's connected now. It's connected.
He's asking me to go there. It's okay.
You can just begin now.
Thank you. So, friends, as we all know, infertility is a very distressing problem, and assisted reproduction is a very important method which can help couples overcome this hurdle, this psychological, social hurdle, and plan a baby and go a family way. So if we look at the world statistics, we can see that infertility is rampant all over the world. Although it is not possible to get the exact prevalence of infertility, but the demographic details tell us, and various fertility and health surveys tell us, that approximately 1 in 6 couples suffer from infertility, and around 10% of them would need the help of assisted reproductive technologies. Now, if we look at the Indian scenario, we can see that around 10 to 15% of all married couples are affected by infertility. And if we see the zone-wise distribution, we can see that infertility is there all over India, but more so in the south, mainly because that is the area where the corporate sector is mainly there, and it is there where there is a lot of stress and lot of problems. The youngsters are there, and hence probably the incidence of the prevalence of infertility is also high. What is a reason of concern in India is that infertility is on the rise in India. This is mainly because of the unhealthy lifestyle of the youngsters, because of unhealthy eating habits, because nowadays the couples are postponing their pregnancy, and they usually start planning for their pregnancy at an older age. Apart from this, stress is also a very important factor that is contributing to both male and female infertility. Now, when we look at the causes of infertility, unlike the myth that is there in the society that most of the infertility is because of the female partner, you can see here that around 30% of the causes of infertility is because of the male factor, 30% is because of the female factor, 10% is because both the husband and the wife are have some problem, and around 25% is unexplained infertility. Now, with this background on infertility, let us now come to assisted reproduction. What actually is this assisted reproduction? Assisted reproduction actually includes procedures that involve in vitro handling of oocytes and sperms or embryos to establish pregnancy. So it includes all procedures in which the male and the female gametes are collected and they are fertilized in the lab in a petri dish, and then the embryo so formed is then transferred to the uterus for implantation and subsequent growth. Now, what is very important to remember here is that this does not include treatments where only sperms are handled, that is intrauterine insemination. So that is not a kind of assisted reproduction. Now, if we look at the history of assisted reproduction, right from the year 1978, when Louis Brown, the first IVF baby, was born in the month of July in Bonehorn Clinic, Cambridge, USA, this technique has undergone a lot of modifications, a lot of development. And the two pioneers of this technique, Dr. Edward Robert Edwards and Dr. Patrick Steptoe, were actually praised a lot. And in fact, Dr. Robert Edwards received the Nobel Prize in Physiology and Medicine for starting in vitro fertilization in the year 2010. But if you see this timeline, you will be able to appreciate that the effort for in vitro fertilization has been going on for almost 100 years before this art could be perfected enough to have a test tube baby. Now, let us see, when do we actually need ART? We need ART in cases of severe oligoasthenoteratozoospermia or azoospermia in the female, or if there is severe tubal factor infertility leading to bilateral tubal blockade in the females, or if there is anovulation, which is very frequently seen in a lot of disorders, premature ovarian failures, or in conditions at time like severe endometriosis or premature ovarian failure. Then it is also needed in cases of unexplained infertility which are not responding to other treatments, in cases which need pre-implantation genetic diagnosis because of some genetic problem in one of the partners, or it is needed in cases of fertility preservation in cancer patients. We frequently get to see young cancer patients who are about to undertake radiotherapy and chemotherapy. So these are the patients who need to freeze their oocytes or freeze their embryos for later implantation. And then nowadays, the social reason is also a very important indication for ART, especially if there are women who are working and who have postponed marriage and childbearing beyond 40 years, and they are worried that they may run out of oocytes. Now, if we look at the types of ART, that is assisted reproductive technologies, we can see that there is a nice long list of these assisted reproductive techniques like in vitro fertilization, ICSI, GIFT, ZIFT, PROST, FET, third-party ART. The list is very long. So I would be taking each of these assisted reproductive techniques one by one. In vitro fertilization, as we all know, is the commonest and the most successful type of assisted reproductive technology. This allows the fertilization to occur outside the body in a glass dish, hence the use of the Latin words in vitro, which actually means in glass. The success rate of in vitro fertilization is around 15 to 35% per cycle, depending upon lot many factors like the age of the female partner, the indication for which in vitro fertilization is being done, the ovarian reserve of the patient, and so on and so forth. Now, how is this ART different or IVF different from natural conception? We all know that in natural conception, the ovaries produce ova, which is then extruded from the ovary at the time of ovulation. And then this ova is picked up by the fimbrial end of the tube, and in the tube, it undergoes fertilization by the sperms. And finally, the zygote and the embryo moves down and is ultimately implanted in the endometrium in the blastocyst stage. Now, in vitro fertilization, what happens? The ovaries produce the ova, and these ova are pulled out, extracted or aspirated by ultrasound guidance, and then this ova is then mixed with the sperm in the petri dish so that the early embryonal development can occur. And this early embryo at around 6 to 8 cell stage or at the stage of blastocyst is then implanted in the uterine cavity. Now, we would very quickly walk through the various steps in IVF. First and foremost, the female partner is subjected to ovarian stimulation and follicular monitoring. For ovarian stimulation, she is given supraphysiologic doses of FSH and HMG, which includes both FSH and LH. And her intrinsic hormones are quietened by giving her GnRH analogs, the agonist or the antagonist. And then by ultrasound, she is monitored to follow the size of the follicles. And once the follicles grow to around 18 to 20 millimeters in size, she is given injection HCG or GnRH agonist or recombinant LH to bring about an artificial LH surge. And within 36 and around 36 hours after this LH surge, oocyte retrieval is planned. This oocyte retrieval or ovum pickup is done in the operation theater under anesthesia and under ultrasound guidance. Using a transvaginal probe in the vagina, the ovaries are visualized and a needle is used to puncture these follicles and aspirate the follicular fluid in a test tube which contains the collection media. And then if you can look here, it looks something like this. The follicular fluid is then poured in a petri dish and examined under a high-powered microscope. And here, as you can see, these poached egg things, these are the oocytes. These oocytes are then cleared of the surrounding corona radiata cell. And this is how the mature ovum looks like. Now, this mature ovum is then put in the petri dish, in the fertilization media, along with the sperms, and it is then incubated under controlled conditions so that fertilization occurs. As you can see here, once one sperm enters the oocyte, there are 2 pronuclei, and finally they fuse to form the zygote, which then multiplies and then divides to form a 2-cell embryo, a 4-cell embryo, an 8-cell embryo, 16-cell, then finally a morula and a blastocyst. And finally, this blastocyst, the zona pellucida breaks, the blastocyst hatches, and it is ready for implantation. If you look at the timeline, you can see that on the 3rd day, the embryo is 6 to 8 cell stage when it can be implanted. But sometimes people also go for late implantations in cases which is called the blastocyst implantation, because here there is a greater chance of pregnancy. Now, how is embryo transfer done? This embryo is transferred aseptically in the uterine cavity using special catheters under ultrasound guidance. After embryo transfer, the woman is given appropriate luteal phase support. She needs this luteal phase support in the form of progesterone, in the form of estrogen, because as you can see here, the length of the luteal phase is extremely shortened if a woman receives GnRH agonist or antagonist. So to ensure that the luteal phase is proper, the endometrium is ready to receive implantation of the embryo, she is given luteal phase support. Another very important reason for giving this luteal phase support is that the progesterone hormone leads to maternal immune tolerance of the semi-allogenic fetal tissue. Otherwise, there are chances that it may be rejected also. So that is how an IVF occurs, and that this embryo after implantation then grows in the uterine cavity like any other normal pregnancy. Now there is another entity called FET, or frozen embryo transfer. Please remember that this is nothing special. It is the same as that of IVF, except that the embryos prepared by IVF may be cryopreserved for future use. And these embryos, which are currently at 37 degrees centigrade, are then frozen in liquid nitrogen at minus 196 degrees centigrade and stored. And when there is the need for pregnancy, then these embryos are thawed using a thawing medium and then put into the uterine cavity. The embryo is transferred into the uterine cavity for implantation. This is a very common procedure, very safe, and the pregnancy rates are comparable to fresh embryo transfer. Now the next, there is another technique which is very popular, which is assisted hatching. This assisted hatching is also an add-on technique to in vitro fertilization. We all know that the zona pellucida has to break and the blastocyst has to hatch out of it so that it can come in contact with the endometrium. Apposition can occur, adhesion to the uterine pinopods can occur, and finally the trophoblastic cell can burrow into the endometrium for successful implantation. So this assisted hatching may be done by mechanical methods or chemical methods or laser method, using laser. Nowadays, this laser assisted hatching is very, very popular, and it can be used to assist in conception and improve conception rates. Now, the next technique, the second very common assisted reproduction technique, is intracytoplasmic sperm injection, or ICSI. This is the very preferred ART procedure in cases of severe male infertility, when either the husband is suffering from obstructive or non-obstructive azoospermia, or he is suffering from severe oligospermia, teratospermia, or asthenospermia. In this case, following ovum pickup, a single mature healthy sperm is injected into the cytoplasm of the mature metaphase 2 oocyte to fertilize it, and the embryo so far formed is then transferred to the uterus for implantation. As it is an add-on procedure to IVF, hence it's more expensive. But the major advantage of this procedure is that it can be used in cases of both obstructive as well as non-obstructive azoospermia also. In cases of obstructive azoospermia, the sperms can be aspirated from the epididymis by means of PISA or MESA. And in case of non-obstructive azoospermia, these sperms can be taken out directly from the testes or following TZ, where a piece of the testicular tissue is taken. And this is how the sperms are collected. And finally, these sperms are used for doing intracytoplasmic sperm injection and enabling conception. The third technique for assisted reproduction is intrafallopian transfer. In this, the ova are aspirated from the ovary, and then both the ova and the sperm are directly delivered laparoscopically into the fallopian tube, the procedure which is commonly known as gamete intrafallopian transfer or GIFT. Sometimes these gametes are first fertilized in the petri dish in the lab, and then the zygote is transferred when it is known as ZIFT, or at times in the pronuclear stage only the transfer is done where it is known as PROST. Now, this technique carries a lot of risk. It has the risk of IVF along with complications related to laparoscopy also, and there is no definite advantage. So nowadays it is rarely used except for religious reasons in some countries. And finally, there is third-party ART or surrogacy, which has become very, very popular thanks to our Bollywood. And we all know how Shah Rukh Khan had a baby through surrogacy, and how Tushar Kapoor had a baby without getting married and without anything. So that is all thanks to third-party ART. Now, this third-party assisted reproduction is used in cases where there is difficulty in producing eggs or sperms, or there is difficulty in carrying the pregnancy to terms. So what happens if there is difficulty in producing eggs and sperms? Suppose the female partner is not able to produce eggs, she can take eggs from the donor, use her husband's sperm to fertilize it, and then get it transferred to her uterus. Similarly, if the male partner is infertile, he can get semen from the semen bank, use it to fertilize his wife's ova, and then get the embryo transferred to the wife. Then it also includes surrogate and gestational carriers in cases where the female partner is not able to continue pregnancy. Here what is done? The egg is taken from the wife, the sperm is taken from the husband, or one of them can get a donor also, and then the embryo so formed is transferred to the uterus of the surrogate who carries the pregnancy to term. And then after delivery, the child goes to the biological parents. Okay, so these are all very tricky and legal issues which have been twisted times and again. Okay, now since it's such a technical and advanced technique, obviously it has not many complications. There are complications related to ovulation induction. There are complications related to egg retrieval, especially anesthetic complications, injury, bleeding, etc. And there are complications related to the IVF procedure per se. But the four most important complications are ovarian hyperstimulation, which can be life-threatening also if it is severe, multiple births, which can pose a lot of problem. It can affect the fetal growth adversely. It can lead to preterm deliveries. It can lead to, there can be miscarriage. There can be ectopic pregnancy. Besides, there are many ethical issues also involved in ART, like pregnancy in elderly women. How elderly should be the mother when you do ART? Because the mother has to live also to raise that child. Then similarly, there are issues related to sale of gametes and embryos, issues related to coercion of women into surrogacy, forcing them into surrogacy year after year by the family and by other people. Then ART conception for getting stem cells from the fetus. So these are a few very important ethical issues also. And then, as you must have read in the newspapers and magazines, like ours, where the protocols have not been followed very stringently till now, and a lot of unethical practices have crept into this assisted reproduction, especially with surrogacy and all. So the government has recently come up with two very important acts in December 2021, the Assisted Reproductive Technology Regulation Act and the Surrogacy Regulation Act. And these acts have been put into force from the 25th January 2022. That is just 2 days back. It has come into force, and we are very hopeful that it may help in regulating ethical ART in India.
So that was very briefly about an overview of assisted reproduction. My take-home message to the audience is ART is actually a very dynamic field undergoing remarkable progress. And with each passing day, there is a new development that comes up in this field. Unfortunately, poor success rates and enormous cost add to the limitations of this technical and difficult procedure. Moreover, in an overpopulous country like ours, which is at the verge of population explosion, addressing infertility itself is a very controversial issue. And there is always a dilemma over establishment of ART centers in the public sector, and hence that limits its use by the poor. That is all for today. Thank you very much for your patient hearing. And please let me know if there are any questions that I have to answer. Any questions? You can raise your hand if there are any questions. Or you can write the message in the chat box. I think there are no questions, so we can wind up this session and we can proceed on with the rest of the workshop. Thank you very much.
How long the embryo can be preserved?
Somebody has asked me in the somebody has written in the chat box, how long can the embryos be preserved? The embryos can be preserved for years. There are studies which have shown that embryos can be thawed and used even after 15-20 years also. We have started this embryo freezing from the year 1995, and it can be frozen for years if you do not disturb it.
Dear chairpersons, please, if you have any query, please ask our speaker, Professor Amita Pandey.
There is a question, what is the maximum age of the female and male for all these procedures? As I told you, there is a lot of gray area in this. As per the new ART Act that has come up just 2 days back, a donor cannot be, a male donor cannot be more than 55 years. So the age of the male donor has to be between 23 and 55 years. The age of the female donor should be between 25 to 35 years. The age of the female recipient cannot be beyond 50 years, and the age of the male recipient cannot be more than 55 years.
Good morning, and thank you, ma'am, Dr. Amita, for enlightening us and giving us an overview on ART. It was a really wonderful talk where I think you covered all aspects of artificial reproductive techniques. And I have one question, is that fallopian transfer technique, which you said, that is actually not very successful.
Yes, it is abandoned now. That is what I said.
Yes,
that it is not being followed because it has a lot of complications, both of ART as well as laparoscopy, and it has almost been abandoned except in few religious sects in Europe where it is still being followed.
All right, ma'am. Thank you. And you already actually answered my query on cryopreservation, which I had one more query, that at what age and what are the indications for cryopreservations? Couples want to do it?
Yes, say for example, there is a lady who wants to postpone her childbearing beyond 45 years. So she wants to take out her oocytes and get it fertilized or preserve her oocytes. So that is one indication for cryopreservation. Sometimes some couples feel that when they go for IVF, around 10 embryos are formed. So all 10 cannot be implanted in the same go. At the most 3 can be implanted, so the rest can be cryopreserved for later use. Or for example, there is a young cancer patient who is undergoing chemotherapy and radiotherapy. So this cancer patient can go for cryopreservation of her gametes.
Right. Thank you. Thank you so much for giving such an enlightening talk.
Okay, ma'am Amita.
Yes.
I have a question, ma'am.
Yes, yes.
Can you enlighten us with the other techniques of ovum pickup?
The
Ovum
ovum
retrieval.
pickup, oocyte retrieval is nowadays done under anesthesia in the OT under ultrasound guidance transvaginally. But suppose it is not possible, if the ovaries are adhered high up, we are not able to reach the ovaries from below, then it may also be done laparoscopically.
Thank you, ma'am. Another question, ma'am. In IVF, if there is any stress in the oocyte or sperm or in the zygote or embryo, how will you identify and how to manage?
That is why it is said there is no way in which stress can be identified in the oocyte and sperm and embryo. That can be usually identified by assessment of reactive oxygen species, but that necessitates a lot of centrifugation. So it is said that there should be minimum handling of the gametes and minimum fluctuation of temperature, pH, carbon dioxide, oxygen saturation in the environment.
Okay, thank you so much, ma'am. Thank you. Everything is clear. Thank you, ma'am.
Thank you, ma'am, for a wonderful session.
Thank you and have a very nice day.
Thank you.
A very enlightening session by Professor Amita Pandey, ma'am. We got a lot to know about the assisted reproduction. And thank you all the chairpersons for this session also, Dr. Sabita Mishra, ma'am, Dr. Aribam Jayashree Devi, ma'am, and Dr. Mrudula, ma'am. Thank you so much. So hereby, we present the certificates of appreciation to our persons. First, the speaker, Dr. Amita Pandey, ma'am, for delivering the guest lecture entitled Introduction to Assisted Reproduction in this pre-conference workshop. Then we present the certificate of appreciation to Dr. Sabita Mishra, ma'am. Ma'am, are you online? Okay. For chairing a session in this pre-conference workshop here today. Next, we give the certificate of appreciation to Dr. Aribam Jayashree Devi, ma'am, for chairing a session in this pre-conference workshop. Thank you, ma'am, for your presence. And we give a certificate of appreciation to Dr. Mrudula, ma'am, for again chairing this session in this pre-conference workshop. Thank you, ma'am, for your valuable time. And we give a certificate of appreciation to Dr. Rashmi Malhotra, ma'am, for moderating a session in this pre-conference workshop. Thank you all. Let's begin with the next session in the series. So let me welcome Dr. Vivek Mishra, sir, who will be the moderator for this session now. He is an additional professor at AIIMS Gorakhpur. He is a member board of studies in the subject expert or examiner in the National Board of Examination, NBE New Delhi, AIIMS Rishikesh, AIIMS Jodhpur, KGMU Lucknow as well, DDU University Gorakhpur, Dr. B.R. Ambedkar University Agra, BRD Medical College Gorakhpur. Sir, can you please turn on your video?
Thanks. Am I audible?
Yes, sir, you are audible. Your video is not visible, sir.
Okay, just a minute.
Yes, sir.
Yes.
Yes, definitely, sir. Welcome, sir. Good morning.
Morning. So good morning, organizing committee members, our speakers, chairpersons, and delegate participants. So on behalf of organizing committee of 68th NatCon of Anatomical Society of India, I welcome our speakers, chairpersons, and delegate participants in the pre-conference workshop on overview of in vitro fertilization with the focus on male infertility. And this session is all about the structure and the function and the physiology of human sperm. Our speaker is Dr. Jyoti Chopra ma'am, and this session will be chaired by our chairperson, Dr. Ajay Kumar Srivastava sir. He is former professor and head of the department in the Department of Anatomy at KGMU, Lucknow. He is founder fellow of the Anatomical Society of India and later became the president of Anatomical Society of India. He has teaching and research experience of 37 years. He has many publications, around 20 publications in the national journals and 14 in the international journals. He has attended many conferences, 4 international conferences and 22 national conferences. Good morning, sir.
Good morning.
Thank you, sir. Next chairperson is Dr. Renu Chauhan ma'am. She is director, professor, and the head of the department in the Department of Anatomy at University College of Medical Sciences and GTB Hospital, Delhi. She is also the head of the department in the Department of Anatomy at Faculty of Medical Sciences at the University of Delhi. She is reviewer of Journal of Anatomical Society of India and Journal of Clinical and Diagnostic Research. She is also the member of Advisory Board of National Journal of Clinical Anatomist. She has many articles published in the index journals, like 22 articles published in the national journals and 20 in the international journals. She has authored many books, like 6 books in her name and 1 book chapter. Yes, she has achieved many awards like Pyarelal Bishan Devi Gold Medal for the best thesis in the pre and paraclinical subjects at the MAMC New Delhi. She has achieved Ranga Travel Grant for the best paper at the NetCon, Jai Hind Humanity Award, Distinguished Doctors Award by the Indian Medical Association, National President's Appreciation Award by IMA, Chikitsa Ratan Award by Delhi Medical Association, Best Teachers Award by the Physicians Forum of the India. She is member of many scientific bodies like ASI, DESMOS, Delhi Medical Association, Indian Medical Association, SOCA, and Physicians Forum of the India. Good morning, ma'am.
Good morning. Good morning.
Yeah, thank you, ma'am. Now, our next chairperson is Dr. Sharad P. Sawant, sir. He is professor and the head at the KJ Somaiya Medical College, Mumbai. He is member of editorial board of 16 international journals. He has many publications, like 223 publications in the national and international journals. He has achieved many prestigious awards. He designed several innovative methods for the teaching and assessment. Good morning, sir.
Sir, online. Sir, online.
Seven, sir. Good morning, sir.
Dr. SP Sawant, sir. Sir, if you are online, sir, can you please unmute yourself? Your video is also not visible, sir. Okay, no problem.
Okay.
Sir, Dr. Vivek, sir, we request you to please introduce our guest, sir, Renu ma'am.
I request Dr. Renu Chauhan ma'am to please introduce our speakers of the session.
Yeah, thank you, Dr. Vivek, for introducing me. It is my honor and privilege to introduce Dr. Jyoti Chopra for this session, who is going to speak on the structure and physiology of sperms. Ma'am is, she needs basically no introduction. She is such a renowned figure. She's a professor of anatomy at KGMU, Lucknow. And she has done her graduation and post-graduation from Kanpur, GSVM Medical College. She has a vast teaching experience of 21 years. Her area of interest are medical education, radiological and clinical anatomy. She has she's a member of medical education, KGMU Lucknow, and she is a member of curriculum committee and associate dean, and she is ethical committee member and also faculty in charge of cadaveric skill labs, KGMU Lucknow. She has edited osteology and gross and cross-sectional anatomy, practical drawing books for MBBS and BDS students. She has prepared a histology manual for MBBS students. She also has edited Grants Dissector South Indian edition, and she has published around 58 papers. She has also conducted cadaveric workshop in collaboration with anesthesiology, orthopedics, ENT, and neurology. She has conducted workshop on integrated medical curriculum, micro teaching, attitude, and communication skills of medical teachers. She has conducted CME on contemporary and evolving perspectives in anatomy learning in IVECON 2021. I welcome ma'am to speak on structure and physiology of sperms. Over to you, ma'am.
Thank you so much, ma'am.
I'll be just sharing ma'am's screen. Just 1 minute.
I request my participants to please write any questions in the chat box. All participants, if you have any question, please write in the chat box during the session. It will be discussed at the end of the session. Thank you.
I am muted myself.
Good morning, everyone. At the outset, I would like to thank the organizing secretary of the workshop, Dr. R.K. Verma, for giving me this opportunity to speak in front of this August gathering. And I will be briefly touching upon about the structure and physiology of normal human sperm. So I'll be beginning my talk very shortly once we are prepared with the slides.
Just sharing the screen, ma'am, now.
Okay, thank you. Thank you.
Screen is visible now?
Yes, screen is visible. So thank you so much. Now I will be talking about the structure and physiology of mature human sperm. As you all know that the exclusive function of the spermatozoa is to transmit the genetic information to the oocyte. And to perform this function, the sperm cell is highly differentiated. The paternal genome is condensed in the head region, and there is a long tail which helps in carrying this genetic material through the male and female reproductive tract. So if you look upon the structure of the human sperm, there is a head with a dimension of about 3 to 5 micron and a long tail of 50 to 55 micron length, out of which it has got several parts, the connecting piece or neck, then there is a mid piece, then there is a principal piece which forms around 2/3 of the entire length of the tail, and finally there is an end piece. This whole structure is bounded by a single continuous plasma membrane. So coming to the head, the dimensions are about 5 by 3 by 1.5 micron with a smooth outline, and it has got a pear shape with a core of the head which is formed by dense sperm nucleus, which is composed of highly condensed chromatin material. And this chromatin material is highly protected against the DNA damage. Because of this condensation, the chromatin becomes metabolically inactive, and this condensation provides mechanical and chemical stability to the chromatin. Once this chromatin material reaches the oocyte, it gets decondensed and acquires nucleosomal structure. As you all know, it carries haploid chromosome. Now, this chromosome or chromatin material is surrounded by a nuclear membrane, and there is a thickening in this nuclear envelope at the base, at the posterior end, which is termed as basal plate. Now, this basal plate forms implantation fossa for the capitulum of the connecting piece. This is the point where tail is attached to the head. Now, this nuclear membrane is very special, is having a very special characteristic that it lacks the nuclear pores. And actually, these nuclear pores are not needed here because the chromatin is tightly packed and inactive, and the absence of these nuclear pores confers protection to the nuclear chromatin against the hydrolytic enzymes which are released during the acrosomal reaction. Now, if this chromatin material is not completely condensed, then the condition is termed as immature chromatin will be present. And if immature chromatin is present, it can cause arrest of the embryo development. Or if there is distorted chromatin over here, then it can lead to post-fertilization defect and even cause failure of ART and early pregnancy loss. Then within this head region, we can also see small clear spaces which are not membrane bound, and they are termed as vacuoles, or on the surface we can see depressions, and these depressions on the surface of the sperm head are termed as craters, and these craters are created actually by the protrusion of the circulatory cells. They are normally also present, but if they are present in more number, that is considered as abnormal feature. Then this anterior 40 to 70% region of the entire head is covered by a cap-like structure, which is Golgi-derived structure termed as acrosome. And this acrosome is having an outer membrane and inner membrane, the central matrix. Outside, this whole structure will be covered by the plasma membrane, as I have told before also. Then there is a potential space between the inner membrane and the nuclear membrane, which is termed as subacrosomal space or perinuclear theca. Then at the posterior side of this acrosomal region, there is an equatorial segment. And this equatorial segment is very important because it is the point where the fusion between the sperm and the oolemma is initiated. So during the acrosomal reaction, when the sperm comes in contact with the zona pellucida, only the anterior part, anterior cap-like portion of this acrosome undergoes acrosome reaction, and this equatorial region is preserved from it, and it does not participate also. And if this equatorial region is not intact, then the fertilization cannot be achieved. In the posterior 35 to 40% region of the sperm head, there is post-acrosomal sheath, and this post-acrosomal sheath contains a special protein which enters during the fertilization into the oocyte, and it activates the oocyte and pronucleus formation. And the posterior end of this posterior post-acrosomal sheath is termed as posterior ring, which marks the junction between the head as well and the tail. Now we have already seen the different parts of the tail. The thing is that starting from the connecting piece, there is a central axoneme, and this central axoneme runs along the entire length of the tail. Right, the structure of the tail, central axoneme is common, and it is running through the entire length of the tail. The thing which is differing is the periaxonemal sheath, which is different in the region of mid-piece from the principal piece and from the end piece. Okay, we will discussing it one by one. First, coming to the neck, that is the connecting piece region, which harbors proximal and distal centriole. The proximal centriole is enclosed in this electron-dense capitulum and is present at perpendicular axis to the long axis of the tail. It preserves its 9+0 organization of this microtubule triplet, and it is surrounded by these striated columns. And these striated columns, when we'll trace it below into the tail, they become continuous with the outer dense fibers. The distal centriole. The distal centriole, it lies at perpendicular axis to the proximal centriole, and it aligns with the long axis of the tail. Now, the structure of the distal centriole is greatly modified in human beings, and it was described by the Fisher Man et al. In 2018 that this distal centriole is made up of splayed microtubules, which provide it a novel and atypical structure. And because of this splayed display of the microtubules, probably this distal centriole was not visible earlier and was considered to be absent from the connecting piece region. Now, these centrioles, they help in organizing the cleavage spindle during the first cleavage division of the fertilized egg. They induce the formation of the implantation fossa, and they give origin to the tail axoneme. Distal centriole, it provides origin to the tail axoneme. So if anything goes wrong in the organization of the cleavage, anything goes wrong with the induction of the implantation fossa or the origin of the tail axoneme, then we will have the decapitated sperm. This is the these are the decapitated sperms, where you will find tails only with a connecting piece which is giving a dilated appearance. Now we have seen that the structure of the central axoneme is common. And now what is the structure of the central axoneme? It has got 9+2 arrangement. In the center, we have 2 microtubules, and at the periphery, we have got 9 doublets of the microtubule, out of which one is complete and another is C-shaped, and to the complete microtubule, the outer and the inner Dynon arms are attached. And these Dynon arms, they permit the microtubules to slide against each other. And this permits the bending of the flagella. And when there is alternate bending of the flagella, the beating motion of the sperm takes place. Now there are radial spokes, and these radial spokes, they control the motion of the axoneme. Now, as I've told that the axonemal structure is common in entire tail, the thing that is varying is the periaxonemal structure. So in the region of mid-piece, this central axoneme, this transverse section shows, this is the central axoneme, and it is surrounded by outer dense fibers, which are 9 in number. That is why we say that mid-piece has got 9 + 9 + 2 arrangement. And these outer dense fibers, they are surrounded by mitochondrial sheath, which is arranged in a form of helix around the outer dense fibers. Then the junction between the mid-piece and the principal piece is marked by this constricted area, which is termed as annulus, and it is acting like a transitional zone between the mid-piece, between the upper cytoplasmic area and distal membrane boundary area of the tail. It is acting as a barrier which prevents the molecular diffusion between the two pieces. Then coming to the principal piece is again having 9+9+2 arrangement, and the outer dense fibers, these outer dense fibers here, they gradually taper off as we proceed through the length of the principal piece. In this diagram, you can see that the outer dense fibers are gradually tapering off. These outer dense fibers are responsible for providing support and elasticity to the tail. Then coming to the end piece, where there is no periexonemal structure and the central exoneme is only surrounded by the plasma membrane. So it has got 9+2 arrangement. Now, the mitochondrial sheath, which is present in the region of mid-piece, it provides actually main source for the energy for the movement of the dynamotor arms. There are researchers which have shown that the glycolysis is the main source of energy for the tail movement, and that part is controversial. But any ultrastructural defect in mitochondria can cause lowering in the sperm motility. In the principal piece, we have seen that fibrous sheath was enclosing the central exonemal structure, and this fibrous sheath, it influences the plane of the beating of the tail and the flexibility of the tail. Hence, the flagellar wave is governed by the fibrous sheath. So we have seen that the motility of the sperm is basically caused by the movement of the tail, right? And this movement of the tail is rapid and highly synchronized. So when it was first seen in 2D microscope, these tails, they appear to have side-to-side symmetric movement. And Leeuwenhoek, when in 17th century saw these movements, he described it like eels in the water. The movement of the tail was described as eels in water. But later on, very recently in 2020, Gadela et al., they did a 3D microscope study of the sperm movement, and they revealed that these sperms, they do not swim, actually they spin. The head of the sperm, it spins, and the tail of the sperm, that rotates. So actually the movement is occurring like Earth and Mars are rotating in the orbit around the sun. So we all know that they rotate around the axis as well as they proceed in the orbit also. So similar type of movement occurs in the sperm also. That is why now we say that sperms, they rotate like in a corkscrew manner. And this movement is essential for effective penetration into the cervical movement. And if there is anything wrong in this type of movement, that will lead to sliding sperm pattern. So with this, I would like to, at this point, I would like to recapitulate what we have discussed till now. We have discussed the structure of the head. Then we have seen the parts of the tail, the central exonemal structure, and the different regions of the periexonemal structure of the different regions of the tail, and a word about the sperm motility. At this point, I would like to emphasize that the morphology of the sperm is not the only factor that is considered for male fertility. And getting this normally described sperm in the semen is not very common. It is important to know that all men, they produce abnormal sperm. And if we observe normal morphology in more than 4% of the sperm population in a semen sample, then also it is considered as normozoospermia. Only if the normal morphology is observed in less than 4% of the sperms, then the condition is termed as teratozoospermia, which can include the defects in the tail, defects in the head, or in the neck. And if this sperm count is less than 15 million in per ml of the semen, then it is termed as oligozoospermia. And if the motility of the sperm is reduced by 42%, then it is termed as asthenozoospermia, which can be due to any structural alteration in the tail element that we have discussed right now. So there is, I wanted to emphasize upon one important syndrome, which is termed as Carter-Jenner syndrome, because in this Carter-Jenner syndrome, there is total absence of these dynein arms. And because of the total absence of the dynein arms, it causes primary ciliary dyskinesia that leads to complete loss of the sperm motility. So in the Carter-Jenner syndrome, we find complete asthenozoospermia. So I will like to enter my talk here. Dr. Mona Sharma, Dr. Rajendra Singh, and Dr. Praveen Pandey will elaborate further upon the clinical aspects. So these are my references, and thank you for your patient listening. And now, if you want to ask any question, I will be glad to answer up to my capability.
Thanks, ma'am.
Thank you,
Now
Dr.
request our chairpersons to ask any questions, if any.
I think we should unmute the chairpersons. Dr. Renu Chauhan and Dr. Rakesh Srivastava. We have to unmute them. So you must have received the unmute request.
Hello.
Hello.
Jyoti, very nice presentation.
Thank you, sir.
But I would like to add that you should have told about the dimensions of the head and the tail piece.
Sir, I have mentioned that.
No, not about the tail, and I think.
Sir, it was 50 to 55 micron in size.
Yeah, no, it is 45 usually, but it would have been better if you had. But since you are telling that you are told, so I might have missed that. Well, what about the morphology, different types of morphology of, are you going to enlighten us about the morphology, that what are the deformities?
That will be covered in the next lecture. That is why I haven't touched upon that point.
Okay, right. Very nice presentation. Good.
Thank you, sir.
Any questions?
Dr. Jyoti, it was a wonderful presentation. I congratulate you for presenting it so well, confidently. And you have left no questions to be asked.
Thank you
very much.
Thank you so much. Thank you so much, ma'am. So if there are no questions, then I would like to.
From Dr. Ashok Sahai, sir. Do sperm mitochondria enter secondary oocyte during fertilization?
Yes, sir, it does. It enters the mitochondria. It enters into the secondary oocyte, but after some time it gets destroyed over there, and usually it is seen up to 2 or 3, 4 to 8 cell stage into the oocyte, but after that it gets destroyed. There are studies which have shown this.
Thank you, ma'am.
So I would like to invite, call Dr. Nikhil to carry out the further proceedings. Thank you.
Dr. Vivek, please conclude the session.
Yeah, so I thank Dr. Jyoti Chopra ma'am for such an informative and educative session. Especially ma'am has mentioned the structures and sperm motility and the factors responsible for the male infertility. So it will add to our existing knowledge. So thanks, ma'am. And thanks our chairpersons for conducting this session smoothly. And thanks our delegates for participating. Thank you, ma'am. Thanks, ma'am.
Thank you, sir. So for this session, I would like to present the certificate of appreciation to Professor Jyoti Chopra ma'am for delivering this guest lecture entitled Structure and Physiology of Sperm in this pre-conference workshop held today. Thank you, ma'am. I would also like to present a certificate of appreciation to Professor A.K. Srivastava sir for chairing this session, this pre-conference workshop. Thank you, sir.
Thank you. You're welcome.
I would also like to present the certificate of appreciation to Professor Renu Chauhan ma'am for chairing this session in this pre-conference workshop held today. Thank you, ma'am.
Thank you.
And I would like to present the certificate of appreciation to Dr. Vivek Sharma sir for Vivek Mishra sir for moderating this session. Thank you so much, sir, for a very well moderated session, sir.
Thanks a lot. Thanks a lot.
So, moving forwards to the next session, I would like to welcome Dr. Chandani Gupta ma'am, who is currently the additional professor at Kasturba Medical College, Manipal Academy of Higher Education. She is the coordinator of Center for Clinical Anthropometry, KMC Manipal. Conference attended in the national international being 28, the workshop and CMEs attended being 69, various publications in national and international index journals. She is also a life member of Anatomical Society of India and a life member of Karnataka chapter of Anatomist. Ma'am, welcome.
Thank you, Dr. Nikhil. And I thank all the organizers for giving me this opportunity. So we have a session next on semen analysis and the WHO 2021 and sperm function test by Dr. Mona Sharma. She is an additional professor from AIIMS Reproductive Biology, New Delhi. And this session will be chaired by three professors like Dr. Sundarlal Jithani. He has done his MBBS and MS from GR Medical College, Gwalior. He is currently a professor of Department of Anatomy at Himalayan Institute of Medical Sciences. He is also the Chief Medical Superintendent at Himalayan Hospital, Dolly Grand, Dehradun. He has a teaching experience of 37 years. He has been a president of Anatomical Society of India in 2002, and he is the president of North State Chapter of Anatomical Society. He is also an external expert for faculty selection in anatomy for Government Medical College of Madhya Pradesh, Gujarat, and AIIMS. Welcome you, sir. Sundarlal, sir?
Sir is not here. I think sir is not here with us.
Okay, then we will move on to next chairperson.
Chairperson, yes.
Okay, so the next chairperson is Dr. Vinay Kumar Veerana Shetty. He has MBBS, MD, PG, CD, PGD, BEME. He is currently a professor of anatomy at AJ Institute of Medical Science, Mangalore. He has given a lot of guest lectures. Like one of the guest lectures is Life in a Petri Dish at National CME Kodagu Institute of Medical Science, Madikeri. And he has given a guest lecture at Anatomy and Physiology of Voice Production at Nifty Institute of Speech and Hearing. He has given a guest lecture in CME on Anatomy of Eye, on luminary class plastination at Adi Chinchangiri Institute of Medical Science, Vellore. So I welcome Dr. Vinay Kumar.
Thank
Vinay,
you.
sir?
Thank you, Dr. Chandani and all the organizers for this session.
Okay, the next chairperson is Dr. Shubhalakshmi Vahangabam. He is a professor of anatomy at Jawaharlal Nehru Institute of Medical Science, Imphal. She is a MBBS, MS, RIMS, Imphal. She's from, and she is undergoing currently DBT 6 months fellowship in genetic diagnostic pediatric department, AIIMS, New Delhi. She is a life member of ASI, SOCA, IMA, GIMS Academy Society. He has been awarded with Dr. Matilal Penn Memorial Gold Medal for the best research paper on embryology by Journal of Anatomical Society of India. He has currently about 10 international publications, 6 national journals publication, and 1 state journal publication. He has presented papers and chairs various sessions in various conferences. Welcome, Dr. Subbalakshmi, ma'am.
Thank you, ma'am, and very good morning to everyone.
Okay, now I request Dr. Vinay Kumar Veerana Shetty to kindly introduce Dr. Mona Sharma.
Thank you, Dr. Chandani. It is my great pleasure to introduce Dr. Mona Sharma. She is presently working as additional professor, Department of Reproductive Biology at All India Institute of Medical Sciences, New Delhi. She did her graduation from KMC, Mangalore, Karnataka, and also PG in anatomy from All India Institute of Medical Sciences, New Delhi. She has experience of more than 15 years in the area of andrology lab services. Her area of interest and research is on premature ovarian failure, polycystic ovarian syndrome, sperm and oocyte contributing factors in fertilization and sperm cryopreservation. She has authored numerous research publications and has co-edited a textbook on andrology as well. I welcome Dr. Mona Sharma for this session. Thank you. Over to you, Madam Mona Sharma, ma'am.
Thank you very much, Dr. Vinay, for kind words. Very good morning to all the organizers of 68th NatCon of ASI, Dr. Punita and Dr. Rakesh, respected chairpersons, fellow speakers, and dear delegates. I congratulate you all for organizing the scientific gathering, especially at this time of difficult pandemic. It's quite motivating, to keep us moving forward. I thank organizers for inviting me to be part of this great endeavor, and very special thanks to Sarabpreet for making me part of this team. I'm going to share my screen.
Okay, ma'am, I am just closing my screen. Then you can share. Ma'am, please proceed to share the screen.
Yeah, visible.
It's visible, ma'am. Yes.
Is it okay?
Yes, ma'am. Perfectly fine. There is a small banner in the center. I hope it is not a problem. Just, ma'am, can you just play the next slide for 1 second?
Yes.
Okay, ma'am, just go ahead. You can start with your presentation. Yes, ma'am.
All right. Because of high muscular strength and apparent physique, man gives an impression of robustness. Therefore, male reproductive health has been a neglected area for physicians. But it's time to realize that male reproductive health equally needs care. With the increase in longevity, reproductive and sexual health needs more attention than ever before. This very small phrase actually depicts the importance of today's workshop, because WHO has already recognized infertility as a global health problem, where males account for around 40 to 50% of the infertile cases, caused commonly due to deficiencies in the semen, and therefore the semen quality is used as a marker of male fertility. Now, Andrology Lab provides routine semen analysis services as a baseline investigation to all the infertile couples that comes to us. There are a few sperm preparation techniques which are utilized during ART procedures like IVF and HC. And then we have a few sperm function tests which are mostly used for the research projects. Now, first of all, why do we perform semen analysis? Now, semen analysis most commonly is done for investigation for male infertility, to know the sperm production by the testes, to know the patency of the male ducts, the function of accessory sex glands, and the ejaculative function. It also helps in checking us the effectiveness of vasectomy, in selecting the donors for ART procedures, and knowing the cases of fertility preservation. So there is a need for lab manual, and WHO has been providing these lab manuals for standardization of procedures globally for the examination of human semen in research and clinical laboratories. Now, the first edition of this manual came in 1980, and the latest one has come in 2021. Now, a few basic facts about semen. Now, semen consists of the cellular components and the acellular components. The cellular components are the mature sperm, the epithelial cells of the urogenital tract, and few round cells like the WBCs and the immature germ cells. The acellular component is contributed maximally by the seminal vesicles, then prostate gland, the epididymis, and of course the testis. Now, in contrast to most other body secretions which are examined for the diagnostic purposes, the ejaculate is actually the mixture of secretions that does not exist within the body before being expelled. So the ejaculate is suspension of sperm, which is mixed with the prostatic fluid, in the urethra, and then followed by emptying of the secretions coming from the seminal vesicles happening during ejaculation. Therefore, the sequential ejaculate fractions are not equally composed. So there is a pre-ejaculate, which is mucinous, then followed by the initial fractions coming from the sperm-rich prostatic secretions, and lastly, the end fractions of the ejaculate, which are contributed by the seminal vesicles. Physiologically, the initial sperm-rich prostatic fractions, they do not come into contact with the rest of the ejaculate. But as compared, in contrast to in the laboratory setting, the entire ejaculate is collected in one container, where the prostatic secretions, they combine with the secretions coming from the seminal vesicles. So in vitro, all these secretions are going to form a coagulum, or we call this as a gel. Now, this picture actually shows the formation of the coagulum by the secretions from the prostate gland, mainly the zinc and the prostatic specific antigen, the sperm and the seminogelins, which are formed by the seminal vesicles. So all these three components actually form the coagulum in the ejaculate. But as soon as we keep the sample within the incubator at 37 degrees Celsius, what is going to happen is that the zinc ions get chelated, which are going to actually activate the prostatic specific antigen, and that is now going to break the seminogelins, thereby causing the liquefaction of the coagulum. Now, this liquefaction is actually the prerequisite for doing or proceeding for the semen analysis. Now, in routine semen analysis, we actually provide all these parameters: the semen volume, the concentration, the total motility, the progressive motility, viability, and the morphology. As compared to the last edition that came in 2010, latest edition actually has made certain changes. Like in semen volume, the minimum, the lower reference limit is 1.4 ml. The concentration should be at least 16 million per ml to call it as a normal sample. The motility, the total motility should be 42%, progressive motility 30%. The number of, the percentage of the viable cells around 50%, and the morphology should be at least 4%. Based on these lower reference limits, we have a nomenclature that we actually use for semen analysis. We call the sample as a normozoospermia if all the parameters, the count, the motility, as well as morphology is normal. Oligozoospermia if the count is less, actinozoospermia if the motility is less, teratozoospermia if the morphology is less. And if there are more than one parameter which is abnormal, then we use combination of the terminologies. We call the sample as azoospermia if there is no sperm seen even after centrifugation. So if the no sperm seen, then it is azoospermia. But suppose if after centrifugation we find a few sperm, then we designate the sample as the cryptozoospermia. We call a necrozoospermia if along with the poor motility, there are the percentage of viable cells is very, very less. Aspermia if the no semen is produced, hemospermia if RBCs are present in the ejaculate, and leucospermia if the WBCs are more, that means more than 1 million per ml. So the concentration of WBC is more, then we call it as leucospermia. Now, what are the steps of semen analysis? As soon as the patient comes to us, we initially take the patient details, the general details, the age, the occupation, the marital status, etc. We give patient the instructions regarding collection of the sample. We give him a labeled container where his name and the lab ID is written. And there is a place, a designated place for semen collection in our lab. And we give instruction to the patient to collect the whole ejaculate. That's very important. And he is asked to report if there is any loss of the ejaculate. And lastly, we take the consent of the patient before proceeding for the semen analysis. Now, within first 5 minutes, as soon as we receive the sample, we keep the sample in incubator at 37 degrees Celsius to liquefy the sample. And then once the sample is liquefied, we further go for the microscopic examination, where we check for the liquefaction, appearance, viscosity, volume, and pH of the sample, followed by the microscopic examination where we make a wet preparation. This wet preparation is important for assessing the motility, sperm numbers, whether there is aggregation or agglutination present, and the presence of the other cells. We decide the dilution factor for counting the sperm numbers, and then we make the semen smears, which we are going to use for vitality and morphology staining. After 4 hours, or if once the semen smears are dried up, then we move for the staining. And the biochemical analysis for the other components of the accessory sex glands can be assessed later if they are required. Now, for the initial microscopic examination, we just look for the extent of liquefaction, whether the sample is liquefied completely or not. Most of the samples, they get liquefied within half an hour, and some may take another half an hour. So by 1 hour, all the samples are liquefied completely. We look at the appearance, the sample should be homogeneously grayish, whitish in color. We look for the viscosity. We check the viscosity of the sample by introducing a glass rod into the sample and observing the length of the thread that is formed upon withdrawal of the rod. So the viscosity should be recorded as abnormal if the thread is more than 2 centimeters. Then we check for the volume. The minimum should be 1.4 ml. The pH should be between 7.2 to 7.5. Now, we move to the microscopic examination, for which, as I said before, we have to make a wet preparation. Now, how do we make a wet preparation? We keep a drop of the sample on a slide, and then we cover it with a cover slip. Now, once the wet preparation is ready, we are going to see certain parameters under the wet preparation. We look for the sperm motility. We look for aggregation or agglutination. We look for the round cells. And we also decide the dilution factor for the sperm numbers. Now, how does the sperm is motile? I think Dr. Jyoti has explained it very nicely, that the sperm is motile because of these vents which are produced by the sliding of the dynein arms backwards and downwards, thereby producing a forward propulsive thrust. Now, sperm exhibits 3 patterns of motility. When it is there in the initial part of the epididymis, it shows basal motility, where it shows where it makes the slow and circular movements. Now, in the distal part of the epididymis and in the ejaculate, it produces this kind of motility that I explained, which is called the rapid progressive motility, which is forward. But within female reproductive tract, it produces hyperactivated motility, where the forward movement is less, but there is increased lateral displacement of the head. So these are the 3 basic patterns of the sperm motility. WHO has categorized the grading of motility in 4 types. In the last edition, the 5th edition, they categorized into progressive, non-progressive, and immotile. But this latest edition has subdivided progressive motility based upon the speed with which the sperm is moving. So if the sperm is moving, at least half the length of tail in 1 second, they call it as rapidly progressively moving sperm. If the sperm is making at least 1 head length to up to half of the tail length in 1 second, then it is slowly progressive. Non-progressive is when it is not moving forward, but it's making small circles, and the distance is up to 1 head length, then it is non-progressively motile sperm. And if there are no tail movements found, then it is called the immotile sperm. So the very important requirement is that we assess motility in 2 replicates. Now, when I say it is 2 replicates, that means we take 2 wet preparations separately, and we assess as ideally it should be by 2 independent observers. Now, the replicate, we count the number of sperms, at least 200 sperms should be counted in total in replicate 1 and replicate 2. And then we take the average of the findings, and then we find the difference, the acceptable difference between the average. Now, this acceptable difference of the average is very important just to rule out any human error if it happens between the 2 independent observers. So if, as per the percentage of the average which we get, we have acceptable difference. That means if the average comes out to be 15%, then the acceptable difference between the 2 replicates is maximum 7. So our difference should be up to 7, it should not go beyond 7. So if it becomes beyond 7, then we are going to discard the wet preparations and we are going to again make the wet preparations. Now, in the wet preparation, we also look for the aggregation and agglutination. Now, aggregation actually represents non-specific binding. If the immotile sperm is bound to immotile sperm, if the motile sperm is bound to the other kind of cells, round cells, whether the WBCs are there or the epithelial cells, But for us, it's very important is to understand if there is any agglutination present. That means if there is any attachment of the motile sperm to the motile sperm, if head-to-head attachment or head-to-tail attachment, then we have to report it as agglutination. Now, presence of agglutination actually, indicates presence of anti-sperm antibodies. Then we also look for the other kind of cells which are present in the wet preparation, the round cells, which can be the WBCs or they can be immature testicular cells. Now, in wet preparation, we have to decide how much dilute we are going to make the semen sample for counting the sperm properly under Neubauer's chamber. So depending upon the number of sperm that we are seeing in a particular field, if the sperm numbers are more than 100, then we are going to dilute it in 1:20 ratio. If it is less than between 16 or 15 to 100, then we are going to dilute it accordingly, according to this particular table. So we have a fixative for diluting the semen consisting of sodium bicarbonate and formalin for fixation. Now, once we have diluted the sample, we are going to do the sperm counting, and we use modified Neubauer chamber. Now, this modified Neubauer chamber has got two counting areas. If you just look at these two counting areas are going to be utilized for two replicates of the semen sample, two independent replicates. That means we are not going to take the diluted semen for one particular tube. We are going to make independent replicates. And both of these replicates are going to be poured over the slide. Now, this counting chamber actually looks like this. It is having 9 counting grids. So we start from counting from grid contains 25 squares, and we have to count from left to right, maybe from right to left, whatever way you want, and then we have to count the number of sperm till we are able to count at least 200 sperm. Now, how does each of this square look? This square looks like this. So each of the 25 squares are actually bounded by the triple lines, as you can see here. And we have to count complete sperm. The head with the tail. So the whole of the line of these triple line is considered to be the boundary of this particular square. So the sperm heads, which are present between the inner two lines, they are counted in this particular square. Now, what about if the head is present on the central line? So if the head is present on the central line, which is making this L, then we count the sperm in this particular square. Otherwise, the head which is present on this line or in this line, we're going to count them in the other squares. So we count till the 200 sperms are counted. Then we take the average of these, the count number of sperm, and we assess the difference as well. And after doing so, we have, so as per the average or the sum of the sperm count, we do have, we take the difference. And this is a list where we can see the acceptable difference. So if the average comes out to be 200, so our difference between the two replicates should be up to 28. Now, once the counting is okay as per this particular table, we go for calculating the sperm concentration as per this, this formula that we have derived. And once the sperm concentration is derived, we multiply it by the total volume of the ejaculate. And this actually gives us the total sperm count. So here comes the importance of knowing the total volume of the ejaculate. So if patient reports that there has been any loss of the sample, then we have to report it in the report, because that actually going to affect the total sperm count here. Now, next thing what we're going to do in microscopic examination is that we're going to make the smears. And how do we make the smear is by a process called feathering. Now, how do we make the smear? We put a drop over the edge, towards the edge of one slide, and then we, slide the other slide at an angle towards the drop. And once the slide touches the drop, we are going to drag it forward. So this is the way of making the smear to avoid, damage to the cells in the smear. Now, once the semen, the sample is the smear has been made, then we proceed for the staining. We do staining for knowing the number of viable cells, meaning how many live cells are there, and then to assess morphology in detail. So for vitality, we have eosin-nigrosin staining that actually depends upon the membrane integrity. So all the cells, the live cells, they have the intact membrane. So they will not be take up the stain. So the stain here, which is going to stain the cytoplasm, actually it's the eosin stain. And nigrosin is basically giving the background staining. So all the stained heads actually represent the dead cell, whereas the live cells, they remain unstained. Now this is the picture which shows the structural components of the sperm, and I think the previous speaker has already explained very nicely. Just to recapitulate, the sperm consists of head and the tail. Head has basic two important areas, the acrosomal area and the post-acrosomal area. So we have to see the defects in both in the acrosomal as well as in the post-acrosomal area. Whereas the tail consists of three parts, the mid piece, the principal piece, and the end piece. So it is mid piece and principal piece, which is seen more in the morphology. So sperm morphology is studied by pap staining, that we all are aware. The pap staining is mostly used for the cervical cells, the exfoliative cells. It is actually the multichromatic stain which differentiate the cells in the smear preparations to clearly distinguish the acidophilic and the basophilic components. So pap staining consists of the three important solutions, the methoxylin, orangey, and the eosinazole. This actually shows the principle of the pap staining, where we first fix the cells, then rehydrate them, stain with methoxylin, then remove the excess stain, the non-specific binding, and then we stain with the rest of the stains. So this is just the basic principle of using the different stains here. The steps of the pap staining has been shared in the manual, so I'm not going into the details of them. Now we do have a criteria based on which we actually categorize whether it is a normal sperm or the abnormal sperm. And that is given by the Kruger's criteria. So the head, the mid piece, and the principal piece, there should be the normal features. Even a single abnormality in the sperm, whether it is in the head or in the principal piece, we designate that sperm as the abnormal sperm. Now in the head, the shape of the head and the size of the head is very important. The acrosome should be covering 40 to 70% area of the head. Even less than 40% and more than 70%, it's considered abnormal. Up to 2 small vacuoles in the acrosomal area are normal, but there should not be any vacuole in the post-acrosomal area. Now, in the mid piece, what are the things that we see? Very importantly, it should be slender. There should not be any enlargement in the mid piece. There shouldn't be residuals, excess residual cytoplasm. Now, excess the cytoplasmic droplets can be there, which are less than 1/3 of the head size. But if the size increases, then we call this as excess residual cytoplasm, and that makes the sperm as abnormal. Now, principal piece should be as thinner than the mid piece, and there should not be any sharp bend in the principal piece. So all these are the criteria based on on which we categorize. So this is just to show the head defects and the neck and the tail defects. So any of the abnormality we consider sperm to be abnormal. Now this plate is actually showing the normal sperm morphology. We can see the lighter area, acrosomal area, and the darker, the post-acrosomal area and the tail. So the acrosomal area, the post-acrosomal area, and the tail all are seen, and it's all of them that you're looking here, they are considered normal. Whereas if you compare this side of the slides actually show all the abnormal sperm having the abnormal head, their size, their contour, their shape. Then if you just look at the tail, there is excess residual cytoplasm over here. The tail is thickened, and the bend, of course, I'm able to show in. I'll be showing in the next slide. So apart from the normal sperm cells, we are also able to see other kind of cell in the semen smear. The large, this irregular shaped cell that you see here, this is the epithelial cells which are being secreted out or extruded out from the urogenital tract. So this is the epithelial cell. Another kind of the cell that we see here, they are the round cells. So the one that you see, you have to see, compare the size with the sperm. So if you just look at the size of this particular cell, it's quite large as compared to the sperm. So this is the macrophage. Now we also look at the morphology of the nucleus inside. So this is the polymorphonuclear lymphocyte or the neutrophil here. Very commonly found. So out of the WBCs, it's the polymorphonuclear, which is very, very common. Now, another kind of the cell that we see here is this. So we consider this cell as to be round spermatid. So they are the immature germ cells, which are also being extruded out, right? So this is again just to show further few abnormalities. Here is the double-headed sperm there. Here you can see as compared to the other of the cells, the head size is quite more. We can see the vacuoles over here. Any vacuole in the post-acrosomal area is considered to be abnormal. So the region of interest basically are the head, the neck and midpiece, the tail, and we have to look at the excess residual cytoplasm as well. So normally we report sperm morphology as percentage of the normal looking cells and the abnormal looking cells. But the latest manual has also added up the teratozoospermia index, which is actually the sum of all abnormalities, means the head abnormalities, neck and midpiece, tail, and the excess residual cytoplasm, divided by the sum of abnormal sperm. So in detail also we can provide the report. And also if we are able to look at the round cells, which are in each of the field, if we see more than 10 round cells, then only we have to report. Otherwise, up to 1 million round cells are considered to be common. Now, what are the advanced embryology tests? Conventional semen analysis, it's not adequate at times to predict pregnancy outcome, because optimal semen parameters sometimes, they can be associated with poor pregnancy outcome. Now, with absolute normal semen analysis parameters, it may not be necessary, to shift to specialized tests very early. But in cases, if we find the parameters are borderline, or if there has been any history of fertilization failure in past, in that case, it becomes necessary to a few tests. Now, there are a few advanced tests which are called the preparation methods, the sperm preparation methods, and these methods are used during ART procedures in IUI, IVF, or HC. And then there are certain sperm function tests to evaluate, where we can evaluate either the different stages of fertilization, or we can also, test the different parts of the sperm. Now, why do we use sperm preparation methods? It's actually to replicate in vitro the natural process. During physiologically, the viable sperm, they are separated from other constituents of the ejaculate, as they actively migrate through the cervical mucus. So the viable cells, they are separated from the other constituents as soon as possible, if we are going to use that sample for ART. Now, how do we decide that which is the method that we are going to use for preparing the sperm? It actually depends upon the quality of the sample. Now, simple wash is used if the sample is of the optimal parameters. If the sample is normal, in that case, we use the simple wash, where we add the media and centrifuge it twice just to separate the seminal plasma. So these are the steps of the simple sperm wash. You can see the details in the manual. Now, there are a few tests which are based upon the migration capacity of the sperm. So sperm may be selected, by their ability to swim out of the plasma, seminal plasma, into the culture media. So we call this technique as swim up technique. So it's very importantly used, where what we do is that we first make the pellet, the semen pellet, by centrifuging the sample, and then we add the media over it, and then we keep the tube at an angle of 45 degrees inside the incubator for 1 hour. So all the viable cells or the motile sperm, they would be coming up, they would be swimming up into the media, which is overlaid the semen sample. And then we separate out the viable cells. And then we can use it further for the ART procedure. So these are the steps and details. Next method we have is density gradient. Now, if the quality of the sample is not very good, and if the motility is poor, then we cannot use swim up method. In that case, we have to go for the density gradient. It is actually density gradient separates the sperm cells based on their density. So at the end of centrifugation, each sperm will be located at a gradient level. And very commonly, we use 40% density top layer and the 80% density of the lower layer. So these are the gradients that we use in a different gradient media that we use here. And depending upon the density of the mature and the immature cells, the cells will be collected separately. So these are the steps in the details. Now, next we have another method which is based on the membrane characteristics. It's called the magnetic activated cell sorting system. Now, MACS actually separates the cell population based on their surface antigens. So it's going to separate the epitotic cells sperm from the non-epitotic sperm. We all are aware of the epitotic apoptosis mechanism. During apoptosis, what happens that phosphatidylserine actually, it is translocated from the inner membrane of the sperm to the outside. Now, the magnetic beads, they are conjugated to the NXN-V antibodies, and they are used to separate the dead apoptotic sperm by this particular method. Now, annexin B has got a very strong affinity for the phosphatidylserine, but it cannot pass through the intact membrane. So annexin B is going to be bound only to the cells which have undergone apoptosis, means the dead cells. So this is just to show the picture where the magnetic collection device, this is the magnetic collection device having the columns where we can keep the tubes here. And the apoptotic and the non-apoptotic cells, they're labeled with the magnetically annexin B particles. And these are going to attach to the outer surface of the sperms, which are apoptotic. So the annexin Bs, they're not going to bind to the sperm, which are non-apoptotic, and they have the intact membranes. So all the apoptotic cells, they would remain within the tube, but the non-apoptotic cells, they would be flowing down and they would be collected in a separate tube. So another method for preparing the sperm is that microfluidics. You all are aware that microfluidic is a branch of physics which studies the behavior of fluids through microchannels. The fluid movement within these microchannels actually depends upon the density of the fluid, the viscosity, the velocity, the size, and the geometry of the environment in which it is flowing. In microchannels, surface tension and capillary forces actually decide whether the fluid is going to have a streamlined flow pattern or not. So the principle of using microfluidic device is that only the motile sperm would be able to cross the border that's going to separate the parallel stream of the semen fluid. So if you can see here, in this particular view, this is a microfluidic slide that we use. Here, if we pour the semen sample along with the media, the viable cells or the more motile or more potent sperm cell, they would be able to cross this channel and they would be reaching into this particular chamber. But if the less the potential cell, they would not be able to cross and they would be collected here. So for ART procedures, we will be collecting sperm from the C chamber and not the D chamber. So this is another way of separating out. Now, after doing this sperm preparation, if the embryologist is doing ICSI, there are a few selection methods that he can utilize while performing ICSI, before performing ICSI. Now, what are those methods? One is called the intracytoplasmic morphologically selected sperm injection, which is called INSEE. Now, in this, the sperm are visualized under very high magnification, that's around 6,000x magnification. Now, under this magnification, the embryologist would be able to look at the sperm structure in detail, like the details of the nuclear structure, the acrosomal structure, and as well as the tail structure. And depending upon the normal looking cell, he's going to pick up that particular sperm and then do the ICSI. Now, suppose if the embryologist finds that there is no motile sperm seen on the culture dish, then what is it going to do? The immotile sperm does not indicate that all the cells are dead. It might be possible that the motility is restricted, but the cell may be viable. So he can use a hyposmotic swelling test where adding the hyposmotic solution, keeping the sperm in the hyposmotic solution. If the sperm is intact, if the membrane is intact, then it's going to show the curling of the tail. So the curling of tail actually represents the viable cell. So this is the method of Horst test that we use. And these are the curling pattern of the tail, and all these cells are considered to be viable cells. So if there is no change in the tail, then that cell is considered to be the dead cell. Next test that can be used by the embryologist is called the physiological ICSI. Why do we call it as physiological ICSI? Because it's based upon the very first stage of the fertilization, where the sperm is crossing through the cumulus matrix, and we know that the cumulus matrix contains hyaluronic acid. So if the sperm is intact, if the membrane is intact, that the sperm is going to be bound to the hyaluronic acid. So there is a ICSI dish where the hyaluronic acid is embedded, and the sperm, the viable cell, will go and bound to that the matrix. So the cell which is bound to that area where the hyaluronic acid is embedded, the embryologist can pick up that cell because that cell is considered to be viable. Now let's move lastly to the sperm function test. So an ideal sperm function test should be able to diagnose the specific sperm dysfunction. It should be able to predict fertilization and pregnancy rates and should indicate an appropriate therapy to alleviate the identified sperm function test as research test. Now, in this sperm function test, we can assess sperm parameters. as the routine semen analysis, but the more advanced, with the help of more advanced tests, we can assess the plasma membrane function. We can also assess the ectrodome, the nucleus, as well as the mitochondrial function. So we do have these tests. We can also assess the ectrodome intactness test. We can also assess the nuclear chromatic decondensation and the DNA fragmentation index. And lastly, we can also assess the mitochondrial activity. Now, not only the sperm parts that we can assess in sperm function test, but we can also, assess the fertilization stages, like hyaluronan binding tests, the physiological ICSI that I have discussed, the sperm zona pellucida binding test, which is called the hemizona assay, the ectrodome. These tests has been obsoleted because of the ICSI has come. So there's no rule of, testing all these, because ICSI and ICSI, we are just directly, injecting the sperm inside the oocyte. So we do have very important tests, which are called the nuclear chromatin decondensation test and oocyte activation test, which assess actually the potency of the sperm to activate the oocyte, once it is inside the oocyte. Now, the sperm ectrodome test is basically, the capacitated sperm can be stimulated to ectrodome react. And as a result of ectrodome reaction, that's going to actually release the ectrosomal enzyme, and ectrosine is one of them. So we can assess the presence of ectrosine and the other enzymes in the media. All the ectrodome reacted sperm, they can be labeled with the fluorescent proteins, some monoclonal antibodies, just to identify which sperm or how much percentage of the sperm has already undergone ectrodome reaction. So gelatin assay test is one of the tests which is going to actually identify the ectrosomal reacted sperm. So all the sperm having yellow around, they are the ectrodome reacted sperm. Now, to assess the nuclear integrity, we do have a nuclear chromatin decondensation test. Now, we all know that the chromatin in sperm is highly condensed prior to fertilization. But during fertilization, what happens is that this condensed chromatin needs to be decondensed to be able to fertilize and to produce normal zygote. So this condensation is being produced by breaking the disulfide bonds which are there in the protamines. And as a result of which, they will be replaced by the histones and decondensation happens. So we can induce decondensation in vitro, and all the decondensed cells, they would be showing swelling. So in this particular side, all the swollen cells actually represent the normal sperm cells, which have undergone the decondensation. So this is again another test that we can use. Now, we all are aware DNA fragmentation index is actually used up very nicely in today's scenario. DFI can be tested by sperm chromatin structure assay or sperm chromatin dispersion assay or tunnel assay or comet assay. So there are so many tests available. So what we do in our lab very commonly is the sperm chromatin dispersion assay, which is based on the chromatin denaturation and deproteinization. As a result of this process, what is going to happen is, the DNA fragmentation, if there is, it actually indicates the degree of DNA fragmentation and the amount of dispersion which we are able to see. So as a result of denaturation and deproteinization, sperm is going to produce sperm nucleoid. The head is seen as sperm nuclei, which is actually the sperm nucleus surrounded by a halo, which is produced by the relaxed DNA loops. So this kind of nuclei is considered to be normal. So we can see in this particular slide, all the sperm heads having this halo around, the stained halo around, all these cells are considered to be normal, whereas rest of the sperm, which are not producing these halo, they actually have the fragmented DNA. Now, we can also assess sperm mitochondrial activity index by looking at by assessing the levels of ROS in the seminal plasma. And also we can use the fluorescent staining methods. One of them is the cell ROS, which is being used. So lastly, a few words regarding the oocyte activation test. Now, why this test is important? We all know that the sperm enters the oocyte. Now, once it enters the oocyte, it releases certain factors inside the oocyte. And these factors, very commonly, the best candidate till now is the phospholipase C zeta. Now, this PLC zeta ultimately what happens is that it's going to stimulate endoplasmic reticulum to release calcium. And once the calcium is released inside the oocyte, it's going to actually stimulate the oocyte to resume its meiosis. We all know that the oocyte is arrested in metaphase 2. So this arrest is released only once the calcium is released inside the oocyte. So this calcium release is triggered by the entry of the sperm site, which is going to release this PLC zeta. Now, how in the lab we are going to test whether the oocyte is activated or not? It actually depends upon one of the functions that we use, which is called the mice oocyte activation test. First of all, why do we need to do this particular test? Now, ICSI has been very successful method till now, but there are 5 to 10% of the cases where the ICSI also failed. So we actually want to know whether the ICSI failure is due to the reasons attached with the oocyte or it is sperm mediated. So the most common cause of the ICSI failure is considered to be the absence of sperm-mediated oocyte activation. That means sperm is not able to release the factors inside the oocyte. So there is no oocyte activation. So we have a model, we call this as heterologous mice model, where we take the mice oocyte and take the human sperm or the patient sperm, and then we inject it inside the oocyte. Now, if there is oocyte activation, the oocyte activation can be visualized by the presence of the formation of the second polar bodies and the pronucleus. Now, if there is oocyte activation, that indicates that the sperm were normal. So the human sperm were normal. So the problem was there with the female. But if there is absence of oocyte activation, in that case, we can interpret that the problem was there with the male. So the sperm deficiency of oocyte activation is the main cause of ICSI failure. So this test is also being used, but mostly for the research purpose. So this is my last slide. This is very commonly done. This is one of the advanced techniques in embryology lab that's are being utilized. So the sperm cryopreservation is used in case whenever there is failure of oocyte retrieval during any ART procedure. So in that case, the sperm needs to be cryopreserved till the further cycle and the oocyte retrieval happens. It is also being utilized for male cancer patients before they go for chemotherapy, because that's the condition here which is going to affect the sperm function, the testicular function. So there are various methods of sperm cryopreservation, but latest what is being done in the embryology labs is the vitrification, where the semen sample mixed with the media, and then it is stored under the in the liquid nitrogen at minus 196 degrees Celsius. And whenever the sample is to be utilized further, then it is de-vitrified or thawed. So these are the reference books that you can read up for this particular topic. This is one of my books, co-edited by me, and also the WHO manual 2020. So thank you very much for your kind listening. Thank you very much.
Thanks, Dr. Mona, for such a wonderful presentation. It was a very enlightening talk. Thank you. Chairperson, Vanessa, do you have any question?
Dr. Chalini, there are a lot of the question in the inbox.
Yes, sir. Yeah. So what to do? Should I ask chairperson first?
Take few questions from the chat box.
Okay, sir. Fine. So Vanessa, do you have any question?
Dr. Binay?
He's unmuted. He has to be unmuted.
Please unmute yourself.
Again muted.
Dr. Binay, please
unmute. Yeah. Unmuted.
You are
that. Yeah. So there are so many questions that are being raised. So first question is, what is the effect of room temperature on sperm count, its morphology, mobility, and lifespan?
If we keep the sperm sample, semen sample in room temperature, the maximum effect is going to be on the motility. So the first parameter that we assess as soon as the semen sample is liquefied, it's going to be looking at the motility, because with the time, as the time advances, the sperm motility, it goes down. So that's the factor which is very, very important to assess as early as possible. Then, of course, if you're not keeping semen sample in any of the culture media, then of course it's going to affect the vitality as well as the morphology. So ideally, it should be done, the time frame that I have discussed, all the parameters.
Okay, thank you, madam. I hope the question is answered. Dr. Swati Saxena is asking, how COVID has influenced the sperm function test, because it has been tabulated in the research articles that it has reduced the main infertility. What is the take on you on this issue, madam?
I have not come across any of the authentic paper that actually states that there is actually effect on the semen quality, I mean the sperm quality. But there has been various review articles which state that COVID directly or indirectly affects. Even one of my collaborators from AIMS Rishikesh, he has one project on this only, the COVID, but he also didn't find any of the changes. So the effect might be because there might be any ejaculative function, but otherwise as such, I have not come across any of the authentic papers.
Okay, madam, thank you. And what are the chances of fertilization in immotile sperms which are viable? Dr. Tharani Pila is asking you.
Yes, definitely. ICSI is actually the model for ART procedure, where we can use the immotile sperm and we can inject inside the oocyte, and the successful results are being seen. Yes. I think that Dr. Sarpreet will enhance, it's going to enlighten about this particular in his
and one last question that we'll take is that Dr. Nandini is asking, what is the liquefaction time in sperm analysis?
So it is 30 to 60 minutes, we say. So by half an hour, it should liquefy, but we wait for another half an hour if the sample is not liquefied. So by 1 hour, most of the sample liquefied.
Okay, thank you. And question, what are the centers in India which have cryopreservation facilities that are there in India?
In India, to be very frank, there are very less of the government setups which actually provide, even in AIMS, being the very good institute, we do not have semen cryopreservation facility. There are so many reasons for that. We have been trying, at least my lab has been trying to establish that. And the semen cryopreservation is being provided by the private setups. But to be very frank, before starting this particular semen cryopreservation, this facility to the patients, there are a lot of things, there are a lot of research that we need to do. Actually, the effect of cryopreservation, the long-term effects are to be assessed first. How are they going to affect the embryo and the newborns? And a lot of things are there that we need to assess first to start this facility. So there are hardly any government setup, and whatever setups are present, they are actually attached with the IVF facility, not for the cancer patients.
Dr. Subhalakshmi.
Morning, sir.
Yeah.
Nice presentation, Mona ma'am. I have a question, ma'am. As you have explained that in the initial fraction of the ejaculate, there is a sperm with the prostatic fluid.
Yes.
And the semianal vascular fluid comes in the later part and it does not come in contact with the sperm.
Yes.
So my question is there any condition where the semianal fluid can come in direct contact with the sperm? And if so, what will be the effect of the seminal vascular fluid on the sperm?
So physiologically, there is no possibility that it can happen. Normally, it is like that the prostatic secretions, which are rich in the sperm, they never come in contact. Because the seminogelin, the function of seminogelin comes into play only in the ejaculate. So they say physiologically, seminogelin is important because it is preventing the premature capacitation. So only the sperm is going to capacitate once it reaches the female reproductive tract. So before that, it does not capacitate because of the presence of seminogelin. Apart from that, there is no way that they're going to come into contact physiologically with seminogelins.
Any pathological condition?
And that I'm not aware of now.
Okay, ma'am. Thank you, ma'am.
All right.
Thank you, chairpersons and moderator. There are a lot of the questions in chat box. I think
Yes,
I will
sir.
compile and share with Dr. Mona. Later on, she will answer on the WhatsApp and the email.
Sure, sir. It would be my pleasure. Thank you very much. Thank you very much, sir.
Thank you. There are a lot of the questions in the chat box.
Sure, I would be happy to answer all of them.
Thank you. Thank you very
Yes,
much.
sir.
Dr. Chandni, please conclude the session.
Yes, sir. So Dr. Mona has given a very wonderful talk, and she has also told us about the infertility, that it is a global health problem, and why do we do semen analysis, and why there is a need for lab manual for doing semen analysis. She has also told about semen composition, the prerequisites for semen analysis, and she has also compared about the semen analysis, which was given in WHO manual in 2010 and 2020. She also told us about some nomenclature used to indicate quality of semen parameters and the steps for semen analysis. In the end, she has also told about the sperm function test, what are the parameters involved in to assess the sperm function test. And in the end, she has concluded by sperm cryopreservation. She has told about sperm cryopreservation. Thank you, ma'am.
Thank you very much.
Thanks a lot.
Thank you, chairpersons. Thank you, Dr. Mona. Now is the time to appreciation. Dr. Nikhil, please go ahead.
Thank you, ma'am. Thank you, sir. So I would like to present the certificate of appreciation to Dr. Mona Sharma, ma'am, for delivering a guest lecture entitled Semen Analysis with WHO 2021 and Sperm Function Test in this pre-conference workshop today. Thank you, ma'am. I would like to present the certificate of appreciation to Dr. S.L. Jethani, sir, for chairing this session in the pre-conference workshop, and to Dr. Vinay Kumar Virana Shetty, sir, for chairing this session in this pre-conference workshop. Thank you, sir. Certificate of appreciation to Dr. Subha Lakshmi, ma'am, for chairing this session in this pre-conference workshop. Thank you, ma'am, to have you here. Certificate of appreciation to Dr. Chandni Gupta, ma'am, for wonderful moderation of this session in this pre-conference workshop. Thank you so much, ma'am.
Thanks, Dr. Nikhil.
So now we can have a tea break session for 10 to 15 minutes. After that, we will again rejoin. So you all can take a break. Okay, thank you. We will be beginning the sessions after 15 to 20 minutes. Thank you.
Hello, everyone.
Yes, Pandey sir, you are here?
Yeah, yes, sir. How are you, sir? How are you?
I am
Good
fine.
morning.
Actually, I am calling you. You are not receiving the call, so we are planning to move on the next session, but you are here, so we have to start your session right now. After that, we proceed further.
Fine, sir.
Okay, so Nikhil, please take the chair.
Hello, sir. Welcome.
Hello. Hi. Good morning.
Good morning, sir. So let's begin with the session after tea break. I hope you all have taken a break. Okay. So I will be introducing the moderator for the coming session, Dr. Devanshi Mishra ma'am, who is currently the assistant professor at HIMSS Barabanki. She has done her MBBS from RMCH Kanpur, and she's the MD anatomy from King George's Medical University, Lucknow. Ma'am, if you are online, please unmute yourself.
Thank you, Nikhil.
Hello, ma'am. Good morning.
Good morning.
I will be moving the slides, ma'am. You can proceed.
Yeah, sure. Very good afternoon to one and all present online for the workshop. I would like to thank Dr. Punita ma'am for giving me the opportunity, and especially Dr. Rakesh Kumar Verma sir for giving me the opportunity for moderating this session. We have our chairpersons with us. Dr. Jayati V. Ma'am is principal and dean, and she's also the professor of anatomy at Saptagiri Institute of Medical Sciences, Band Research Center, Bangalore. Ma'am has done fellowship in International Medical Education and Research Center. She has 30 paper publications as well as more than 45 paper presentations in international, national and state conferences. Another speaker we have with us is Dr. Kumar Satish Ravi sir. He is currently additional professor of anatomy in AIMS Rishikesh. He is also ex-assistant dean in academics there. He is editor-in-chief, National Journal of Clinical Anatomy. He is former assistant professor, course director, and head of the Department of Anatomy, School of Medicine, Spartan Health Sciences University, St. Lucia. Then, sir, please change the slide. Okay, he has received a Best Teacher Award in 2018, Best Researcher Award in 2021, as well as Best Professor of the Year Award in 2021. He has published several papers in international as well as national journals. He is also a member of American Association of Anatomical Anatomists. He is a lifetime member of ASI, also a member of Indian Society of Human Genetics, Federative International Committee for Scientific Publications. He is editor of globally recognized book, Snell's Clinical Neuroanatomy for South Asian edition. I welcome you, sir. Now, another chairperson with us is Dr. Yogesh A. Sontake, sir. He is also a regional professor. He has research projects and grants, expertise in Adobe Illustrator software for drawing medical illustrations, articles in various national and international journals, around 52, working on various immunohistochemistry and confocal microscopy based products. He is a life member of Anatomical Society of India, Society of Clinical Anatomists, as well as Associations of Anatomists. He has published books, Textbook of Human Histology, Textbook of Human Embryology, second edition, Textbook of Human Anatomy, volume 1 to 4. 5, 6 are in press now. Principles of Clinical Genetics, second edition, Principles of Histological Techniques, Immunochemistry and Microscopy, Principles of Scientific Writing. I request Kumar Satish Ravi sir to introduce our guest speaker for the session.
Thank you so much, Dr. Devanshi Mishra, madam, for introducing me. So before I introduce our guest speaker, I would like to thank the organizing committee of KGMU under the leadership of Professor Punita Manik ma'am for organizing this national conference during this pandemic. And I can see the topic which has been chosen for this pre-conference CME is very apt, and this will definitely help not only the anatomists, even the other clinical disciplines can be benefited by the CME. So now I would like to introduce our guest speaker of the today's session, Dr. Praveen Kumar Pandey. He has done his MS surgery, MCH apart from the DNB. He is a consultant urologist and renal transplant surgeon, presently working at Sahara Super Specialty Hospital, Lucknow. There are several academic awards and fellowships to his credits. That includes a Dr. I.P. Agrawal Memorial Best Postgraduate Paper Award. He has received at 25th Annual Conference of the Association of Surgeons of India in the AMP State Chapter in 2008. Apart from that, he has received the Best Poster Award for Foreign Bodies in Lower Urinary Tract and their Management in USACON 2012 at Jamshedpur. Apart from that, he has also received the fellowship known as USI Olympus International AUA Fellowship in 2013. Apart from that, he has also received another fellowship known as UAA Youth Section Fellowship in 2014. So with this brief introduction of Dr. Praveen Kumar Pandey, we welcome him and invite him to present the guest lecture. Welcome, Dr. Pandey.
Thank you, sir. Sir, I just want to say a few things. Sir, as you know, as per the time session, we are running a little bit late. So I request you to, sir, kindly wind up the session as soon as at the earliest, sir.
Sure, Dr. Nakil.
Thank you, Dr. Ravi, for such a nice introduction. And good afternoon, everyone, respected chairpersons, members of the organizing committee, and respected audience. I'm really privileged to be here, and it's really an honor to be at this platform discussing this very important topic with all of you. So can I start sharing my screen?
Yes, sir. I have stopped my screen from sharing. You can begin the session, sir.
Okay. I think it is showing it has been disabled from your side, please.
Okay, sir, just hold on. Yes, sir, you have been made the co-host now. You can just share the screen. Sir, are you getting the option to do that?
Yeah, I'm getting it.
Okay.
Is my screen visible?
Yes, sir, absolutely. Please go ahead, sir.
Okay, so I'll come straight away to my topic, that is workup of an infertile male.
So please make this slideshow. In the bottom, there's an option to click the slideshow. It will full screen.
It's already in the slideshow mode.
Sir, it's not showing up actually. There may be a certain lag because it's showing in the form of the normal minimized window actually. So in this slideshow options are below.
Can you see it now in slideshow mode?
So just you have clicked. I can see you have clicked it. It's showing a little bit lag from your side.
Just a moment. I'll reshare my screen. Just a moment.
Please do it. Yeah. Okay, sir.
Is it okay now?
Sir, again, it is minimized. Please click on the slideshow mode.
Actually,
F5, you can press F5 if you're using the Windows.
I understand that. Actually, is it okay now?
No. So can you please try clicking F5 or slideshow menu? In the slideshow menu, there's an option. Okay, now it has stopped sharing now.
Yeah, I know. Just give me a moment.
Yes, sir.
Just a moment. Is it okay now? Hello.
We can see your screen, but sir, the PPT is not open. We can see your screen, sir. But it's showing the file folder view. No worries, sir. We all are not techno savvy.
No, that's okay. I don't know why it's happening that way.
Happens, sir, to the best of us.
How is it like now?
Sir, just I can guide you where it is written at the bottom of the page on the right side where it is showing the zoom icon. You just click that PPT sign. So please, if you can try that, it will show up immediately.
Just a moment.
Sir, on the right side bottom where it's written 69% in the zoom, just next to it on the left side, there's an icon to play the slideshow. So if you can just click on that, it will just begin up.
Can you see my screen now?
I can see your screen, definitely.
So
sir.
this is the slideshow button.
Sir, just follow my words, sir. In the right side, in the bottom side, where it's written 69%, just next to it on the left side, there's an icon. Just click on that, please.
I'm on that icon. Can you see my screen now?
I can see your screen, sir. Please click that icon.
Yeah.
So,
it is full screen on my screen, but I don't know why.
It's full screen on your side, sir. It's not showing up here. Okay, sir, then we don't have any other option. Let's start then, sir, please. This way only you can just slide. If it's showing up on your screen, you will move the next slides. Let's see.
Just let me just, Can you see my screen now?
Screen is visible, sir.
And the presentation?
No, presentation is not visible, sir.
Okay, I need to change it then. Is my screen visible now?
Yes, sir. Screen is visible, sir. You can just start the presentation. It will
now is the presentation visible on the full screen?
So full screen is visible, but the presentation is showing blank screen now. Sir, just move the next slide. It may show up. Just move the next slide.
The next slide.
No, sir, it's not showing up. You can just, sir, start the presentation in this view. Yeah. So just begin.
So I think.
Yes, ma'am.
I think we can increase the percentage if full screen is not visible.
Okay.
So please start the presentation in this way only.
Okay.
No problem in that. We will just begin the session.
So can you see the first screen of introduction?
No, sir.
Okay. And I want to understand what I need to do. Okay, fine. I have to move it manually.
Yes, please do that. Now it's visible, sir. You can just start it.
So 7.5% of sexually active men, they seek care in their lifetime for difficulty conceiving. And out of these 7.5%, around 20%, 18 to 20% are diagnosed with reproductive problem, one or the other. And this leads to some social impact, the psychological impact to the couple. And not only this, approximately 20% of their annual income goes into infertility related expenses. So it leads to so much impact on the couple, and mostly it is the men who are the earning member of the family. So they have to pay a good amount of their earning on this also. Now, if you look at the different age groups in the men, around it is the relatively younger age group population, that is 25 to 34-year age group, where maximum number of surgeries are being offered for the treatment of male infertility. As the age group grows up, we see that this number of surgeries they go. So it is the younger, relatively younger age group of population that is facing this problem more and more. If somebody wants to do a workup of an infertile, many a times these may come to me in my clinic when they already have undergone some kind of evaluation, like they have undergone some semen analysis, they've undergone some imaging testing. So it is very important for me to understand that any of the points cannot be left aside. So we have to be methodical in our approach in the workup of an infertile male. And these are the 5 pillars. That is the history taking, the physical examination, laboratory and imaging evaluation, and if required, testicular histopathology. If you look at this chart, I know it is smaller in size from at your screens, but there are n number of medical conditions, diseases that are associated in male infertility. So there are a wide variety of diagnoses that are associated in male infertility, and for all potential possibilities, a methodical approach should be acquired. So the patient may complete a form at home or in the waiting area. We might develop a questionnaire and just hand it over to them, so that once they fill this questionnaire and they come to us, then most of the time I have an idea what I am looking at and in which direction I have to evaluate this men. This is a chart showing a large number of points in which the history should be taken. To begin with, it is the duration of the infertility, or are there any history of prior conceptions? The duration of infertility has a very important impact, because many a times few couple, they recently get married and they start visiting the infertility clinics, or they start coming to us, doctor, we are not conceiving. So I need to ask them whether you are using any barrier methods, or if you are just been married for a very short duration of time. So at least we should allow 6 months to 1 year of time for this couple to practice intercourse without any barrier methods, without any precautions. And then only we try to work up these males if they are not able to conceive. Also, if there is history of prior conception, that it makes my job very easy, because whatever problems there, it is not very big in magnitude, and it is of very recent onset. So we can deal with it in a very easy manner. We definitely take sexual history, past history of medical disorders, childhood histories, infections, surgical histories, which I will stress upon certain factors as we move ahead in the presentation. And eventually, we also take a family history, keeping in mind the disorder of infertility can run in the family. So what causes infertility? Mostly or broadly speaking, infertility may be due to toxins, infections, or inflammations, some childhood disorders, or maybe because of sexual abnormalities. So I try to take history in these 4 headings, so that I can identify the factor that is causing the male infertility. So toxins, first of all, the spermatotoxicity might be due to some endocrine factors. In males, the spermatogenesis takes place under the influence of testosterone, and estrogen acts just against the testosterone in male body. So how does it act against the testosterone? Because the estrogen levels, by negative feedback, they inhibit the gonadotropins being released from the pituitary. So it can in turn decrease the testosterone level in the male body. If we take history of obesity, if we take history of any uses of any particular drugs like anti-androgens such as bicalutamide, flutamide, nalutamide, these drugs, they eventually cause decreased level of testosterone and increase estrogens in the body. History of intake of certain steroids and induction of hyperprolactinemia. Prolactin itself is an endocrine modulator that acts directly against the testosterone. Now, this is a picture simply showing the feedback mechanism in the body. Hypothalamus being at the top, then the pituitary and gonadotropins being released from there, working at the level of testicles. So whenever testosterone in the body is converted to estrogen by aromatase activity in the adipose tissue or by any other activity, this estrogen in fact inhibits luteinizing hormone secretion, and this in turn decreases the testosterone levels in the male body. Again, if there is any history of testosterone supplementation from outside, that is exogenous testosterone, it can also decrease intratesticular testosterone synthesis in the male body. Apart from this, there could be certain history of certain drug intake which can interfere with testosterone levels. Intake of cannabis for recreational use has shown to decrease plasma testosterone levels in a duration and dose dependent manner. Chronic alcoholism and heavy chronic alcohol intake further decreases androgens by increasing aromatization. Smoking is a very known factor which causes toxicity to the spermatogenesis, and if it is paired with varicocele, like if a person who's having varicocele also and his history of smoking also, then they are having a very grim chances of conceiving a child. So what is the effect of maternal smoking? Like if a female, she's expecting and she's on smoking, heavy smoking, there are certain studies which have shown that this can also lead to some fertility issues in their male offsprings. There are certain questions we get from our patients like, so I'm using the electronic cigarette off and on, does it is going to cause any impact on my male fertility potential? So till now there are no studies which state that these electronic cigarettes have any adverse effect on the male fertility. Again, spermatotoxicity may be because of certain drugs, as in terms of medical drugs like antihypertensive. Certain antihypertensives such as ACE inhibitors have shown to cause erectile dysfunction. Calcium channel blockers prevent sperm attachment to zona pellucida. Antipsychotics, many times some patients on an antipsychotic, some of them such as SSRIs, they cause anorgasmia and interfere with intercourse. Some of these antipsychotics, they cause elevation of prolactins level in the body, which in turn causes abnormalities in spermatogenesis, and dopamine antagonism also interferes with the spermatogenesis in the male body. Certain opioids, they suppress LH release and in turn decrease testosterone levels. Even endogenous opioids in the testicles, they act with the Golgi cells in an autocrine and paracrine manner, and they can also suppress LH release. Certain antibiotics such as tetracyclines have been known to cause spermatotoxicity. Chemotherapeutic agents, n number of them, we all know that they have got very ill effect on the spermatogenesis because they target the cells in the body that are replicating very profound manners, that is the cancer cells. But the germ cells in the body, they also replicate in a very higher manner, and therefore they become target of collateral damage. So these chemotherapeutic agents, if there has been a history or somebody is going to be prescribed these drugs, we must know, because before they are exposed to these drugs, as Dr. Mona just told her in her presentation, there is the idea of cryopreservation of sperms. So we can ask them, we can offer them cryopreservation of sperms before undergoing treatment or exposure to certain chemotherapeutic agents. There is another drug which is called intravesical BCG, that is intravesical BCG installation is being done by us urologists in certain cases to prevent recurrence and progression of urinary bladder cancers. So this BCG has also shown to interfere with spermatogenesis. Certain anti-inflammatory agents being used by our gastroenterologist colleagues, such as sulfasalazine, cause oligostenospermia. We can tell them, you can ask your doctor to change it to mesalazine. So this doesn't cause any ill effect on spermatogenesis. Environmental toxins, insecticides, pesticides, heavy metal exposure, they all have been associated with abnormal spermatogenesis. Now, thermal toxicity, how it affects males. We all know that spermatogenesis occurs in testicles, which are lying outside the main body in the scrotum, and the temperature in the scrotum is 2 to 4 degrees centigrade less than the main body. So spermatogenesis occurs at this slightly lower temperature, and if the testicle is in the main body, such as in the case of cryptorchidism, then the testicles are at a high temperature and the spermatogenesis impairment happens. Again, varicocele is a condition in which there is tortuous dilatation of pampiniform plexus of veins. This pampiniform plexus of veins torches dilatation, destroys the counter current mechanism that is responsible to keep the testicles at a cooler temperature. So once this varicocele happens and the testicles again go up to high temperature, this interferes with spermatogenesis and the quality of sperms goes down. Radiation, ionizing radiations are known to cause germ cell loss and Leydig cell dysfunction. And there is recent data which says that increased cell phone talking time, that cell phone has also caused some degree of residual radiation. And if males are using these phones for a very long time to keep on talking, then this type of exposure has also shown to delay some of the seminal parameters. But still it is not confirmatory, it is under evaluation. Now, these were the certain toxins. Now we will also take history of certain infections and inflammations which are known to cause infertility in males. These infections and inflammations, they might cause some anatomic consequence, such as if there is a STD or there is some infection in the urethra which causes urethral stricture formation, that is the narrowing of the male urethra. Then in that case, ejaculation might be hampered. There could be functional consequences because of infections, as in certain STD organisms are more virulent and affect the fertility potential if compared with the normal bacteria that they cause UTI or certain testicular infections. Even non or post-infection inflammatory process affecting prostate has shown to cause sperm alteration, as in prostatitis. So the history of STDs, certain prostate infections, manipulations, or history of stricture, we need to take these history from some of the patients if they complain about some of these disorders. Apart from this, we also take history in some of the patients about their childhood diseases, because if there is a history of some pediatric surgery, as in this history of some repair of hernia or hydrocele, then there could be a possibility of vas deferens obstruction, which may in turn be because of the inflammatory process of the surgery itself, or maybe because of the entrapment of the vas in the mesh that is used for the repair. Some of the children might have undergone some surgery for some anatomic abnormalities like exhaustrophy of bladder, where bladder reconstruction and bladder neck reconstruction is done. But despite this, these men develop retrograde ejaculation, which can again impair their fertility potential. Testicular torsion is a known factor. History of testicular torsion tells that there is some abnormality in the testicles, and it is just not the testicle that is being affected by the torsion, but it has also been found that even the contralateral testis on biopsy shows some abnormality in seminal parameters in 50 to 80% of cases. And after torsion, these patients develop anti-sperm antibodies, approximately 10% of them, and this can also hamper the fertility potential in these patients. History of cryptorchidism, as I just told about the thermal toxicity. So even if this cryptorchidism is corrected by orchidopexy, it has been found that if the cryptorchidism is bilateral, that is affecting both the testicles, then even after correction, the fertility potential in these subset of patients is just 70% of the normal population. So we must also take a history of any surgical procedure for cryptorchidism, whether it was unilateral or bilateral. And again, this cryptorchidism correction should be done before puberty sets in, because once the puberty sets in, then the results are not that good. Retractile testes are also known to hamper sperm density. Family history is important of infertility because some of the disorders may be systemic disorders and may be a part of a syndrome which might run in their family, such as cystic fibrosis. So as Dr. Rajinder sir will elaborate in genetic testing, there is cystic fibrosis evaluation can be done by certain tests, that is CFTR gene mutation. These gene mutations is evaluated, and we can diagnose this disease not only in the favor of treating male infertility, but counseling them for the future prospects also. Now, coming to the sexual history, we definitely take history of frequency of intercourse, whether there any abnormality in erectile functions, whether they are using any lubricants for intercourse, because some of these lubricants may be harmful for the sperms, including the saliva. Again, Dr. Mona was just answering a question about the effect of COVID on the seminal parameters. So COVID may or may not affect directly the semen parameters, but if it causes stress because of the COVID, if the patient has been in some ICU care for some very long duration, or they have lost some of their near and dear ones, then they might be in some degree of stress, which can also impair semen quality. And again, if this stress factor is very, very high, or there is some clear-cut psychological abnormality in the male, then this is the time for a psychologist referral. So after having done taken the whole history, we go ahead and examine the patient. That is in two parts, that is a general physical examination and the male sexual or the reproductive tract examination. So general physical examination begins the moment the patient enters into our clinics. Just by looking at the patient, we can tell whether the secondary sexual characteristics are properly developed or not, because it gives us some idea about their testosterone levels in the body. Also, if a patient has got a long arm span and lower body segment length, this also tells us that there is decreased level of androgens in their body, because low androgen levels, what they do, they cause delayed fusion of the epiphysis, and because of which these alterations happen in the structure of the body. Again, by examining the patient, by looking whether they have a gynecomastia along with some unicoid appearance and a tall height, these are classical features of a syndrome, that is Klinefelter syndrome. And once we suspect a Klinefelter syndrome, we can channelize them and send them for a genetic testing. Again, obesity, but just by looking at the patient, we can tell if a patient is morbidly obese, he might be having some hormonal abnormality in their body, such as raised estrogen levels. So general physical examination makes a very important part of our examination. And having done that, we move on to male reproductive physical examination. That is by examining the scrotum. They might be hypoplastic, they might be absent contents, that is there might be cryptorchidism, bilateral cryptorchidism or unilateral cryptorchidism. There might be retractile testes. There might be reactive hydrocele or a tumor. A tumor in itself is a dreaded disease or a cancer, a testicular cancer. A testicular cancer directly causes ill effect on the spermatogenesis within the same testicle and in the contralateral testis also. Again, we can diagnose varicocele by scrotal examination. Testes and epidermis examination can be done in a simple clinic. We can use Seeger orchiometer to know the size of the testes and the volume of the testes. The size of the testes, if it is less than 4.6 centimeters, raises suspicion of hypogonadism. Or if the volume of the testicle is less than 20 ml, again, we might have to consider hypogonadism. Spermatic cord examination will tell us whether the vas deferens is palpable or not, and if it is absent, whether it is absent on one side, on both the sides. If it is absent on one side, there could be associated Wolfian abnormalities, and the same side kidneys might be absent. So the patient might be having just one kidney and the other kidney is absent because of Wolfian duct abnormalities. If there is bilateral absence of vas deferens, then again the patient might be having a CFTR gene mutation, and then we have to channelize the patient into a genetic testing. Varicocele examination again can be confirmed by spermatic cord examination. Phallus examination, we can have a look and tell whether there is phimosis, there is meatal abnormality because of hypospadias or epispadias, or if there is a significant, clinically significant penile curvature, because all these issues, they interfere with sexual intercourse and deposition of semen into the female tract. Now, examination of prostate and seminal vesicles can be efficiently done by a simple digital rectal examination in the clinic, but it may or may not be a routine to do so. Why? Because the patients become apprehensive many at times. Okay? I have come for my male infertility and the doctor wants to do a DRE. See, if the patient has already been labeled as an infertile male and they have ventured for an IVF and they are being subjected to a number of tests, it has been found that that apprehension level is not very high at that point of time. But this is the first encounter of a patient with a clinician, then DRE might not be a very good idea. But if we end up doing it and we find the seminal vesicles are palpable, then definitely it is an abnormality, and it may be a cause or a condition in which ejaculated duct obstruction is a part. So this can lead to azoospermia, and we can straight away diagnose it by doing a simple DRE in our clinic. Having done the physical examination, we can come to laboratory evaluation of male infertility, and these are the three main components, that is the endocrine evaluation, analysis, and genomic assessment. So analysis of semen genomic assessments, I have seen that they are analysis of semen has already been dealt with, and genomic assessment is in some of the later talk by Dr. Rajinder. So I'll not cover much on these topics, but yes, I will tell certain things about endocrine evaluation. Routine endocrine evaluation in an infertile male includes testosterone estimation, serum hormone binding globulin and albumin levels, LH, FSH, and estradiol levels. So these are the four hormonal analysis that should usually be advised to a male coming for infertility. We might suspect an endocrinopathy in such patients if a person comes with a semen analysis report and tells that these are my factors, these are my reports. Again, serum hormone binding globulin and albumin levels are important to know the bioavailable testosterone levels in the body, because this is the testosterone component which makes all of the difference. LH and FSH levels, they together can give a good idea about whether the azoospermia is because of the obstruction or it is because of the impaired production of the sperms. So reduced testosterone size and decreased FSH levels, they tell us that the problem is because of the improper secretion of the gonadotropins. So the problem might be in the pituitary. Estradiol levels, if increased estradiol levels are found in the body, it may be because of so many factors which I have previously discussed. So having done these all four tests, certain other tests might also be done for endocrine evaluation, but in certain conditions. Like if there is a history of congenital adrenal hyperplasia, then certain other parameters or analysis like renin, testosterone, and other adrenal metabolites may be assessed. If one suspects a pituitary lesion, like a previous history of some pituitary disorder, or if there is difficulty in vision, or their prolactin levels, history of prolactin levels was high, then one can also do TSH, ACTH, growth hormone levels to assess the pituitary functioning in the body. So this is just a chart to tell that how the FSH, LH, and testosterone levels are there in the normal body and in certain conditions. Like we can see in hypogonadotropic hypogonadism, the FSH and LH levels are low, and so is the testosterone level. So it is all because of the negative feedback mechanism that these changes are happening in the male body. Serum hormone binding globulin levels, their levels may be decreased or increased in certain abnormalities in the human body, and that is why the assessment of these hormones is important, because these are certain abnormalities, certain systemic disorders which might be associated with these abnormal levels. Hypogonadotropic hypogonadism, I have just told you that there could be some abnormality at the level of central nervous system, some pituitary tumors, but apart from this, there could be some systemic disorders. So this is a very, very long list. So it is beyond the scope of discussion of this presentation, but we must know that these can also cause problems. Evaluation of semen, needless to say, Dr. Mona has done a splendid presentation. So these are certain terms which we commonly come across while evaluating the infertile male. And this is a chart which shows that even in infertile males, sometimes all the parameters might be normal. It's not necessary that always it is the semen which is parameters that are abnormal in infertile male. But yes, evaluating them gives us a lot of idea. Now, this is a chart which shows certain clinical significance, like Dr. Mona was telling us about so many parameters of the semen. So just looking at the volume, if the volume is really low, like it is less than 2 ml, there could be a possibility of retrograde ejaculation. So, or incomplete collection itself. If we are suspecting retrograde ejaculation, like in certain conditions, like in males who have history of prosthetic surgeries or bladder neck reconstructions, then we evaluate the post ejaculate urine analysis. That is, once the ejaculation has happened, we ask the patient to pass the urine and we collect that urine sample and we look for sperms in them. So by analyzing this sample, we can come across a diagnosis of retrograde ejaculation. Similarly, if there is low volume and non-coagulation, then there could be possibility of congenital bilateral absence of vas, which may be a part of cystic fibrosis. So ultrastructural assessment has already been dealt with. It is not a routine test, but ultrastructural abnormalities could be a part of some systemic disorders, such as cartaginous syndrome. Now, genomic assessment again is covered in some other presentation. I'm just telling you the name of the certain tests which can be done, such as karyotype, Y chromosome microdeletion, genomic sequence assessment, CFTR gene mutation assessment. So where these tests are done, these tests are at the discretion of the treating physician. It is not a part of the routine evaluation of the infertile male. A male with azoospermia caused by spermatogenic dysfunction, here karyotypic can be done, or in cases where there is severe oligospermia, because many times it has been found that it might be associating some genetic abnormality. So these genomic assessment tests are not part of routine investigation, but should be done in certain subset of patients. Ultimately, we have done all the laboratory evaluation of such infertile male, and then we end up advising certain imaging testing. So the most common routine investigation that is advised is scrotal ultrasound with color Doppler, which gives us an idea about the testicular volume, whether there is presence or absence of varicocele. Sometimes there might be incidental diagnosis of certain testicular tumors in such males also, which can also give us some idea why there is infertility in these males, because the tumors or the malignancy can cause impair of spermatogenesis. Again, this scrotal ultrasound may be coupled with transrectal ultrasound to give us some more information, which I will be telling in the next slide. Vasography was a test which was previously performed, in which a contrast was pushed into the vas deferens towards the body end to see the patency of the vas deferens. So it has its pros and cons, and because now certain more developed tests have come into place, so the vasography has mostly discontinued now. This is an image showing the tortuous dilatation of the pampiniform plexus of the veins. And in the next image, we can see that this is the color Doppler mode in which the reversal of the flow is seen on Valsalva maneuver. So these are the classical presentations of a varicocele, which might interfere with the male fertility potential. This was the test I was talking about, the vasography, where a contrast is being pushed into the vas deferens. And this is the image where the contrast has gone into the ejaculatory duct, seminal vesicles, and even into the bladder. So this is the normal one, and this is an abnormal test where the vas is obstructed, and we can know that what is the cause of infertility in male. Venography is also a test in which where there is a contrast pushed into the pampiniform plexus of veins, but rarely it is performed now. It is helpful only as a part of embolization of varicocele. So it is not being usually routinely done in patients. Transrectal ultrasound, this is also not routinely done in the patients. It is done in those patients where there is heavy suspicion of ejaculatory duct obstruction leading to azoospermia. It can also be a part of certain tests such as seminal vesicle aspiration can be done with truss, chroma-intubation or vasculography, which is of much of the theoretical discussion rather than the practical applications. An MRI with endorectal coil, apart from truss, is not done in all the cases. It is only advised in those cases where the information that we are looking for is not being provided by the truss. Abdominal imaging as in ultrasound to look into the kidneys present or not could be a part of a unilateral absence of vas deferens. So it is not a routine investigation. Cranial imaging is also not routinely done. It is only done in those cases where we suspect certain pituitary abnormalities. This is a picture showing the image of an transrectal ultrasound image where there is a prostatic cyst. This is a transverse image and this is a longitudinal image. Here you can see there is a very big cyst causing ejaculatory duct obstruction, and that's why azoospermia. And this is a straightforward case for us to treat, where we can do a transurethral resection of ejaculatory duct and thus making the men fertile again. Testicular histopathology, it's not indicated in the initial diagnostic evaluation, and traditionally it was advised in azoospermia to know whether the production of sperm is ongoing in the testicles. But by doing a biopsy, we can confirm certain abnormalities like Sertoli cell only syndrome and maturation arrest that is ongoing in the testicles. The only limitation that the biopsy has that it is invasive, and plus if you do a biopsy, it may not describe the entirety of the histology of the testis. That is, we don't know if we are taking a portion from a small area of the testicles, we don't know whether the spermatogenesis is good or bad in the other part of the testicle. So testicular histopathology comes at the end. To conclude, I would say that we should be methodical in our approach to increase our accuracy in diagnosing these infertile males, and to make a proper diagnosis so that we can offer them treatment. There is not a single best test for diagnosis of male infertility, but yes, by applying by adapting a methodical approach, we are less likely to miss any of the causes. Again, interdepartmental cooperation is very much required, because we need to do certain tests. Sometimes we need opinion from our endocrinology colleagues. Sometimes we give a referral to a concerned specialty like psychiatry, or any type of test that we are doing in radiology, we need a good radiologist to know the cause and to know the diagnosis that we are looking for. So in the end, it is the judicial and practical use of armamentarium that is at our disposal to evaluate such infertile male. So these are certain algorithms which we will not be discussing. Thank you all for the patient listening. Thank you so much.
Thank you, sir. Now I request our chairpersons for their expert comments. Dr. Jayati, ma'am.
Jayati, ma'am, please unmute yourself. Dr. Jayati, please unmute.
Sir, it is an excellent presentation. Excellent presentation, and I congratulate Praveen for giving in detail the presentation on the work of the infertile male. I would say that you gave in detail like how to do what are the investigations has to be done, and how the history has to be taken, and what are the drugs, recreational drugs, and then the decreased testosterone due to various factors like cannabis, then also antihypertensive drugs, then the opioids, all that, and physical examination, how important it is, and similarly the per rectum examination, which even I had not thought of, so that also, and the lab test, and similarly the ultrasound, all that. So we are really thankful to you, sir, for giving the brief and in detail presentation about the topic. Thank you, sir.
Thank you, ma'am.
Thank you, ma'am.
I request Dr. Kumar Satish Ravi, sir, for his comments.
Dr. Satish, please unmute yourself. Yes, go ahead. Dr. Satish, you are not audible.
Okay, thank you so much. I congratulate Dr. Pandey. It was a wonderful talk, and in fact, he has given an extensive outline of the different appraisal. And he has very well discussed the contemporary techniques for assessing the infertile males. Apart from that, he has also given the reasonable manual for whole course of assessment of infertile males. So that's all from my side, because we are lagging behind and we are having the scarcity of time is there. So from my side, there will be no question. If anyone would like to ask any question, we will request them to take only 1 or 2 questions.
In chat box.
Okay, now I request Dr. Yogesh sir for his comments.
Dr. Yogesh, please unmute.
Please unmute him.
Yes, sir.
Yes, Dr.
Am I audible, sir?
Yes.
Yes, it was a very nice talk. Nothing to add in this one. A very good presentation. Thanks for inviting us as the chairperson. Thank you, sir. Thank you.
Thank you. Thank you, Dr. Praveen, sir. I would like to collect your questions and will share with you. After that, you can answer our delegates, their WhatsApp and email.
Thank you, sir. Thank you.
Okay. Thank you very much. So we proceed. Pandey, sir, please close your screen. So, with a token of appreciation from our team to Dr. Praveen Pandey, who is the guest speaker of this session. Thank you, sir. Thank you, Praveen, sir.
Thank you, Dr.
This is a token of appreciation to our chairperson, Dr. Jayanti V. Thank you, ma'am. Jayanti, ma'am, thank you very much. You are with us. A token of appreciation to Dr. Kumar Satish Ravi. Dr. Ravi, thank you very much.
Thank you so much, Dr. Rakesh, for inviting me and the wonderful conference and the CME.
Thank you very much.
Thanks a lot.
Token of appreciation to Dr. Yogesh. Thank you, Dr. Yogesh.
I'm thankful, sir. Thanks for inviting us. Nice to see you, sir.
Thank you very much. A token of appreciation to our moderator and our student, Dr. Devanshi.
Thanks a lot, sir. Thanks a lot, sir. So I would just like to add a quotation to conclude this session very quickly.
So
anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young. So keep learning and stay young. Thank you, sir.
Thank you very much. Thank you, Devanshi.
Thank you, sir.
So we are moving on the next session. Rajinder Singh with us. So first of all, I would like to invite Dr. Suman. She is the moderator of this session. Dr. Suman is the additional professor at JIPMER, Puducherry. She did MBBS from Meerut and MD Anatomy from UCMS, New Delhi. She has more than 12-year experience of the teaching, and she co-authored of the book Exam Preparatory Manual for Nurses, Anatomy and Physiology. So Dr. Suman, I hand over to you. Please introduce to our chairperson of this session.
Thank you so much, sir. Good afternoon, everyone, and welcome to the session on genetics of male infertility. To begin with, I'll introduce our respected chairpersons. Our first chairperson is Dr. Anita Mahajan, Director Professor Anatomy, Maulana Azad Medical College, Delhi. She has 22 years of teaching experience and keen interest in gross clinical anatomy, embryology, and anthropology, morphological studies. Ma'am has published several papers and organized workshops to impart basic anatomical skills in young anatomists. Welcome, ma'am.
Thank you so much.
Thank you. Our second chairperson is Dr. Praveen B. Iyer, MBBS MD DNB, Additional Professor Anatomy. He's co-director, GSMC FAMER Regional Institute, convener, NMC Nodal Center for Faculty Development, Department of Medical Education. He's member of Bioethics Unit, member of Task Force National Medical Commission, Task Force MUHS, recognized MD PhD Guide for Anatomy MUHS. He has 14 research publications and 2 book chapters in Art of Teaching Medical Students, 3rd edition. Welcome, sir. Our third chairperson is Dr. Dushyant Agrawal. He's Additional Professor of Anatomy, Sub-Dean Examination, AIMS, Jodhpur. Sir is Visiting Professor, Royal College of Surgeons in England, Dublin. His major areas of interest are interactive medical education, radiological anatomy, and cystogenetics. His current research involves, so he has patent designs published and granted, about 5. He has 4 research projects completed and 6 ongoing. He has 26 research publications abstracted, 6 papers in national conferences and 7 in international conferences, and various courses and CMEs, 29, which he has attended. Welcome, sir. Now I request Dr. Dushyant Agrawal, sir, to introduce our guest speaker, Dr. Rajendra Singh.
Thank you, Dr. Suman.
Thank
now
you,
it's my privilege and honor to introduce Dr. Rajendra Singh, and who is a senior scientist as the Male Reproductive Biology Laboratory, Endocrine Division in the CDRI Lucknow. He has published more than 144 publications, 122 research articles. He has edited the 2 books, 22 book chapters they published. Also have supervised the 13 PhD students, and he has also the author of the 2 books which are published. The 1 book is a Male Infertility, Understanding Cause and the Treatment, the Molecular Mechanism in Spermatogenesis and Male Infertility. Can you change the slide, please? Yeah. Here also have some awards which he has felicitated. One is the Haryana Yuva Vigyan Ratna Award. The fellowship which he got, he is the SERB Indo-US Postdoctoral Fellowship from the University of Alabama, Birmingham, USA. He has also have some award, Innovative Young Biotechnologist Award by the Department of Biotechnology, Government of India. Young Scientist Award, Council of Scientific and Industrial Research. Young Scientist Award from Indian National Scientific Academy. Young Scientist Award in Medical Genetics, and also have the fellowship CSIR UGC Fellowship. So we welcome Dr. Rajendra Singh. Thank you.
Can we stop this and then... But slideshow mode में नहीं है ना?
Good afternoon. Please confirm if you can see the slide in slideshow mode.
Yes, sir, we can see the slideshow.
Okay, great. Thanks to the organizers for giving me this opportunity. We have lost about 4 or 5 minutes. I'll just save that and go straight to the presentation. We work on genetics and epigenetics of male infertility at CDRI. And we have been working in this area for the last about 15 years. I thank you, Rakesh and Sarpreet, for giving me this opportunity to speak in front of this August gathering. Infertility is growing alarmingly, and in India, we have about 28 million infertile couples. And we can see the IVF centers blooming all over the country. To just explore one of the causes of infertility, we looked at the semen profile over the last about 4 decades, for which we compared the data from 1979 to 2016. And we found that we have suffered a drop of sperm count by about 26% in India, which has definitely shown declining semen quality. The same is reflected in WHO criteria as well, if you compare the recent WHO manual with the previous ones. There are several causes behind this decline. There are environmental, there are genetic, and other causes which are unexplained. In case of environmental causes, we have poor lifestyle, stressful professional life, and lack of exercise, complexed with the declining quality of the environment. All those contribute to infertility. But yes, there is definitely a certain genetic component as well. And that is what we are working on. With respect to genetics of infertility, the first chromosome that we talk about is Y chromosome. It is one among the smallest human chromosomes. It is made up of about 60 mbph and has merely 78 genes on it. Y chromosome is very unique and very interesting. It is patriarch inheritance, follows the male lineage. It doesn't recombine. It does not carry genes that are essential for life. It is highly variable chromosome with a very unique organization. The first report on Y deletions were published by Tipolo and Giuffardi in the year 1976, where they surveyed 1,117 fertile men and identified a short Y chromosome in just 5 individuals. If you see 5 with respect to 1,000 individuals, it looks like maybe this is not the cause with respect to the percentage. But they were intelligent enough to score that, yes, there is something on Y chromosome, on the longer arm of the Y chromosome. Thereafter, Ma et al. In 1992, they identified 21 infertile individuals having Y chromosome deletions and mapped the YQ region using 30 unique probes specific to this region. And that is how they characterized and called it azoospermia factor region on YQ. Thereafter, Watt et al. In 1996 undertook further dense mapping of Y chromosome using 76 probes and further specifically characterized this region and classified it into AZF A, B, and C regions. These are azoospermia factor A, B, and C. And today, as we know Y chromosome, it has SRY gene on the P arm, which is necessary to make a male, and the YQ region, which has spermatogenic genes classified into 3 broad regions, as I just mentioned, AZF A, B, and C. Y chromosome is well known to undergo a lot of inversions, deletions, translocations, and even replications of the repeats because of its very unique palindromic structure. Here you see the palindromes of homologous sequences that are sitting next to each other, which make it a very, very unique, unstable, and a very different chromosome with respect to others. We started working on Y deletions in the year 2007, and we conducted a 10-year-long study on identification of Y deletions in Indian populations. And we had collaborating centers like AIMS Delhi, obviously CDRI Lucknow, KGMU Lucknow, that was our collaborating center in Lucknow. We have IMS BHU, we have Institute of Reproductive Medicine Kolkata, CCMB Hyderabad, and Bharati Medical Center in Chennai. So this way we try to map almost the whole of India except some parts in the south. And we analyzed about 4,000 cases and 2,500 controls for Y deletions. We found that GR deletions, which is a type of AZFC deletion, those are the most common deletions in Indian populations. This is followed by B2B4, B2B3, and B1B3. These are just the unique names. You may not remember them, but they show actually the parts of AZFC which are deleted in infertile individuals in India. And this picture differs in other countries. It is not exactly the same. For example, in case of Chinese, you do not see that high frequency of GR deletions. And by undertaking a quantitative analysis with respect to sperm count, we established that GR deletions cause about 25% loss of sperm count. Hence, they are major contributors to infertility in India. We also analyzed all published data with respect to Y deletions from Indian subcontinent. And for this, we collected whatever was published in the last several years, and we grouped them according to the groups, according to regions, according to the type of deletions. And we found that Y deletions have been reported in as little as 0.7% or as high as 20% frequency in Indian populations. We also compared the Y deletion data from India with respect to other countries across the world, and we found that we have moderate frequency of Y deletions, that is 5 to 10%, which is comparable to many other countries. On the basis of Y deletion data that generated originally in our lab for the case control study and the data collected from all over India, followed by a meta-analysis, we prepared a Y chromosome deletion detection kit. That is what we designed in-house. This is based on 4 panels of STS markers, which are able to detect microdeletions and partial deletions in sperm or otherwise say blood samples. And this has applications in infertility clinics. This can score sex chromosomal aneuploidies, Y deletion obviously, and this is helpful in recurrent pregnancy loss, sometimes because of the male factor. This can predict the success of IVF treatment, assisted reproduction cases, and this can help in, say, gonadotropin therapy or infertility therapy, otherwise using antioxidants and hormones. This can be useful in deciding about the testicular sperm extraction. In addition to the Y chromosome, it is reasonable to propose that a number of the autosomal genes, they are also essential to assist the spermatogenic genes in carrying out spermatogenesis optimally. That is why we say that they do not contribute to fertility directly, but are important for fertility. And to investigate these causes, we undertook exome sequencing analysis. As you may understand, exome is the whole coding part of the human genome. So we analyzed full exome in about 100 cases of infertility. And on the basis of that, we identified MTHFR, LRRC6, HSF2, and all these genes listed here to be important for spermatogenesis, and these were the mutations in these genes that were linked with infertility in Indian populations. On the basis of this, we further undertook in vitro functional assays on KLK3, MTHFR, DHH, OXB1, and AKR1B1 that regulates a blood testis barrier to participate in spermatogenesis. What I just discussed, they are quantitative causes of infertility. But we also have certain qualitative causes where defects in a single gene, they are enough to cause infertility. And many of these genes, they have been identified on the basis of case studies where there are unique phenotypes. For example, in case of globospermia, characterized by round head in the absence of acrosome, mutations in DPY, SPATA16, PIC1, SPASA1, and ZPBP1 have been reported in globospermia, and single mutation in one gene is enough to cause infertility in these cases. We often find single cases, but rarely we also find families where, say, there are 2 to 3 brothers who all are infertile, and obviously father was fertile. So we have some such families as well, where we analyze the genotype of the children with respect to the father. So I have one very interesting case that we are presently writing that has sperm tail defects. I have not put it here because this is yet unpublished. There are other genes reported in acephalic spermatozoa, acephalic, which is characterized only by tail, or you can say headless sperm. Mutations in SPATA6, SUN5, HOOK1, BRDT, and PMFBP1 genes have been reported in acephalic spermatozoa in infertility. There are other mutations in ion channel genes that result in infertility. There are genes DNH1, CFAP, 65, 69, QRICH2, mutations in which cause exonymal defects. Mutations in septin12, they cause defect in annulus, and their mutations in SEP135, they cause centriole defects. All these cause structural defects in midpiece and tail characterized by immotile spermatozoa as the cause of infertility. In case of macrozoospermia, characterized by large sperm or having multiple tails, mutations in AUKR, RKC have been reported. We have recently shifted our focus from genetics to epigenetics of male infertility, and I will try to convince you why. Say, sperm is generated by shedding a lot of cytoplasm from the round spermatids. And looking at sperm, we feel that this is merely a vehicle of delivery for paternal genome to the oocyte. But this is not so. This is not simply so. So sperm also carries a lot of RNAs. It is very rich in RNAs, particularly small RNAs, and also carries a full layer of methylome on its DNA. So that is what we missed for so many years. And we started working on methylome and RNA in the year 2012, since we had our first project on methylome. And we have realized that it is as important as the basic DNA component. I'll just not talk about this. Say, we know that the first IVF child was born on 25th July 1978 in UK, and till date, more than 10 million children have taken birth using these methods. But many of these kids, they are more frequently prone to developmental disorders in comparison to those born without assisted reproduction. For example, back with Wederman syndrome, Angelman syndrome, Prader-Willi syndrome, Silver-Russell syndrome, they have been reported more frequently in these children. So what have gone missing? What have we missed to understand? To answer that, to find answer to this, we compared methylome in case of fertile and infertile sperm samples. And we found that in a number of genes, there was hypermethylation, and in many other genes, there was hypomethylation in infertile sperm. So what I mean to say is that infertile sperm are not only infertile, they are molecularly abnormal as well. They are molecularly not as normal as fertile sperm. And we undertook further deep sequencing studies using NGS methods on the genes identified by this study. We found differential DNA methylation in GATA3, CRISPR-LD1, EBF3, BCAN, CPV2, SMYD3, KDM4C, OXB1, HLA-DQA1, HLA-DRB6, LPHN3, TP73, HLA-C, which is histocompatibility gene, TCERG1L, and we found differential methylation in almost all SPATA genes. These are spermatogenic genes which participate in spermatogenesis, SPATA4, 5, and 6. And at the same time, we also investigated a number of imprinted genes in for differential methylation, and we found that differential methylation in IGF2, MEST, LIT1, PEG3, IGF2R, CTNNA3, they were all differentially methylated in case of infertile sperm. So how methylation is regulated? We know DNMTs, DNA methyltransferase genes, they establish and maintain DNA methylation. And there is another class of genes, these are 10-11 translocases, TETs, which help in DNA demethylation. So we asked that, is there a general defect in DNA methylation machinery in infertile individuals? For this, we analyzed DNMT3, DNMT3A, 3B, and TET1, 2, and 3 enzymes. And we found that, yes, there was a significant alteration in case of DNMT3A, 3B, and TET1, 2, 3 genes in these individuals, indicating that infertile sperm or infertile individuals in general have a defective DNA methylation process. Looking at this, we asked if some of these epigenetic markers, they could be used as epigenetic signatures of infertility. For this, we analyzed 1680 CpG markers between fertile and infertile sperm, and some of them were validated using deep sequencing by NGS, and we found that they were very good markers to differentiate, as you can see in the heat map on the right-hand side, to differentiate between fertile and infertile sperm. So they have potential as markers of infertility or markers of sperm quality. This data was published in Human Reproduction in the year 2018. Further, we also asked if some of these markers could be scored using peripheral blood sample instead of using a semen sample. For this, we again undertook whole genome-wide methylation analysis in infertile and fertile individuals, this time using blood samples instead of a semen sample. And we found that there were 329 CpG markers that were differentially methylated in the peripheral blood samples of infertile individuals, making scoring of this further easier and applicable to all age groups, wherever semen sample may not be available. And some of these markers were further validated by NGS. I'm not going into the details of these. I have skipped so many graphs and details because remembering the name of the markers is not important. What is important is to understand the overall concept. This data was published in Fertility Sterility in the year 2019. So looking at the picture, what we were doing till now, we were assessing semen quality on the basis of sperm count, sperm morphology, and sperm motility. But the picture is not that simple. The picture is quite complex with respect to the development and inheritance. So sperm is not merely a vehicle of DNA. It also has many other things, and sperm samples should be seen not only with respect to the number and count, but also with respect to the genome it carries, intactness of the genome, the layer of methylome on that genome, and the presence of a number of small RNAs in sperm. I had some slides on small RNA as well, but I have removed them because of lack of time. But we have investigated a lot of sperm RNAs, and some of them are so important that they are perhaps the key to switch on the post-fertilization development. Because this is a pertinent question we keep on asking: what happens? What triggers the development upon fertilization? So the key may be in small RNAs present in sperm. And before we can talk about designer babies using assisted reproduction and other methods, we have to look for better markers, more markers, modern markers of sperm quality that can be used to ensure that we do not, say, introduce more defects in the upcoming generations. And since we have been affected with COVID for the last about 2 to 2.5 years, so we wrote an article on COVID, if it could affect male fertility. This was an invited review article. And I wrote another article for Fertility Sterility on the concept that assisted reproduction in COVID-19 season must continue. This is not, say, life-threatening, and infertility is not among essential services, but in infertile patients, this is quintessential because they have a ticking clock which is going on, and they may quickly lose fertility once they are identified to be infertile. And to summarize the whole of this part, spermatozoon delivers DNA to the oocyte, but also delivers many other things which we have not understood well. Why deletions are the leading cause of male infertility. There are qualitative and quantitative genetic causes of infertility. Epigenome in sperm constitutes an important layer of inheritance. We must not forget that. And there are a number of environmental factors that may affect sperm epigenome. I would just introduce, in the year 2018, I founded a journal that is Polymorphism. So we published genetic studies in this, not only with respect to infertility, but also from all fields. Until date, we have published 8 issues of this. This is coming in PubMed soon. These are my books on male reproduction and infertility. One we have published with Springer, the other one with Taylor and Francis. And the third one, Genetic Testing in Reproductive Medicine, is coming by May of 22. And this is my book, not on male infertility, on issues related to life. So that was out of scientific domain. I would like to thank CSIR, ICMR, SARB DST, and DBT for funding our projects. Would like to thank collaborators, particularly Dr. Satyanarayana Sankwar of Department of Urology, KGMU. We have been working together since 2008, so it has been about 13-14 years of long-standing collaboration. And Dr. Kiran Singh of Banaras Hindu University, and among everybody else, whoever is listening, you are most welcome to collaborate with us as long as it pertains to male infertility. And with respect to infertility, this is my favorite dialogue from the movie Vicky Donor, where he says, infertility ki jad ki hai pata? Kuch ki hai? Stress. It is all stress. In the modern life, it is all stress that is contributing to the rising cases of infertility. And we have to remember that we don't have to just produce sperm. We must also ensure to produce healthy ones. It is not only an aim to have a baby, to have a healthy baby. And thank you very much.
Thank you so much, sir, for this beautiful and interesting presentation and taking us to this fascinating world of genes and sperm. Now I invite Dr. Anita Mahajan, ma'am, to give her expert comments.
Thank you so much, Dr. Rajendra ji, for this very apt and wonderful presentation. You talked in depth about the causes and markers about the male infertility, especially all genetic causes. And you also mentioned that by using peripheral blood smear, we can spot the CPG markers. So that can be included in infertility screening panel also. So this was wonderful, very informative and educative talk. Thank you so much, Dr. Rajendra.
Thank you.
Now I invite Dr. Praveen, sir, to give his expert comments.
Yeah. Thank you very much. I think right from the beginning of the presentation, Dr. Rajendra really managed to keep our attention focused towards what he's speaking. And as he rightly said, that he wanted us to focus on the concept more than the names of the genes and etc. In fact, the first time when I read the abstract of this particular presentation, I was totally lost because there were so many genes that were mentioned here. But, when I have listened to your presentation, Dr. Rajendra, I think you have made an excellent flow of presentation, and I think the concept is well understood by all of us. I have only got one question that I want to ask you. Yes, we focus on finding out the genetic causes for male infertility. And how many centers are available in India to do that? That is one. And secondly, if a genetic cause is found, then is there a possibility of correcting that particular cause? And then what will be the expenditure that will be incurred by the couple or the family to do so?
Yes, sir. First of all, thank you very much. With respect to samples, clinics have some repositories, and we have a repository at CCMB and at CDRI as well. We have about 5,000 samples available with us for various analysis. We have about 150 very interesting cases where we are working on the specific genetic causes to a particular case or a particular family. We have samples where, the sperm tails are coiled, where there are more than one tail, where the head is bifurcated. So we have different samples that we are working on. And coming to the genetic cause and its cost. Say, the first test that we always like to do is Y deletion analysis. And the cost is not much because we have our in-house developed kit. So the cost may be barely maybe 6,000-7,000, not more than that. I mean, within 10,000. And wherever we do not identify anything like a Y deletion, after that, there is only one approach to go for whole genome analysis. And whole genome analysis in our own laboratory costs not above 20,000, and in commercial settings, this would be somewhere between 25 to 30,000.
Now I invite Dr. Dushyant sir to give his expert comments.
Thank you, Dr. Rajendra. It was a wonderful talk, and thank you for enlightening us about the infertility, male infertility, and their causes, genetic causes, and keep us alert all the time presentation. Thank you very much.
Thank you, sir.
Thank you so much, sir. There are some questions in the chat box, which will be forwarded to you. Or you want me to read out the questions in the chat box?
In India,
Would
there are studies done in different parts showing variations in cause of infertility, especially.
So I'll read out the question. What is the most common Y chromosome microdeletion for infertility among AZF, A, B, and C? And is there any specific testing for these?
This is AZFC. Yes, there is a specific testing for AZFC. We have about 3 markers. And for the whole of Y chromosome testing, we have about 16 markers. And I just mentioned the cost is well below 10,000.
Okay, thank you, sir. And next question is, what percentage of infertile patients are having genetic component as the main cause of infertility in India? And are there any studies done in different parts showing the variations in the fertility causes? And which part of India has the higher incidence in the genetic involvement?
Right.
A lot of questions in one.
Right. So with respect to overall contribution of genetic causes, this is roughly 10%. It varies from as little as 1% to 20%, but average is 10%. And the genetic causes in case of infertility, as the reports go, they have been reported more often in southern India. But yes, there are so many other factors which contribute. Sometimes, there is lack of accuracy. Sometimes the sample size is small. I mean, that does not mean that there is definitely a higher frequency in a particular region. There may be other factors contributing to this. And was there one more question?
Is there ways of prenatal assessment of imprinted genes of ART?
Yes, there is, though people are not doing that right now, I mean, till now, but yes, that is very much possible using peripheral blood because we find DNA fragments there. So we are able to sequence the fetal DNA using the peripheral blood sample of the mother. So yes, definitely, it is also possible to score the epigenetic changes in the peripheral blood. Yes, it is possible.
Thank you, sir. Thank you for answering the questions. So with this, we conclude the session where Dr. Singh has given us an overview of not only the structure of Y chromosome, but various genes present on the Y chromosome and the various microdeletions which are seen in Indians. And also especially interesting was the study on the DNA methylation in infertile patients, especially using the CpG markers and possibility of making these as the part of screening panels. Thank you so much, and over to the host.
Thank you, Dr. Suman, for this session. This token of appreciation to our speaker, Dr. Rajendra Singh. Thank you, sir. A token of appreciation, our chairperson, respected Dr. Anita Mahajan, ma'am. Thank you, ma'am.
Thank you so much.
Dr. Praveen Parasubramaniam Iyer, token of appreciation from our team. Thank you, sir. A token of appreciation to our friend, Dr. Dusant. Thank you, Dr. Dusant. And in the last, Dr. Suman, thank you very much coordinating our session so nicely. Thank you very much.
Thank you so much for the opportunity, sir.
So with this, we end this session. Now we pass on the next. That is the next talk of the Dr. Sarabpreet. I handed over this to Dr. Swati Saxena. Dr. Swati is our student. She did MBBS and MD from KGMU Lucknow, and right now she's the assistant professor at Doon Medical College, Dehradun. Her area of interest is the cytogenetics. She published many papers, and she's a member of the SI and the SOCA. And now I invite Dr. Swati, please introduce to our chairpersons briefly and hand over the mic to our today most awaited speaker, Dr. Sarabpreet. Dr. Swati. Dr. Swati. Dr. Swati. Okay, Dr. Swati, I think so is not here. So I will introduce to our speaker, our chairperson. Our chairperson is Dr. Rashmi Malhotra. She is the additional professor at AIIMS Rishikesh. She has more than 14 years of teaching experience, more than 25 publications. She has presented many papers nationally and internationally. She's participated more than 40 workshops and the CME. Her area of the interest is the cytogenetics, medical education, and the gross anatomy. She is a member of the various committee at the institute and various other. So next chairperson of this session is Dr. Vivek Mishra. He is the additional professor at AIIMS Gorakhpur. He is a member of the board of studies of the subject expert and the examiners. He is the member of the National Board of the Examination. He is previously a faculty at the AIIMS Rishikesh and the Jodhpur. He is also he is the expert at AIIMS Rishikesh and the Jodhpur, and also in KGMU Lucknow. Next chairperson is the Dr. Manisha R. Gaikwad. She did MBBS, DGO, and MS Anatomy. She is the additional professor and head of department at AIIMS Bhubaneswar. She has more than 21 year experience of the teaching. She is the examiner of the UG and PG and the PhD. She is a member of UG for UG at Dr. NTR University of Health Sciences, past president of the Anatomical Society of India, executive committee of the member of the Anatomical Society of India in 2017, 18, 2020, 2021, and right now in 2022 also. And now I request Dr. Rashmi, please introduce to our speaker, Dr. Sarabpreet Singh. Dr. Rashmi. Dr. Rashmi?
Yes, sir. I'm just enlarging. Okay. We welcome Dr. Sarabpreet Singh, our speaker. He is MD from AIIMS, IFS and ESHRE certified senior clinical embryologist. He is a senior consultant and chief embryologist at the Artemis Health Institute since 2009. He is director at the Fertilis Academy, which provides online and hands-on teaching in reproductive medicine to medical postgraduates across the globe. The various awards that he's won are Champion of ISAR Award at ISAR Conference 2020, Award for Best Convener, Special Interest Group at Fertivision 2019, Best SID Applied Genetics Award at Fertivision 2020, Best SIG Applied Genetics and PGT Award at Fertivision 2021, Best SIG Applied Genetics and PGT Award at Fertivision 2022. His areas of interest are cryobiology and male infertility. Next slide, please.
This is the only slide. So thank you, Dr. Rashmi.
So we welcome Dr. Sarabjit Singh, and I hand over the sphere. What do we say? As to Dr. Sarabjit Singh.
So now I'm stop my screen. Dr. Sarabjit, please share your screen.
Yeah, thank you, Dr. Rashmi, for that kind introduction. I would like to thank the organizers for, I can share my screen, Dr. Rakesh.
Yes, you can.
So we are running a little late on time.
Yeah, sorry for that. Actually, this is the first day, in any event, first day become the late.
Doesn't matter. I would like to, still, I think I'll take around an hour or so, 50 minutes at least.
No problem. Your topic is you can say this is the key and whole soul of this workshop. So go ahead, take your time.
Starting the topic, and there have been wonderful talks by Dr. Mona, Dr. Pandey, and Dr. Rajendra. It has made my topic much easier because I don't have to go to embryology now. I can straight away start with the embryology part of it. So give me a minute. Let me just set the. So the topic which Dr. Rakesh he invited me, and when we were discussing, he said, why don't you speak on something about embryology, the clinical embryology part of it, what goes on inside the lab. So this was the topic we decided, and we thought we'll give you an overview. We can't go into details of any procedure. It will be a very superficial overview, but we will try to touch upon almost everything. We may not be able to cover everything, but we'll touch upon whatever we can. So the objective of any IVF treatment is the creation of highest quality embryos and healthy children. And it must always remain the primary focus of assisted reproduction treatment. So with this kind of a background, so where are the embryos being created? It's in the lab. It's in the IVF lab. You can't really choose oocytes. Definitely you can choose the base sperm. There are techniques which are enabling us to do that, though they are more or less hypothetical, not proven, but yes, we can still screen and select sperm. But oocytes, whatever is handed over to us, we have to make the best of it. So IVF lab should be very nicely planned and very nicely designed so that there is no iatrogenic damage which is happening. Like Dr. Rajendra spoke about epigenetics. So there should be no epigenetic damage that should be taking place. And we should be very goal-oriented and result-oriented when we are doing ART or IVF treatment. It is said that your IVF program is as good as the lab which supports it. So the lab is the heart and soul. It's the sanctum sanctorum of any IVF unit. So a lot of money goes in, a lot of planning goes in, a lot of minute details we have to pay attention to while bringing up the IVF facility. So that I'm just trying to emphasize that it's a very important part of the whole IVF unit. I would like to touch upon these keywords before we move on to the actual discussion. All of you must be knowing most of it, but I would still like to go through it. IVF is in vitro fertilization. ICSI I will call for intracytoplasmic sperm injection, where we go inside the ovum and inject the sperm. OPU and ETA is ovum pickup, where you pick up the eggs from the follicles, ovarian follicles. Embryo transfer is depositing the embryos which we have created in the lab in the uterine cavity of the female. IUI is intrauterine insemination. ART is assisted reproduction technology. Incubator is a device. It's like a mini computer which controls pH, CO2, temperature, everything, and it's just mimicking the uterus of a lady. Or we culture embryos in it, and we try to grow embryos in it. So it's like a fallopian tube cum uterus kind of environment we create in this. Media, we have two kinds of media in IVF. One is media which is used outside the incubator, that is HEPIs or MOPs. These are names of buffers. HEPIs or MOPs buffered media. which we are using to handle the oocytes and sperm outside the incubator. That is flushing and gamete handling media, sperm preparation media. And then there are a set of medias which are for prolonged culture. They are bicarbonate buffered medias like fertilization, cleavage, blastocyst. You used to fertilize, you used to cleave the embryo and then make a blastocyst. So these are bicarbonate buffered medias for prolonged culture inside the incubator. Then there is a term known as denudation, where we kind of decolonize or decumulase. We remove the cumulus cells from the oocyte cumulus complex or cumulus oocyte complex, which is known as COC. And finally, another term which we come across is cryopreservation or vitrification, which has replaced cryopreservation now as a term, because vitrification is something which we are doing for embryos and gametes also. So vitrification is a sort of technique where we freeze the embryos. So assisted reproduction technology, a Center for Disease Control and Prevention, CDC, it has defined ART to include all fertility treatment in which both eggs and sperms are handled. And it includes ovarian stimulation, which is a gynecologist's job, and they stimulate the patient, and then ultimately the patient comes to the lab after the oocyte retrieval is done. Intrauterine insemination, in vitro fertilization, then ICSI, cryopreservation, and pre-implantation genetic testing. So all this spectrum of treatment, it comes under the broader category of ART. So if you look at any IVF unit, it has got certain regulations and certain criteria before when you're trying to bring it up. So minimum physical requirements have been given. It has been divided into a sterile and a non-sterile area. So we are primarily focused in the sterile area, and amongst sterile area, we have the OT, we have the room for embryo transfer, but our focus will be embryology lab or the IVF lab. So if you take the case of an IVF OT, this is how an IVF OT looks like. This is the OT, and beyond OT is the lab. Like this door goes in the lab. So this is the minor OT, and we can enter the lab when we move into this. And this is what the lab looks like. And these are the essential components of a lab. This is the laminar flow hood, which is the main workstation where gametes are handled, vitrification is done. All the key processes are done on the laminar hood. It has got a heated stage, it has got microscopes, and it has got all the consumables and disposables where you do it. Then you have got incubators. There are broadly two categories of incubators, a box incubator and a benchtop incubator. So both the incubators are being shown. And then you have the ICSI machine or the micro manipulator, that is microscope plus apparatus for micro manipulation. So this is the ICSI machine. So these are the three broad equipment which you require. And there's a lot of other small things which make the most of it. But these are primary things which you need to maintain day in and day out. And besides this, there are many other factors which I'll just touch upon. So again, if you see, this is the laminar flow hood or laminar airflow. This is the chief workstation. Ovum pickup, embryo assessment, embryo transfer, everything is done in this laminar flow hood. It has got a stereo zoom microscope, and the stage is heated. So stage has to be maintained at 37 degrees, which is the body temperature of most of the times, most of the procedures. Then there is a concept of macro and micro environment. See here, the lab environment has to be maintained in a particular way. Otherwise, the instruments will not function, neither the gametes will survive, neither the embryos will be formed. So the concept of macro environment, I'll be briefing you about. And micro environment is the environment which is in the incubators. That is the a very tight control over pH, temperature, CO2, etc. And we have got air purifiers in the lab, which help. They are like nowadays with so much of pollution all around, people having air purifiers in their homes also. But these are different. How these are different, I'll come to it later on. And that is the ICSI workstation, which I showed you before also. So if you look at the embryonic development, I think most of people here are anatomists and they understand embryonic development better than me, because I have left anatomy since almost 14 years now. So fertilization, formation of zygote, cleavage, compaction, decompaction, recompaction, cavitation, blastocyst, expansion, herniation, and implantation. These are the processes we are interested in. So pre-implantation is our field, and post-implantation is all, which is the core embryology is all about. So mainly it is pre-implantation which we as embryologists are interested in. So any culture system or any culture media should be able to support, it should be able to maintain the viability of gametes. It should be capable of decreasing the embryonic stress by maintaining temperature, pH, and CO2. And subsequently, it should ensure normal embryonic development by ensuring fertilization of oocyte, cleavage, genomic activation, compaction, cavitation, and expansion, and ultimately implantation has to take place. Only then it can, give rise to good pregnancy rates. So this is what a culture media is all about, but we can't limit ourselves to the support to culture media. There is a concept of culture system, which not only encompasses the culture media, but it takes into account various other things, which we'll touch upon in the later slides. So embryo culture is more than culture media. So what all does it include? It includes the interactions that exist not only between the embryo and its physical surroundings, but between all the parameters in the lab. So what all parameters are in the lab? We have got plastic dishes, we have got oil, we have got oxygen concentration, light, temperature, pH, again, so many things are there. And there was a study which said that total 175 factors are there which have to be controlled in the lab to ensure optimal embryonic development. And these include air quality, even the pipettes, the plasticware, stages, their temperature, microscope, light, culture media, culture dishes, protein supplement, culture oil, incubator gas, temperature, CO2 partial pressure, O2 partial pressure. I mean, the list just goes on. There are a huge number of factors. You have to really micromanage the things. This is another slide which, again, which helps in understanding the same thing. You have to control the incubator environment, whether it's a box or a bench top. You have to maintain pH, temperature. You have to control the volatile organic compounds. The gas supplies you have to ensure, humidity you have to maintain. Again, air quality, when you talk about the air quality, the air handling units should function well, the filters should be in place, VOCs should be at the minimal, room temperature and humidity should be ideal for embryonic development. Culture media, again, you've got a lot of difficult choices to make when you're selecting a culture media, because and you really can't experiment because you're trying to create life. You cannot experiment on a patient's embryos. So you have to, you should be very sure about what you are going to use. So many factors here: osmolality, pH, temperature, size, position of droplet, what kind of culture, single versus group culture, and number of things are there. So I'll not go into the detail because I don't have time to go into the detail. I'll just like to tell you that a lot of quality control and activities go on in the lab, where we have to monitor each and every factor, each and every parameter every day, and some almost every month, and some can be monitored every 3 months also, depending on the lab performance. And you have to make a note of it. And it's a religion, actually. It's not about your work and your it's not like any other job. It's a religion. You have to do it very, very carefully. So this article came in 2020, and it was known as the Cairo Consensus, in which most of the leading scientists of the world got together, and the bottom line which they gave was, there is only one thing that is truly important in the IVF laboratory: everything. So they said that everything, every minute detail is important. Everything is important. You have to maintain a logbook of many things. I mean, so if you read the Cairo Consensus, which are the guidelines on IVF culture conditions, you will come to know that it has a lot of material. It is almost 30-40 pages of article, and I think everybody present here must go through the Cairo Consensus. It's freely available online. So just to recapitulate, if I draw a line here, this is stimulation, patient, and then the patient, then you retrieve the oocytes here. So OPO is done here, and then you have to assess the oocyte quality, and then the lab work starts from here. And in the lab, so many things are important, like air quality. In our country, the number of embryologists are not too many, and especially the well-trained embryologists are actually, maybe not even 50 to 100 in the whole country. And then the number of incubators is important. If you come to the culture system, then so many factors like oil overlay, gas phase, tissue culture supplies, number of drops, number of embryos. I mean, so many things are important, which when you come into the practice, you will begin appreciating. So these are all the critical elements of an ART treatment cycle. So when we talk about culture system, it has got culture, its components are culture media, culture conditions, culture protocols, embryo assessment, and quality control. So it's not possible for me to touch upon everything, but we'll just touch upon culture conditions and quality control. I'll just touch upon these two things. So when I talk about culture media, it's specialized for each procedure, as I've explained before at the start of my lecture. But when you talk of culture conditions, culture conditions should be optimal to optimize embryonic development and pregnancy rates and implantation rates. And when I talk of culture conditions, I've got a micro or a micro culture conditions or a macro culture conditions. So micro environment, which is the environment of the incubator, and the macro environment, which is the ambient or the lab environment. Only with proper tight control over these, we can ensure consistent culture conditions, reduce environmental stress, and optimize the development of embryos. So when I talk about the macro, we have got a lab design. It all starts with the lab design. If your lab design is wrong, you can never achieve proper and optimal pregnancy rates. Air quality is very important. The pressure has to be positive pressure. The lab has to be at a positive pressure so that the lab air goes out and nothing from outside comes in, because outside air might be contaminated. Air changes should be there. At least the air, it should be at least 16 to 20 air changes per hour should be taking place in the lab to remove any contaminants which have come in, because you're trying to create life here. You are mimicking human body, human uterus here. So you can't allow contaminants from outside come in. Humidity has to be maintained, and particulates have to be kept at a minimal. More particles or particulates have to be kept at a minimal. When you talk about the micro scale, incubator temperature, oxygen, pressure, CO2 pressure, pH, which results in the right pH, osmolality, and again VOCs. These are the 6 very important critical factors which have to be controlled, and not more than 0.5% variation is allowed in such factors. So I'll just touch upon air quality and temperature just for the reasons of explaining things. So it is said that the particles between size 0.5 to 5 microns in an IVF lab should be less than 3.5 lakhs. So less than 3.5 lakhs, 0.5 to 5 micron airborne particle, and this is known as a class 10,000 lab. So it is said that if you achieve a class C ambient, then you can achieve class B in the incubator and the laminar. So if your ambient air is good, you can achieve excellent air in the incubator and laminar hood. Otherwise, if your ambient is bad, you can, because everything which is ambient goes in the incubator, it goes in the laminar. It's impossible to create optimal environment if you don't take care of the ambient air quality. So we are talking about class 10,000 and class 100. Class 10,000 in the lab to achieve class 100 in the laminar and incubators. So microorganisms, these are the guidelines by Cairo consensus. So they say that microorganisms should be less than 10 colony forming units. VOC is less than 500 gram per meter cube. Air changes, at least 15 air changes per hour, as I explained. Temperature should be between 20 to 24 degrees, depending on the region. Humidity between 40 to 45%. Overpressure, again, it should be at least 40 to 50 pascals. And for achieving this, we have got various, we have got air handling units, and for achieving this, we have got air filtration systems. We have got air handling units. Examples are centralized heating, ventilation, and air conditioning unit, which you see in various malls and other OTs also. But IVF has got a particular kind of HVACs with their own specifications, which not many companies manufacture. So this has to be kept in mind. Some people use compact filtration systems, and some people do use portable filtration systems as your home air purifiers, but they work at a different level. So I can't go into the details. I can just tell you about the basic filtration system. So like in your home air purifier also, we have got a pre-filter which takes care of the bigger particles. And then we have got an activated carbon and potassium permanganate filter, which takes care of volatile organic compounds. And finally, the air is filtering through UV charged HEPA filters. The UV light will take care of microorganisms, and HEPA will not allow anything which is more than 0.3 microns to pass. But yes, COVID virus is much smaller and it can easily pass. So the cost of filter is inversely proportional to the HEPA filter saturation. So that is about the filter arrangement. This was a study way back in 96 and 97 in which they were just trying to measure the pregnancy rates or implantation rates against the air quality, and they found that when they fumigated the lab or the vicinity of an IVF unit, then the pregnancy rates and implantations rate, they went down drastically. And then again after some time the pregnancy rates recovered. When they changed a new filter, when they put a new filter which was maybe inferior in quality, then again the pregnancy rates went down. Then they again changed the filter and the pregnancy rates went up. So this just goes on to show that the air quality is extremely important for the success of an IVF unit. And actually we spend at least not less than 20 to 25 lakh rupees just to maintain this, maintain this air quality around the year. So this is the kind of investment and dedication which goes in the air quality. Touching upon temperature now, two physical things I wanted to touch. So for maintaining a pH of 7.3 in HEPIs or MOPS buffered media, we need to maintain a temperature of 37 degrees on the stage, which will ensure the spindle integrity. So we are all anatomists here, so we understand the meaning of meiotic and mitotic spindle and how to maintain it. So this was a study, a landmark study by Wang et al, and they with the help of polarized microscopy, they focused the meiotic spindle, and they found that after just 90 seconds of change in temperature or cooling was done, the spindle density, it went on decreasing, and in 5 minutes the spindle was gone. So this just goes on to show how important it is to maintain the temperature, because if spindle is gone, the oocyte is never going to divide. But they again reverse the temperature and they could find the spindle coming back. This is the first part of the study. The second part of the study, again they did the same experiment, but the conclusion was that if the degree of change of temperature was too fast or prolonged beyond 10 minutes, then it is very difficult to recover the spindle. You may recover the spindle and you may not recover the spindle, but then again, the spindle may not be functioning correctly. It might give rise to aneuploidies and cleavage errors, division errors. So spindle assembly is temperature and time dependent. So do not expose your oocytes to changes in temperature for no reason. So again, the same thing, human microtubules are highly thermosensitive. So maintain temperature. Very tight control has to be there. Again, this study which assessed the effect of follicular fluid temperature at egg retrieval. The follicular fluid is the fluid which is aspirated from the ovarian follicles, and they found that when the temperature was between 36.4 to 36.9, the implantation rate was 40%. Whereas if the temperature was less than 36.4, the implantation rate went down to 34. And when it was more than 37, it went down to again 22.9. So again, every process in the lab, see, follicular aspiration, all oocyte and embryo manipulations, embryo transfer, every process in the lab has to be maintained at a very strict temperature of 37 degree plus minus 0.1, I'll say, or 0.5 maybe, not beyond that. Then you probably will lose the oocyte and the embryo. And I always say that a lot of embryo success is about embryo handling, the way you handle the embryos and the oocytes, rather than so many other things. They are also important, but the way you handle, the more quickly you handle and the more seamless you are in your operations, the better it is. Again, the importance of ambient temperature control. We had discussed about ambient air quality. So they said that room temperature affects laboratory instruments and equipment on observational study. And here they found that the microscope stage went up with the room temperature going up. So the room temperature has to be controlled. All the equipment are designed to function at a particular room temperature. You cannot sit in Kashmir and maintain the temperature at 4 degrees. You have to still maintain the temperature at 25 degrees only. Only then your instruments will be functioning optimally. Or you can't sit in Rajasthan and you say that the outside temperature is 50 degrees, so your incubators are going to just blow up. So we have ourselves had in one of the labs which I was consulting for, I found that the incubator actually went around 40 degrees when the ambient temperature was not controlled. So we lost all the embryos there because the doctors will simply, just to save money, they'll switch off the ACs when we went outside the lab, and when we used to come next day, we have to see that the AC is off and the temperature is going up. So ambient temperature control is extremely important. Again, just briefly, we'll touch upon this before moving to the workflow of an IVF lab. So IVF lab maintenance has to be done in 4 broad categories in which we maintain the lab. We have to maintain the environment, which I showed you about the macro environment, ambient air quality, temperature, etc., humidity. Equipment, all the equipment, incubators and laminar and all the machines. Then you have to have a tight control over the lab procedures also. You need to have SOPs, standard operating protocols defined for all procedures, and accordingly, and then you have to choose your contact materials very, very scientifically, because these are the things in which embryos and oocytes and sperms are coming in contact. So if you don't choose them wisely, and they should be absolutely non-embryotoxic, non-gametotoxic. So if you don't choose them wisely, then you might be simply, inducing lot of unwanted changes in the embryos. Epigenetic changes may happen, and the embryo may not even survive. The sperms may not survive. So everything, small micromanagement is required. So it's not possible for me to go into the details of all the 4 heads, but I'll just generalize by saying that standard operating manuals for each of the procedures ensure that no mix-up of embryos and gametes takes place by labeling all the tubes, dishes, and pipettes. Everything must have a double marker, the name of the patient, maybe the date of birth of the patient, those things, at least 2 markers. And all pipettes should be immediately discarded after use. So there is no chance of a mix-up. The moment you think of saving money, you lose it at the same time. You can't keep storing things. And, I've seen people labeling pipettes. This belongs to, Reshma, so I'll use it again for Reshma. So it's all a mix-up. Don't use the same thing again, just discard. Sterile areas should be checked for contamination. A logbook has to be maintained for temperature, CO2, humidity. Or these can be digital or these can be manual. So nowadays, digital things, real-time monitoring is done. Everything gets fed into your computer on its own, and you just have to come and monitor, or you can sit back at your home and monitor on an iPad or your computer. And periodic calibrations of all the instruments and record keeping of such calibrations is extremely important. So you have to label the dishes, patient name and ID, or the name of the couple and an ID, and you have to label which dish this is. So this is a culture dish, which is a cleavage dish. That is, it will support the embryo development from day 1 to day 3. A blast dish will support the embryonic development from day 4 to day 5. And then even on the incubators, you can write the name of the patient. So it will help you identify. And you will, if you need Ritu's embryos, so you will be opening only 3rd cabinet. You don't have to search all the cabinets, and that preserves the incubator environment for a longer time. So you can't open and search. It has to be, you should be knowing it before. See, this incubator has this patient, and that kind of incubator management has to be there. So on a daily basis, you have to monitor CO2, VOCs, osmolality, temperature. Particle count can be done every 3 months. Microbial count again every 3 months. pH 3 months. Microscopes, etc., which are source of lights, they have to be cleaned almost daily. So a lot of daily QC has to take place, and these are the instruments which help us in for a daily quality control. And if they are in-house, nothing like it. Otherwise, at least some things are mandatory and you should be having in your lab, and for this you can outsource, and the company guy can come and do it for you. What we have done is, this is a manual way of quality control. We use an attendance register, and daily we are monitoring CO2 is okay, temperature is okay, humidity, water is being changed, decontamination is being done. All the instruments you can just write down, and you can simply go on ticking or recording whatever observations are there. This is another way of a good quality control. Indigenous way. We use this fishbone kind of diagram for every patient. So we exactly know that these are the lab conditions, temperature, quality, all the air quality, everything is in place, microscope stage. And then we take the case of contact materials, OPU needle, culture media, and we go on writing their batch numbers also. So whenever anything goes wrong, technical issues where they're all under control, procedure elements, at what time what was being checked. So wherever we think there is a deviation in the inputs, only then it will lead to poor embryonic development. If everything is still here is nicely controlled, then you should be having good embryo development. But again, there are a lot of inherent and genetic causes to poor embryonic development and poor implantation. So those cannot be ignored. But yes, these are the factors which you need to control. And you can have this printed for every patient, and you can go on tick marking or recording your observations. Now, having told you about the quality control, so how do you measure your quality control? So it is said that you can neither improve nor you can measure. You cannot improve. No, you cannot monitor what you cannot measure. So you need to have. There are 18 key performance indicators for an IVF lab, which you need to measure. Only then you can, see whether your lab trends are going up or they're going down or they're plateauing. So every indicator has got its own specific inference, and then you have to, measure these, monitor them over a period of time, and only then you can understand if there's anything going wrong in the lab. So take the case of ICSI damage rate. You're doing ICSI and the eggs are getting damaged. So if less than 10% eggs are getting damaged, it's perfectly fine. But if more than 10% eggs are getting damaged, then there is something wrong with the person who is doing the ICSI. Or so you go back and send the patient for training again, and that is how you can sort it out. It is said that even the best ART unit in the world will occasionally have low periods of poor performance, and then so this is quite inevitable to have phases in which you're doing very well and phases in which you do badly. But overall, at the end of the year, all your key performance indicators should be at a basic minimal level. If you're not able to maintain that, then you need to improve. So now we will take a 2 minutes break, and then we'll go on to the workflow of an IVF lab.
Thanks, sir, for the break. Everyone is need a break in this winter.
So Rakesh, you tell me when to start. I'm sitting here only.
As soon as possible, because already we are so much delayed.
Okay. So now after this, another few slides, but then there
After
are
that you can
some videos.
After that you can move on the video demonstration in your lab.
Okay. So I think let us start with the workflow of an ART lab or an IVF lab.
Yeah, sure.
So embryonic development, I think people sitting here, they understand much better than I understand. But again, this is at day 0, we are retrieving the oocytes. So the day of insemination or the day we are doing ICSI, that is day 0. On day 1, that is around 17 to 18 hours post insemination, we expect a 2 PN, that is first PN and male pronuclei and female pronuclei. So we expect a 2 PN in cases of normal fertilization. In case there is an abnormal fertilization, we can have a 3 PN in which 2 sperm have gone in. So you have to assess for embryonic development. That is, now I'm coming to what we are doing routinely in the lab, and we are discussing embryonic assessment or embryonic development. And on day 2, you expect 4-cell embryo. Day 3, you expect around 6 to 10-cell embryo. And day 4, we find morulas in which cell boundaries have merged and it is like a big clump of cells. Day 5, cavitation starts and the embryo is differentiated into outer cell mass and inner cell mass. So trophectoderm and inner cell mass. So this is the basic embryonic development. And with this background, I'll move on to the things which are happening in the lab. So on day 0, we are doing ovum pickup or ovum retrieval, where the ovum is retrieved transvaginally through ultrasound guided aspiration is done of the follicles, and the oocytes retrieved are incubated. So I'll show you a video where show you a video in which a needle is going in and ultrasound guided, and this follicle is aspirated. Then the follicles are transferred to the embryologist. So this is another video in which see the follicles are being aspirated in a round bottom tube. So this is now screened for oocytes, and the oocyte cumulus complexes, they are smooth dark circle which is surrounded by translucent cumulus cells. So when you find an oocyte looking like this, see, so this is a translucent silverish white kind of cumulus cells are seen, and they pick it up and then they transfer it to another media where these cumulus complexes are washed and rinsed, and then they are put in the incubator for some time. So now they have collected and now they're moving to the next. So this is how we wash the oocytes. In the side well, we'll wash the oocytes and then transfer them to the center well once they are nicely rinsed and they're free of blood. See, now these are the cumulus oocyte complexes, and they can appear. So they can appear either they can be mature, in which we've got a radiating corona and cumulus cells, or it can be slightly adherent and cumulus cells are expanded, but they're not as expanded as the first picture. So these are almost mature, and the immature ones are having very tight cumulus, which is tightly adherent and looks very tight and difficult to denude also. Then they are incubated in the incubator, whatever kind of incubator you have, you just incubate in the incubator. And while you are incubating the oocytes for 2 hours, 1 to 2 hours we incubate, and simultaneously we ask the male patient to ejaculate and the sperms are prepared. So Mr. Sehgal will be demonstrating about the sperm preparation techniques, and Mona has already briefed you about the sperm components and those things. So we'll leave it to them, and semen sample can either be prepared by simple washing, swim up, or density gradient. We'll see it in the workshop now, how Mr. Sehgal is going to demonstrate. And hopefully, as promised by Dr. Rakesh, we will be having a physical workshop in somewhere in March when COVID is gone, and we will demonstrate you all the techniques physically also.
Sure, sir.
We have reached this step. So after incubation, now the person is set for IVF. Now we have to do an IVF. And for doing IVF, we take the oocytes and inseminate the right amount of sperm solution, prepared sperm sample in the dish. So either we can go for a long incubation or a short incubation. These are the technical terms which you will understand once you kind of do the hands-on physically. After incubation, we denude the cumulus oocyte complexes, and on day 2, 3, and 5, we assess the embryos, grade them, and go for embryo selection. So how do we do IVF? So this is an center well dish in which we have got 5 oocytes, and to this we add sperm preparation in the ratio of 20,000 to 50,000 motile sperm per oocyte we are adding. And the dish is kept overnight in the incubator. And this is how it looks like. See, the sperms are, getting close to the cumulus oocyte complexes, and ultimately they are going to penetrate. Only one sperm is going to penetrate, and if more penetrate, then it leads to polyspermy. So this is the beautiful image of very high resolution image of how the sperm is entering the oocyte. See, this is the sperm. It is suddenly sinking in, and ultimately it enters the oocyte. It's a beautiful video which I got from internet. Now it has gone in. So now this was about IVF. And when we talk about ICSI, in ICSI, again, the oocytes are retrieved, they're incubated. Simultaneously, we can have either ejaculate, which we have to prepare, or a testicular sperm sample, or testicular tissue, which we have to prepare, or an epididymal sperm. So these are retrieved surgically. So this is part of surgically retrieved sperm, or surgically retrieved sperm, which is TISA and epididymis sperm, testicular and epididymal. And ultimately, we have to prepare all the tissues and all that. These have got different ways of preparation. And once we are done with the semen preparation, we can go ahead with our ICSI. In ICSI, we denude the eggs first before, in IVF, we are inseminating and then denuding. In ICSI, we are denuding them first, assessing for their maturity, and only the mature ones are taken for ICSI. So you have incubated the oocytes in the appropriate media, and this incubation helps in cytoplasmic maturity. And then you have to denude after 1 to 3 hours of incubation. You have to denude the eggs. So this is how what a normal cumulus oocyte complex looks like, and this is how a denuded egg looks like. So now you can see the polar body, perivitelline space, oocyte, zona pellucida. You can actually grade an oocyte. There are various methods of grading an oocyte. So but you cannot grade a cumulus oocyte complex. You can grade, but then it's difficult to say whether it is mature and what kind of anomalies, extracytoplasmic or cytoplasmic, it has got. So ICSI has its own advantages and IVF has its own advantages. So after denudation, this is how we make the denuding dishes. These are the hydase drops, the same hyaluronidase media which sperm head acrosome has got, which breaks down and digests the cumulus cells. So the same media we derive from animal sources, and we make drops of that media and denude the oocytes in this media. So it digests the cumulus and corona cells, and then it is fit for insemination. So this denudation has got two parts. First, we expose the complexes to enzymatic denudation and then to mechanical denudation. So this is just a small video which we made. So you have to keep on agitating or keep on aspirating and releasing in the hydase media. So it will help in digestion of the cumulus cells. See, the cell masses are becoming small, and you can see small black oocytes now in places of big cumulus cells. So after you have the small black masses or the oocytes with you, that means the cumulus is not there, and then you can take them to another dish where you can expose it to. See, now this is a mechanical denudation. So again, you can see some cumulus is being withered off, but with the help of pipettes, 170 microns and 140 microns. So this is how we are denuding the oocytes. So after the oocytes are denuded, then they are evaluated for maturity. So ideally the ratio should be 85% should be mature and 10% should be M1 and 5% should be germinal vesicle. A germinal vesicle has a germinal vesicle in the ooplasm. M1 has got no characteristic, whereas M2 or metaphase 2 oocyte has got a polar body. So this is a fertilizable, M2 is a fertilizable oocyte morphology, which you do ICSI on, and finally the embryonic development takes place. So now, since I've mentioned that we are preparing testicular tissue also, so this is how testicular tissue looks like when it is obtained from a man's testis. It's convoluted seminiferous tubules, and then we kind of, we tease it down and we cut it, and then so that the sperm can actually move out of the tubules, convoluted tubules. So this is how a sperm looks like in convoluted tubules. At times it will be motile, but mostly it is immotile. And so these are the sperm. And this is the clinical sense which you develop over the years, that which sperm has to be taken. At times you will, if you're lucky, you will find some motility. If you're not lucky, you will not find any motility. And then you have to, choose based on your experience, and ultimately fertilization will take place if you're choosing a live sperm. So now I'll just demonstrate the process of ICSI. So this is how an ICSI dish is made, and these are all herpes buffered media, and in between there are PVP drops where sperm is kind of introduced in this PVP drops, and this helps in slowing of the sperm, and it is easy to catch it. So why do you need to catch it? Because you have to hit the tail and immobilize the tail for better control as well as for oocyte activation. When you hit the sperm tail, oocyte activation factor is, see, he has hit in the tail, immobilized. Now he has aspirated in the pipette, and oocyte is denuded and fixed. Polar body is at 6 o'clock position or 12 o'clock position. So everything has got its own importance. Everything cannot be told in one class. Now the sperm is going in. The sperm will again be aspirated along with the ooplasm. Once it is aspirated, see, it is now being aspirated. And again, the ooplasm is being deposited along with the sperm. So now this aspiration is again important. Hitting the sperm, immobilizing the sperm is again important. So every small detail is important. This is a schematic diagram for IVF process where oocyte, and this is surrounded by sperm. It will penetrate on its own, and things are nice and cool. But in ICSI, there are a lot of technical things take place, and you have to go in the oocyte and introduce the the sperm. So again, the treatment choice depends on the sperm concentration and motility. If the concentration is more than 10 million, there is no female factor, go for IUI. If it is 1 to 10 million, say 5 to 10 million motile count, go for IVF. If it is less than 1 million, you have to go for ICSI. So there is no way you will not go for ICSI. If it's a testicular sperm, you have to go for ICSI. Epididymal sperm, you have to go for ICSI. So absolute indications of ICSI are oligozoospermia, like Mona has explained so many times about oligozoospermia, actinozoospermia, tereto. Dr. Rajinder spoke about globozoospermia, repeated IVF failure, anti-sperm antibodies. If the oocytes are very few, then you don't want to, because ICSI rates are definitely better than fertilization rates are definitely better than IVF rates. But again, it's your choice. If the count is low, then you might go for ICSI again. Surgically retrieved sperm, because the sperms are not moving, so how can they penetrate? You have to, aid them and help them, deposit in the ooplasm. These are some of the absolute indications of ICSI which you have to follow. So now we have covered I've combined both the charts now, IVF as well as ICSI. So we have introduced the sperm in the ovum, and we've done the embryo assessment and embryo grading, and now we are fit for embryo transfer. So either you can go for embryo transfer direct, or nowadays there is a trend to freeze all the embryos or vitrify all the embryos and then prepare the endometrium again and transfer them in the uterus at a later date. Those are known as freeze all cycles. Or you can do a pre-implantation genetic screening or testing on the embryos and then select the best embryo genetically and then transfer it. So this also involves vitrification, because genetic results also take time, and in the meantime you have to kind of freeze the embryo till the time your reports are available with the doctor, and then you can choose the right embryo. And all the steps need a very strict quality control and quality assurance program running in the background, and all the KPIs or key performance indicators have to be maintained. This is just a video of how embryo transfer is done. The embryos are assessed, they are selected. And once you're sure that these are the embryos which I'm going to transfer, you load them in an embryo transfer cannula or embryo transfer catheter, which is attached to a BD syringe. And then once the embryos are loaded, it is passed on to a clinician who deposits it in the uterus. And in the uterine cavity, you have to deposit it around 1 to 1.5 centimeter proximal to the fundus. See, it's going in now. And this is the uterus. And now she is deposited. And yeah. And now she will withdraw. And this is a better video on the right side. See, the catheter is going in. We're trying to negotiate in the cavity. So once we are able to go in, we'll deposit the embryos at the right location. See, now the embryos are going in along with the media. And see, this splurge of media was there in the uterus, and now they've removed the catheter. So coming to the last few slides now, I know it was a very exhaustive lecture, but I really couldn't help it. I have to tell you everything. So now cryopreservation techniques are basically two broad categories: slow freezing and vitrification. In slow freezing, you slowly cool the embryos and then take it into the liquid nitrogen at minus 196 degree. In vitrification, you cool the embryos and suddenly plunge them into liquid nitrogen. So slow freezing is you are going down a hill slowly and slowly. Vitrification, you are directly jumping from the hill on the ground, something like that. So slow freezing is obsolete now. Vitrification is giving the best results for embryos and oocytes. So everybody is doing vitrification. It's a cheap technique, but it requires more time and more attention. So when you talk about vitrification or cooling cryopreservation, then you must understand that the ice crystal looks like this. It's very spiky. So any ice which will form, so when you're freezing at minus 196 degree, whenever you're going below 0 degree, it will definitely introduce formation of ice. But again, the bottom line is that when you are doing vitrification, you have to prevent the formation of ice crystals. If ice crystals are formed due to any reason, it will lead to damage of the embryo. So this is a nice graph which shows the nucleation temperature. It says that from minus 30 degree to minus 130 degree, This is the temperature of nucleation. And if you can pass to this temperature quickly, then you can prevent ice formation. And below minus below minus 130 degree, it is the glass transition temperature of water. That is below minus 130 degree. If you can manage to prevent ice formation till minus 130 degree, then below minus 130, it will directly convert into a glass. So no ice will be formed. It will directly convert into glass. So vitreous in Latin, it means glass. So vitrification means glass-like formation, you know. So when you form a glass, obviously the ice is not being formed and the cellular architecture is preserved for a longer time, and it's a much safer technique. So when you're doing vitrification, you have to prevent chilling and osmotic injury. So I can't go into the details right now. So the steps broadly are, for any cryopreservation process, add cryoprotectant, cool cells to minus 196 degree. Then again, when you have to use them, you warm them and you remove the cryoprotectant. In the meantime, the bottom line is minimize ice formation, stabilize membranes and intracellular structures. So these are very broad terms, but have a deep meaning. This is how we do vitrification. We, after proper equilibration, we deposit the embryos on a straw at a minimal drop size and then plunge them into liquid nitrogen and keep them in the appropriate cryo can. And we have to document where we are keeping which patient's embryos, and everything is, the documentation is also very important. So again, just how to minimize the drop size, because the smaller the drop, better the results of vitrification. See, after depositing, he's aspirating the excess fluid. See it again. See, after depositing, it's a very minor fluid, but again, you have to aspirate whatever little media you are depositing, because the lesser the media, better the results of vitrification. Then you directly, after after you've done vitrification, you directly load it on the cryo device or a straw. See, he is doing the steps of vitrification, and now it is being loaded on a cryo straw. So this is a straw on the left side. There is a straw. It has been loaded and then directly plunged. So there is no slow cooling going on. It's directly going into liquid nitrogen. It is shaken to bypass the Leidenfrost effect. And when you're warming the embryo, again, warming rates are even more important than cooling rates, because during warming, again, you are passing the same temperature range, minus 130 to 230, where ice formation can take place. So you have to be very quick during warming also. And the warming rates are even more critical compared to cooling rates, because the chances of ice crystal formation are more during warming compared to cooling. This is how they are warmed, they're located, and then see the junior embryologist is doing, and he's directly, from minus 196, he's going to 37 degrees. Okay, another thing which we do very commonly in the lab is we do laser assisted hatching, where we hatch the zona. For doing a PGT or a pre-genetic analysis, we have to pull out a blastomere. So how do you pull out a blastomere? You have to, go through the zona. See, now with the help of lasers are safe, they're not embryotoxic, and we create a hole in the zona. And after we create a hole, so you can go inside, pull out a cell. It is a very difficult technique, but with time you can understand. So all the frozen embryos have got very hardened zona, and at times, if patient's age is more, and if you're getting repeated failures, then you might think of thinning the zona. So this is, nowadays we have got programmable lasers with us. We can draw a path, and you don't have to move the embryo. The laser moves. See, he has drawn a path. And now after drawing a path, see the laser is going on, and along the path, the zona will be thinned. So the theory is that the zona is hard and it is not able to hatch, and the embryo cannot come out. But if you thin the zona, it helps it helps the embryo proper come out, and then only implantation will take place. Till the time zona is not hatching because of any reason, inherent factor or because of vitrification. So see, they have thinned the zona, and now the embryo can come out and it can have higher chances of implantation. Now, the last thing which I want to tell you is the pre-implantation genetic testing. Nowadays, we are doing only day 5 or day 6 embryo biopsies. And this is already a breach is there in the zona and the embryo is coming out. The trophectoderm cells are coming out. So when we do this, see, so he is aspirating the cells which are coming out. So around 6 to 8 cells are required for a proper genetic diagnosis. So you aspirate the cells and pull them, and through the traction method, the cells can come out. Or you, after aspirating them in the pipette, just give few laser shots here, and it will automatically detach from the main embryo mass. So a lot of patience is required for doing embryology. It's not that you can't do it in a fraction of seconds. It takes time and a lot of effort is there. So see, now the embryo has detached. The cells have detached from the main embryonic mass, and then they can be sent for genetic analysis. Again, there is a way of how to send it for a genetic analysis. So that was a hatched embryo, and this is not a hatched embryo. In this, we give laser shots in the zona, and we want the embryo to expand so that the embryo proper and zona can be seen separately. So we will give it a few tweaks, and we'll just push it with the help of aspiration pipette. See now, see the embryo folding. So there will be some space which will be created for the pipette to go in, and when you go in, we aspirate the cells. It looks very barbaric, but believe me, all the embryos survive this procedure. So now I've taken the right number of cells, and I'll give a few shots, because more laser shots you give, more embryo anomalies are introduced. Just give one shot on the top and one at the bottom, and then there is another way of detaching these cells from the without the help of laser. Also, we can do it. There is a technique. So now it detached, and you can send it for chromosomal analysis. So with this, I thank you all. My presentation is over, and thank you so much. And before I end, I would like to say that we are running courses on clinical embryology and IVF at the Fertilis Academy. We are doing online trainings, as well as we are doing hands-on trainings, which we are advertising at regular intervals. So you can visit our website, thefertilisacademy.com, or call me directly. This is my WhatsApp number also if you need any assistance. Thank you so much, and I'm open to questions now.
Thank you, sir, for enlightening us about the workflow of IVF assisted reproductive techniques. Now I request my chairperson of the session for any comments or questions. I request Dr. Rashmi Malhotra, ma'am.
Thank you. Thank you, Dr. Saripri, for such a wonderful and extensive presentation. We felt that as if we have really visited the lab. But I would like to ask one question. Though it was made very clear by you that the maintenance, the establishment as well as maintenance of the lab is extremely important, and it is a Herculean task, which involves both the macro and the micro management, and various SOPs have to be laid down for handling the embryo. But part of your presentation, the embryo while doing the genetic testing.
See, there are, it's a very good question, actually, Dr. Rashmi. The chances of embryo damage are quite high, because we are not only exposing the embryos to embryo biopsy, which again looks very rustic and very rough, when we're doing it. But most of the embryos will survive embryo biopsy in well-trained hands. Another procedure which we have to do along with embryo biopsy is embryo freezing. So you have to freeze the embryos, because the genetic reports do not come in 2 hours and 3 hours. It takes days and weeks for the genetic reports to, final evaluation, and they'll reach you in suppose 3 weeks. And then after 3 weeks, you warm those embryos. So the embryo is being exposed to 3 things. You're exposing it to a micromanipulation. You are kind of, doing an embryo biopsy and first intervention, which can go wrong. And then you are doing a vitrification, which can again go wrong. And then you are doing a thawing or warming, which can again go wrong. So it's a risky procedure. Having said that, there are studies which say that in good hands, all the 3 procedures generally go out very well, and the embryos are able to survive all the 3 techniques.
Okay, sorry for the interruption, but the other part of my question would be, who bears the cost if the procedure goes wrong?
Patient, because everything is being explained to the patient beforehand.
Okay, right. And what is the what is the cost of IUI, IVF, and ICSI in India right now?
See, for IUI, it's like between 5 to 10,000 rupees, depending on the facility and the doctor. And for IVF, generally it ranges between 1 to 1.5 lakhs per cycle. Freezing will cost you around 25,000 or 10 to 25,000. You know, again, it depends from region to region, paying capacity of the patient, where you are located, which city you are practicing. But generally, between 1 to 2 lakhs, you can get an IVF or a ICSI done nowadays.
Okay, thank you.
Now I request Dr. Vivek Mishra, sir, to kindly put some comments or questions. Dr. Vivek Mishra, sir.
Am I audible?
Yes, sir. Yes, sir.
Yeah. Yes. So, Dr. Sarapati, first, thanks to your question was very informative, very educative, and each and every steps and minute details were clearly explained by you. So the basic thing is that in the IVF lab, the lab is the core component, and we should have the meticulously quality control over that. So how frequently do you check on this quality control? Do you have any auditing system over the quality control?
Daily checks are there.
Daily checks are there.
So the checks are done daily, except for pH and particle counts, which are done every 3 months. Particle counts you can do every 6 months also. pH we do every 3 months. Rest, temperature, CO2 pressure, oxygen pressure, humidity and all, they are done almost every day.
So have you any auditing system? You take the help of external source or?
We have got instruments in-house. So it is good to have instruments in-house because for pH and all, it's little expensive instruments. So we have outsourced it.
Okay.
Some instruments are cheap, like temperature instruments, gas analyzers, and they are relatively reasonably well priced. So those, and they're very important to monitor them every day. So we have bought the instruments and we are doing it on our own every day. Okay. Whereas some pH and all, they're difficult to handle. So we call the company guy.
Okay.
Also,
so your videos were very clear. सर एक हिंदी में कहावत है कि आपने शेर के मुंह में खून लगा दिया, ब्लड लगा दिया है. Now much needed, sir, hands-on workshop is much needed now.
Sir, we are doing it in March. We cancelled one. It was supposed to be done last week, but because of COVID, we had to cancel it.
Okay. So one more question, sir. How will you guide our young anatomist to choose this clinical embryology as a career?
It's my dream that, you know, most of the anatomists should take up this branch and they should, you know, take up the IVF, the lab part is at least in their hands.
Yeah.
I have given my phone number and email ID. I can share it with you again. So I can't share it now. If people permit, then they can take a screenshot and they can be in touch with me. So we are there to guide, and we want our fellow anatomists to, you know, come up in this branch. And along with their, you know, medical college jobs, all the colleges nowadays have started developing IVF centers also. So they can, you know, they can be posted for some months in the IVF facility also, and some months in the teaching facility also. So that can be arranged.
So if we plan to establish a lab, IVF lab, so how much costing will be there at the institute level?
There is no end to the cost actually, but any good lab, it starts around any basic lab, will you have to spend at least 60-70 lakhs to start with. Land is yours, and you know, I'm not taking the civil part of it, I'm just taking the technical part of it. Around 60-70, and prices have actually gone down. When we set up a lab, this is a corporate hospital, these guys spend around 1.5 CR. So, but then the more, you know, the same thing you will get for 3 lakh, the same thing you will get for 25 lakhs also. So according to the budget, you can make the choices. So you can start with 50 lakhs and you can go up to 2 CR also. And then if you want you want a very high.
Are there any funding agencies that are helping to establish these labs at any institute or?
Bharat Sarkar and Bharat Sarkar. There are no funding agencies as such. They're all private money or government money, nothing else.
Okay. Thank you, sir. Thanks a lot, sir. Thanks a lot.
Thank you, sir. Now I request Dr. Manisha ma'am to put any comments or question. Dr. Manisha ma'am.
Unmute. Ask
She's
her.
unmuted, I think. She's muted.
Kindly unmute her.
Okay.
Yeah.
Thank you. First of all, I would like to thank the organizers for inviting me to chair this session. Secondly, I wanted to clarify, I was not the past president of Anatomical Society of India. It was a past president of Anatomical Society of India, Odisha State Chapter. Okay. And thirdly, I would thank Dr. Sarabpreet Singh sir for a very lucid presentation on what goes on in the IVF lab as such. Sir, I have one question for you.
Yes, ma'am, please.
Just I wanted to know regarding where do we register or certify for this lab if we want to set up as such certification?
You have to register with ICMR, who will be giving you a registration number, and then you have to register at the PCPNDT Civil Surgeon Office, the CMO office.
So that is done before setting up the lab as such, with paperwork, everything, or how is it?
Ideally, it is done before setting up the lab. You have to register the ultrasound machine, all the instruments, and there are details. There are set forms. Form A is there, which we fill, and Form B comes back within 3 months, and it comes as a registration certificate only. So we can guide you on that also. I mean, how to apply for registration and what, there are different sort of registrations which you apply depending on the procedures you are going to undertake in future. And there are norms. Even they've defined the area, the staffing, everything is nicely defined by PCPNDT. So it's
it is as such a teamwork you are carrying out over there.
It's a teamwork, and it's a detailed lecture, on setting up of how even the infrastructure requirements, the technical requirements. It's a detailed lecture. I think it's a detailed lecture which we can do anytime, whenever you wish.
Sure, sir. Sir, and one more thing, may I know who are eligible to carry out this clinical embryology course, or anyone can do?
Recently, in the new ART bill, they have defined embryologist as a doctor with a MD degree,
okay,
not less than 2 years of experience, or a PhD in the field of clinical embryology, with again not less than 2 years of experience. I think 2 years is a little less to I think it should be not less than 4 years.
Okay.
Embryology, but again that is how government agencies have defined 2 years. So
MD, they have specified only other subjects, gynae or any other, or anatomist also.
They have not specified MD. They have specified medical professionals with a MD degree, with a master's degree, and PhD in clinical embryology.
Okay. Thank you, sir. Thank you. Once
Thank
again.
you. Thank you, ma'am.
So,
sir, there are some questions in the chat box. Question by Dr. Jyoti. Write a note. Tell the note about warm embryo transfer.
So, warm embryo transfer, ma'am. We identify the embryos which we have frozen and in the cryo can, and then so it is like during freezing, what we are doing is we are removing water, so that when we freeze the embryo, it directly becomes glass and no ice crystal formation takes place. Now, when we warm the embryo, we have to replenish the water which has been pulled out during freezing. So you replenish the water, kind of rehydrate the cell. And at the same time, when you rehydrate the cell, there again should be no ice crystal formation. And so a lot of water is going in during warming. But at the same time, it should be controlled diffusion into the cell. If it is a very fast diffusion, it will be leading to osmotic injury. The cell will burst. So you have to be very careful while warming. Warming is a much more important step compared to freezing. It is even more critical because a lot of injury takes place during warming compared to during freezing. So these are all technical things which when you do, you understand much more. If I say osmotic injury, probably it will be difficult to understand. Chilling injury is something which is due to ice crystal formation. Osmotic injury is another term which I showed in my presentation also, but I didn't touch upon it. But since you've asked this question, so both the injuries have to be prevented in order to achieve success.
Okay, thank you, sir.
Freezing has got 5 T's. freezing and thawing. Technique, temperature, temperament, and testimonial, which is the, where you are storing the embryo. And there's another T, I think, which I've forgotten. I'm sorry. So there are 5 T's which are important: technique, temperature, and
Is it time?
time. Yeah, time.
Oh.
Yes, time is important. If they're saying 12 minutes, then 12 minutes. 40 seconds means 40 seconds. You can't make it, 80 seconds by your own whims and fancies.
Okay, so thank you, sir. Thank you, ma'am.
Thank you.
So we can see DR Singh, sir. Also, he's connected to us. Sir, I request you to please help us with few words of wisdom. Sir, please unmute yourself. Sir, DR Singh, sir. Sir, we have requested you to please unmute yourself to enlighten us with some words of wisdom. Sir, yes, you are unmuted, sir. You can speak, sir.
Hello.
Yes. Good evening, sir.
Am I audible?
Yes, sir. Definitely, sir. We welcome you.
First of all, I must compliment Dr. Sarabpreet Singh for a very lucid and informative talk. It was a very difficult, it is rather a very interesting clinical entity, and as he dreams, young anatomist can take up. But the cost which he has set to establish is not accessible by most of the colleges, I propose. And but anyway, he has given a very difficult topic in a very lucid interval. So I again congratulate him for his great talk.
Thank you, sir.
Okay, thank you, sir.
Okay, thank you, Dr. Sarabpreet.
Thank you, sir.
So we move forward with certificates. So hereby I present the certificate of appreciation to Dr. Sarabpreet Singh, sir, for delivering a guest lecture entitled "What Goes Inside an Embryology IVF Lab" in this session. Thank you, sir. Then we also give a certificate of appreciation to Dr. Rashmi Malhotra, ma'am, for chairing this session today with us. Thank you, ma'am.
Thank you. Thanks a lot, organizers. Thanks a lot.
We present the certificate of appreciation to Dr. Vivek Sharma, sir, for chairing this session. Thank you, sir.
Mishra.
Oh,
Welcome.
Thank you, sir. We present the certificate of appreciation to Dr. Manisha, ma'am, for chairing this session. Thank you so much, ma'am.
Thank
for
you,
your
Dr.
time.
Ritesh. Thank you.
Ma'am, Dr. Nikhil.
Sorry.
And then we present the certificate of appreciation to Dr. Swati Saxena, ma'am, for moderating this session wonderfully. Thank you so much, ma'am.
Thank you, Dr. Nikhil.
So lastly, I would call upon Verma, sir, to conclude this session. Thank you so much for the wonderful arrangement. Thank you.
Thank you, Dr. Nikhil.
Thank you.
First of all, thank you, Dr. Sarabpreet. So nice, so lucid talk on the IVF, so vast topic, can't cover in 1 hour, but he stimulated all of us to do something in this field. Right now, the company representative here, they play some video regarding the IVF lab, especially regarding the male infertility, semen analysis. So I request Dr. Sarabpreet to ask to company personals play their video. And I can see Dr. DR Singh on the screen. Good evening, sir. I need your blessing.
I am very much involved with this conference because the topic of Dr. Sarabpreet was so interesting that I could not stop looking it through from the beginning to the end.
Yes, you are absolutely right. Thank you, sir. Thank you very much.
It was very important topic as well as very well delivered by Professor Sarpreet.
Thank you, sir.
Thank you.
At the beginning of it, Dr. Sarpreet Singh said it is a very long talk, but I think so when the topic, when the lecture is started, we all are thinking why Dr. Sarpreet is ending now this lecture. It must be go on. We all want to listen more and more. Dr. Sarpreet, now you can go ahead with your personals.
For your kind words. Now we will hand over the stage to Mr. Sehgal. He is the director of Infotech company, which is a leading company dealing with lot many things, and they have their own ART bank. They deal with sperm samples, frozen sperm samples, and they are taking all the required, precautions regarding the storage and transport, and they're following all the government guidelines also. So, Mr. Sehgal, I hand over the dice to you, and kindly unmute yourself. Rakesh, can you just switch on his, ask someone to switch on his camera, and so that he can share the screen and carry on with the video demo. So Mr. Sehgal will be demonstrating 4 techniques: semen analysis, sperm vitality, semen preparation, and sperm morphology. So these are the 4 chief male workup techniques as far as the lab is concerned. So Mr. Sehgal, are you there? Rakesh, kindly unmute him. अनम्यूट तो करो उनको, म्यूटेड है वो और कैमरा भी ऑन नहीं है. आप उनको बोलो मिस्टर सहगल हैं. हाँ जी.
Great, I think you're unmuted.
Yeah, Mr. Sehgal, how are you? Good evening.
Good evening, sir. Namaskar.
Good to see you, sir, after a very long time. वो भी virtually.
COVID has not been kind. We've been working virtually only for the last about 2 years now.
Every week also, I'm seeing you after like 2-3 years now.
Yes, sir.
Sir, you can introduce a little bit about you and your company, and then you can start off.
Positively, sir. Thank you for your kind words. Namaskar to all esteemed audience. Nothing much about our organization, but for the fact that we are a very small organization specializing in only andrology. So today, what I'll be presenting to you would be ABC of andrology. And we specialized into this because we started India's first semen bank in 1995. And today we have 8 semen banks where we process and freeze donor semen samples. And that's how this entire journey started. Not going too much into the commercials of things, I would straight away go on to the academics. You heard one side of the things, that is the IVF lab side. Now today, I'll try and take you over the next 1.5 hours through what we call as the andrology, starting from semen analysis to various functional tests of the sperms and going on to how to do semen processing. In 2020 itself, we received the latest version of the WHO manual, where a lot of things changed. So we have incorporated some of them into our presentation, but some are still, we are trying to understand as to what exactly would be the implication and how can we implement into our lab scenario. Coming to the WHO manual, and this would be an interactive session, so I would request you to please stop me wherever you have any queries so that we can make it more interactive. I'll be using videos as a background to explain the procedures, which we would love to do that in the hands-on as well. Corona or Omicron permitted. So coming to the most myself to semenology, we start off with the very, very basic, that is the collection of the semen in the lab. Very clearly, we have to make sure that the plasticware we use for semen collection has to be tested for chemical safety, as Dr. Sarpreet before me very clearly pointed out that these are SOPs that we use in our labs. They have to be sterilized using gamma radiation. They have to be individually packed. Once they come in, we open it from the wrapper. We write down the name of the patient, the time we are giving the container to him, give the patient very clear instructions that he should be going to the semen collection room. washing the penile area with water, no soap, dab dry with tissue, masturbate and collect the sample. As soon as it comes back to us, we do our first test, which we call as the volumetric analysis. And WHO now says that for doing volumetric analysis, we should not be depending on what we used to do earlier, that is the pipetting and stuff. We should use devices like this. This is a very simple weighing scale, which is available for about what, 300-400 rupees on Amazon. So what do? We switch it on. This is something which you would have seen your jewelers use, because this is less than 100 grams weight scale. So what do? Before we give the container to him, we put the container on the weighing scale and measure the weight. Supposing the weight here, what is showing me is about 14 grams. So once the container comes back to us and I put it right back on top of the scale and it shows me 16.2 grams, I can comfortably write down that the volume is 2.2 ml. Once we've done that, we do the first part, that is what we call as the semen analysis. We transfer the container into the incubator for a period of 20 minutes, waiting for the liquefaction to happen. Once the liquefaction completes or the 20 minutes have elapsed, we pick up the sample using a pipette and mix well and do what we call as a drop test, where what we are trying to do, I'll show all these to you in the video once it follows later in the demo part. What it tells us is that the liquefaction is complete. The strand forming between the tip and the drop formation should be less than 5 centimeters. If it is, then in that case, if the sample is well liquefied. We do the pH test right at this time, but there we have a small blockage because the pH papers available right now are sensitive to 5, 6, 7, 8, whereas what we are looking for in terms of semen is 7.2 to 7.6. But at least it gives us a little idea. So we put a drop on our pH paper and look at the pH of the semen. Now we put the semen sample, a drop on a plain slide, put a 22 into 22 cover slip on top of it. And do not press from any side. By the weight of the old cover slip, the cover slip settles down on top of the sample and gives us what we call as the analysis. But the problem with that is that we don't have a reference point. That is, we do not know which side to start from and where to finish. Hence, the concept of the sperm counting chamber comes into play. And how do they work? We put a drop of semen on a plain, undiluted specimen. Now I'll start sharing with your permission. Oh, my screen sharing is disabled by the host, so you'll have to enable it, sir. I hope you can see that. So this is a counting chamber on which we have the top and the base is now exactly 10 microns. We are supposed to count any 10 squares adjacent, either vertically or horizontally, but a minimum of 10 squares and a minimum of 200 sperms. This is exactly as per WHO. Why this is important is because sometimes when the count is low, we sometimes count maybe about 60 of them in 10 squares and say that the count is 60 million. But WHO says that you keep counting till your count comes to 200. So the concept very simply here is that we are supposed to count any one square at a time. I'll just take it on a higher magnification. We count only the motile ones first, one square at a time, write down on a piece of paper and then count the non-motile, add up what we found on the 10 squares. The motile count divided by total into 100 gives you my percentage motility. The motile count into volume gives me my total motile count. This is important once we come to the second part of things, that is for finding out which procedure to use in which indication. Now, the problem is that this count and motility procedure, however done, gives us a beautiful count and all that stuff. But the problem that we have is that Can you see the screen? Because it tells me my screen sharing is paused.
Your screen is visible, sir.
Thank you very much, sir. Thank you very much, sir. There was a little confusion here. So, okay. So now WHO says that besides doing the count and motility, we must also do what we call as the functional test for these pumps. And some of the functional tests you would realize are so simple to do that we sometimes wonder why we were not doing it in the past. And the first one that we'll be demonstrating to you is what we call as the vitality staining, which is a very, very simple process to do. All you have is a vitality stain. You need a cover slip, a slide. We take the semen sample, mix well. Put a drop on the slide. Take my vitality stain, which in this case is eosin stain. Put a drop of the same on the drop of semen. Take my cover slip with the edge. Mix up the sample. And put the cover slip on top of it and straight away take it for analysis. And what does the analysis show us? I'm pausing it here for the sake of analysis. The sperms which pick up the stain are the ones which are counted as non-vital, and the sperms which do not pick up the stains are the ones counted as vital. Here again, we use the principle of you counting 200 sperms and report it as percentage vitality. Can you see the difference? Vital, non-vital, non-vital, non-vital. This is a very simple test to do. Oops. But gives us a beautiful information about the fact that sometimes when we assumed that the count was and the motility was good, when we do the vitality, we realize that the reverse is true. That is, the sperms which we were counting as motile were necessarily not the ones which were going to give us results. And the reverse is also true. Sometimes we get very low motility and we realize that the vitality is high, which gives us immediate pointer towards the possibility of perhaps blockage in the seminal vesicles. That is the fructose, that is the energy source for the sperm not coming. So these functional tests are very good guidelines in terms of finding out actually what is going wrong and validating the count and motility that we have been doing. You can do the same procedure by even using it as a eosin nigrosin stain. Only difference being that this is a live staining, takes only about 10 seconds to do. Whereas in case of an eosin nigrosin, we'll have to make a smear, let it dry, and then the background, which is pinkish here, will become dark. So this pink color or the stained sperm sort of shines out towards you. Another way of doing this same test is what we call as the hypoosmotic swelling. So you take open an ampule, break it open, add about 20 microliters or 2 drops of semen to the ampule, mix well and put a paraffin film on top of it. 30 minutes, sorry, let's not go to analysis, let's do the, we put the paraffin film on top of it and write the name of the patient so that no spillage and no mixing can occur. 30 minutes later, we take the ampule, take a pipette, mix well, and put a drop on a slide and put a cover slip on top of it, and immediately go in for analysis. And what does the analysis tell us? Sperms which are showing you coiling of the tail, this one as well as this one, both are vital. And the sperm which are showing you straight tail are the ones which are the non-vital ones. Vital, 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 and so on. So again, we count it as 200. So the question which would perhaps pop into your mind is that why do I need to do both the tests? The reason very simply is that the application is different. Now imagine a scenario where you're doing only an analysis, a simple eosin staining would do. But if supposing you were doing a microsurgery procedure like you've done a TISA, you've picked up 4 sperms from the retitestes or from the seminiferous tubules. there, because they are not motile, it is impossible to find out. And we can't expose them to eosin dye because that would be toxic to them. So we expose them to HOS under laminar flow hold. Sperms which show me the coiling of the tail after 30 minutes are the ones which are then transferred to my IVF media, wait for the coiling to become straight, and use that one now for the purpose of my ICSI. So procedure or the analysis part is the same, only the application varies. That is, this is a non-toxic where I can reuse the sperm, where I could not reuse the sperm which I've exposed to eosin or eosin nigrosin stain. So this in a nutshell is what the vitality staining is all about. Now we come to the most important part, which has now been made almost mandatory, which is the morphology. Now for morphology, you will be needing the stains, that is the A and B stains. You will need a fixative and you will need the mineral oil and 2 slides to start the procedure. The procedure goes like this. First, we take a drop of semen on a slide. Take another slide. Make a smear. Let it dry naturally. Once before we sort of put it for drying, we must write down the name of the patient. In this case, we are marking it as XX. Once the drying is complete, I take my fixator, spread it right across the slide that I have just prepared. Again, let it dry completely. Once the drying is complete, I go to the next level, that is open my A stain, which is the red one, which is in a Copeland's jar. Give it 20 dips. In this, and once finished, wash the slide dry. Wash the slide with water so that the excess stain can be removed. I repeat the same procedure now with my B stain, which is blue one. Again, 20 dips. Wash with water, let it become dry again. Once I confirm that this slide is completely dry, I take my oil, which should have the refractive index of 1, if in case your manufacturer is not supplying you the oil with the morphology K. Put a drop of oil on the slide, spread it a little bit so that we can observe a wider area, and focus it at 100x magnification. Now, both the other tests that we have done so far were focused on 40x magnification. This is the only one we'll be doing at 100x magnification. Now here I've stopped this for a different analysis. Now every sperm, there is a possibility of 3 abnormalities which can happen. You can have an abnormal shape of the head. You can have an abnormally attached midpiece or an abnormal midpiece, and you can have an abnormally attached or an abnormal or more than one tail. So when we count one sperm, we look at 3 possibilities. In the head, the upper 40% has to be the acrosome, which is the pinkish portion, and the lower portion, 60% is the DNA, that is the dark blue. If at all you have vacuoles present, we allow 1 or 2 vacuoles to be present in the acrosomal area, but we never allow or accept as normal vacuoles present in the DNA area. Now here you can see it a little more clearly that you have the upper 40% and above as the acrosomal area. You have a vacuole present here, but because it's in the acrosomal area, we are considering it. So this is a normal sperm, normal midpiece, and normal tail. Abnormal head, very small acrosomal area, wrongly attached midpiece, and a coiled tail in this sperm. So you have this sperm where you have all the 3 abnormalities simultaneously.
Mr. Saigal, I have one question.
Yes, sir.
How many ml of the semen required for the analysis for this procedure?
Sir, we just need 1 drop.
For the whole analysis, how much quantity of the sperm you have to collect?
See, we've collected the entire semen in a collection container, out of which we have used 2 drops for, or 1 drop for the eosin, 1 drop for the morphology, and the other test that I'll be showing you, another 2 drops out of it. So I would say about what, 40, 50 microliters?
40-50 microliters is sufficient for the whole analysis of the sperm?
Yes, sir. Yes, sir. More than sufficient, sir.
Okay, thank you.
And which is the reason why, sir, why we do this test even on samples which we are going to prepare for insemination. Reason being that sometimes there are variations, and these are the variations because of which we may end up getting not the desired results. So this is morphology, what I was explaining. The first one, what I explained to you, was vitality.
Yes.
You can again see the
go
microsomal area.
Now you can go ahead.
Thank you, sir. Thank you very much. So this is morphology. Again, we count 200 sperms and report it as percentage, normal or abnormal, and we can even go ahead and record as to whether the abnormality was in the head, with piece or tail. So these are the 3 tests that we have discussed, that is vitality using the eosin, vitality using the HOS, or and doing morphology. Now we come to the most important test, what we call as the DNA fragmentation, which is the talk of the town these days, because almost everybody. Now here the kit that we are using is the one which has been prepared by Government of India from the National Institute of Health and Family Welfare, where you have 10 ampules for 10 patients. In this vial, you have 10 small discs, and you have the fixative and the staining reagent. You would need a slide, cover slip, and the procedure goes like this. I break open an ampule. I open the vial which contains the paper discs. Take this out. If you would notice, this is packed along with a lot of silica gel particles. This is the reason, because the chemical on the disc is very strongly hydrophilic. So we are trying to keep that away to increase the shelf life. So I introduce this disc into the ampule and leave it for 10 minutes. Once the 10 minutes are over, I put a parafilm obviously on top of it so that it doesn't do any spillage, and write down the name of the patient and make sure, I'm sorry, this is important, and make sure that the disc has reached the bottom. It should not get stuck somewhere in the neck, so that it can activate the solution there. 10 minutes later, remove the parafilm, mix the sample well, add 2 drops or 20 microliters of the semen sample into the same ampule, and put the parafilm again and leave it for exactly 10 minutes. It's important. The first 10 minutes was for the activation of the solution. The second 10 minutes are for the purpose of the solution to act on the semen sample. Exactly 10 minutes later, I put 1 drop of the fixative in the same ampule, making sure that it has reached the bottom, thereby stopping the reaction. And once this is over, I mix it well using a fresh pipette, put a drop on a slide, put a cover slip on top of it, and straight away focus it at 40x magnification for analysis. And what does the analysis tell us? Sperms which are still showing me the regular shape which I was seeing before I started my analysis. This is a fragmented DNA, and this is a intact DNA. You can differentiate between the size of the head now. Fragmented, non-fragmented, non-fragmented, and on. Fragmented, non-fragmented. 2 together will easily give you non-fragmented, non-fragmented. Non-fragmented, non-fragmented again in this frame. Fragmented and non-fragmented. So we again count as what is the percentage of the fragmentation which has happened to these sperms. So this finishes my sperm function test. So unless you have any queries, we go on to the next part, that is how to do the semen washing.
All the delegates are requested. If had any query, please ask. So Mr. Sehgal. All the delegates. My question is, Mr. Sehgal, what is the cost of this analysis?
Oh, normally we don't answer these questions in the academic sessions because I am from the commercial side of things, but because you asked
you can answer privately to me.
I can tell you even otherwise. Eosin testing costs you maybe about 15 rupees a patient.
Okay.
Morphology costs you maybe about 80 rupees a patient. DNA fragmentation costs you maybe about 600 rupees a patient.
Okay.
A fructose qualitative would cost you maybe about 30 rupees a patient. A fructose quantitative would perhaps cost you about 150 rupees a patient. So the cost is hardly anything. The only thing is that so far we were not even focusing on these things. And I'll tell you, now that you asked the question, I'll give you an anecdotal answer also. When we started semen banking in 1995, somewhere in 2000, we realized that when we used to send these frozen semen samples to doctors, and some of them used to come back with answers saying pregnancy nahi mil raha. And we started wondering, what is it that is going on? What could be happening that we can improve further? So we started doing these tests on our own donors somewhere in early 2000. And then that's when we realized that what all were we missing? And here comes to my most important presentation that I normally make to gynecologists. You are from the anatomy side, so this is not addressed to you, but as a gynecologist, all these people, including Dr. Sarabpreet, have been focusing so much on the female partner and missing completely the male side, which is responsible for 50% of success or failure. Earlier, till 2020 edition of WHO came in, even they were only focusing on the female side of things. Now, the focus is completely shifted, and some texts are now pointing out that as much as about 60% of the infertility is because of the male side, not the female side. And so far, what are we doing for the male? Only a semen analysis, which is not even standardized. You know, Dr. Sarabpreet made a beautiful point there, and I hope and I wish that people from this group who intend to start getting into this business should make sure that the quality is the most important thing. Because SOP or standard operating procedures for your lab, the quality assurance manual for your lab is what will give you results, not just doing the procedure.
Yeah, I agree with you, Mr. Sehgal. Wonderful presentation, and quality control is something which is missing in our Indian scenario. I mean, it's a concept which is missing in the whole society as a whole, I think.
Absolutely. Absolutely. More so on the infertility side.
That is the bottom line. So you have to maintain, and once you are doing quality work, you actually cannot go down ever.
Absolutely. Absolutely rightly said, sir.
So it's difficult for you to work in a different setting where the quality is not maintained. And when you are
invariably, sir, we get questions like, why are you expensive? Why is it costing more at this end? So if you want quality, you'll have to pay top dollar. Otherwise,
you have to pay for it.
So I hope I answered your question, sir. On the cost.
Yes, Dr. Sehgal, you can proceed.
Perfect. So now we go on to the second part of things. That is, once we have done the analysis, once we have found out what is the count, motility, total motile count, now we decide on which technique to use. Now, broadly, semen analysis is divided into two techniques. The first one being swim up, which was the age-old tested scenario, where this is how we started semen processing in the early 80s. And today, what is used mostly is what we call as the density gradient. Now, there are other techniques which have come in, like microfluidics, magnetic cell sorting, and there are devices which are available. But for the purpose of this workshop, we'll restrict ourselves to the two basic techniques, that is the swim up and the density gradient. Now, remember, we did the count and we did the motility, and we did a calculation which is motility into volume, which gave me my total motile count. Now, imagine a scenario where the count is 20 million, motile count, and the volume is 1.5 ml, which means my TMC is 30 million per ml. So for the sake of calculation, I'll stick to this 30 and say, if in case I was to do a swim up on this 30 million count, I'll be able to recover 3 to 5 million out of this. And if I was to do a density gradient, I'll be able to recover 15 to 20 million out of this same 30 million count. So now your technique of choice would be based on what is the end procedure that you're intending to do. If you're only intending to do IUI, then in that case, density gradient is the only choice. But if in case you're doing IVF, where our requirement is 50,000 sperms per oocyte that we've taken out, a swim up would also do perfectly well. So again, the choice of technique would be based on what is the end result that you're looking for. So based on that, now I'll quickly take you through the just 1 second, sir. I think I closed my other files. So let me first take you through the.
No problem, sir. Take your time.
These last 2 years have actually taught us a little bit about, otherwise we were so used to doing this live that we were not even comfortable with these computers. I mean, to the extent of you making a presentation out of it.
Okay.
Hold on. Let me mute this so that I can do the buck. Now, when you're using a swim up technique, the only media that you'll be needing would be a swim up media. That is the HTF, in this case, what we are using. Now, again, swim up is divided into two parts. One we call as the centrifugation and swim up. There, what we do is, again, this is the liquefaction test I was talking to you about. That is, we mix the sample and do the drop test. We put a drop on the counting chamber. In this case, we are using a cell counting chamber. You could use Macklers, you could use Petrov houses. There are so many of them available in the market. Put a standard 20-22 cover slip on top of it and focus it at 10x or 20x magnification. And look at the count pre-wash. Again, counting 10 squares vertically or horizontally. We record the count. Now we go to the procedure. We first, I'm showing you first what we call as the centrifugation and swim up procedure. So we break open the ampule. Goes without saying that the 5 equipments that are needed for doing the semen processing are the same irrespective of what procedure you're using. So I missed this out earlier. We need 5 basic equipments. We need a centrifuge machine, which should have a digital speed and timer control. We need a seminology incubator, which should be able to maintain an exact 37 degrees centigrade temperature. We need a laminar flow hood to make absolute aseptic conditions while we are doing the processing so that no infection from our side ends up on the sample. We need a compound binocular. We mostly use trinocular because we also video record along with it. And you need a sperm counting chamber. These 5 equipments can help you do your andrology, your IUI, and your semen preparation completely. So what we're doing here is in a centrifuge tube, we are adding the semen sample. Okay, sorry. Once we've added the semen sample using a fresh pipette, we add the exact same quantity of media into the semen sample. That is 1:1 dilution. Mix it well. And put it in a centrifuge machine. After counterbalancing, now this is another important part which I'm sure you guys are aware, that is we must counterbalance the tube with an equal amount of water so that the balancing is fine. Put it in a centrifuge machine diagonally opposite to each other. Centrifuge it for 15 minutes at 1200 RPM. 15 minutes later, what we get is a pellet at the bottom and the media on top. We remove the pellet completely. And using a fresh pipette, gently layer 1 ml of the wash media on top of the pellet. Put it at an angle of about 45 degrees in a test tube warmer or in a test tube stand inside the incubator for a period of 45 minutes, allowing for the best of the sperms to swim up into the upper portion of the tube. And now, 45 minutes later, I transfer the upper portion into a fresh tube, centrifuge it for 5 minutes, at 1000 RPM. Again, you will form a pellet at the bottom. I'm sorry, this is ज़्यादा forward हो गया. Remove the supernatant. From on top of the pellet, add another 0.5 ml of wash media to the pellet, mix well. And now the sample is ready for loading. We can straight away load it into the cannula, put a drop on the counting chamber for doing a post-wash analysis, and do a post-wash analysis of the sample before we send it for insemination. This is my swim-up technique. Swim-up technique can also be done by one more method, which we call as neat semen swim-up, which is what mostly these days people prefer. Because the problem with centrifugation and swim-up is that when we are centrifuging, along with the semen sample, or the RBCs, the WBCs, the survival plasma, everything is settling down in the pellet and getting tightly packed, which can increase the ROS generation. Hence, mostly people prefer the second method, which I'm about to show you, which is, again, we are doing a pre-wash analysis before we do the procedure. Here, the procedure goes like this. We take the media ampule. I'm sorry, मैं थोड़ा forward कर रहा हूँ इसलिए कि मैं ज़्यादा देर आपको बोर ना करूँ.
Sure, sir.
Now,
Sure, sir.
We now take a round bottom tube. Gently put 0.5 ml of the semen sample into a tube. Now, if in case you have a sample which has 2 ml, I'll be doing 4 tubes at the same time. That is 0.5 ml of the semen sample on each tube, and gently layer my wash media again, like I did last time, on the semen sample. But this time I'm not mixing. I'm just layering it on top of the semen sample very gently without mixing. And you can differentiate that the media is very clearly visible. So I put 0.5 ml of the semen sample and I add 1 ml of the wash media on top of it. Again, put it in a 45-degree angle, leave it for 45 minutes, 30 to 45 minutes for the sperms to swim up. But this time, because they are swimming up from raw sample, the possibility of ROS gets greatly reduced. So for all the tubes, we put them in the test tube warmer or incubator. And now, 45 minutes later, I transfer this upper 75% to a centrifuge tube. And I do it, with, if in case I've made 4 tubes, I do it with all the 4 tubes. That is, pick up the upper 75% and transfer to a fresh tube. Centrifuge it again for 5 minutes after counterbalancing at 1000 RPM. And what do we get at the end of 5 minutes is again a pellet at the bottom. And the supernatant on the top. We remove the supernatant, add 0.5 ml of the wash media, mix well, load the cannula, put 1 drop on a counting chamber, and do what we call as a post-wash analysis. Now, this is both the ways swim-up technique can be done. That is the neat semen swim-up as well as the centrifugation and swim-up. Now we come to the second technique, which is what we call as the density gradient technique. So I'm showing you the density gradient technique as well, sir. Here, there, if you remember, we used only one kind of media, that is the washing media. Here we'll be using 3 kinds of media. You have the lower density, that is 45% 1 ml. You have the higher density, that is 90% 1 ml, and you have the wash media 5 ml. So again, we check for liquefaction. We do a pre-wash analysis. Now we do the actual procedure. First, we take the 90%, which is the higher density, and transfer it to the bottom of the conical bottom tube. Now we break open our second ampule, which is the 45%. And this would require a little skill. which is the reason why the embryologists are so sought after these days. Very gently layer it without mixing. Drop at a time. And if you do this right, you'll be able to see both the layers very clearly in your tube, because both have different densities, so they are sort of visible. Once we've done that, we now layer the semen sample on top of the density gradient. Counterbalance and put it in the centrifuge machine for 15 minutes at 1200 RPM. So 15 minutes later, if you notice, we have now the semen sample, which, you have our semen sample here, you have the upper density, you have the lower density, and you have a pellet at the bottom. If you see very carefully, you can see the difference in the colors of the layers also, and something in the interface as well. Now we first remove the semen sample from on top. We remove the medias after that. I mean, I would normally suggest that when you're starting off, don't do this in a single step, because here we do it faster. But normally it is easier or better to do it slowly. Now we break open the larger ampule, just take 2 drops of the wash medium. This procedure is a little different because now we take 2 drops of the wash media, add it to the pellet, mix it well, and transfer it to a fresh tube. Because in this tube, beyond the 2 ml mark, around the walls, there is still seminal plasma hanging, and we don't want this to enter into the uterus, otherwise it will give us cramps. So the second procedure of the washing we'll be doing in a fresh tube. So I transfer the resuspended pellet to a fresh tube, add another 2 ml or 3 ml of the wash media to this resuspended pellet, mix well, counterbalance, centrifuge for 5 minutes at 1000 RPM. After the centrifugation, remove the supernatant, add another 0.5 ml of the wash media to this, do a post-wash analysis, and my sample is ready for insemination. So this completes my presentation for the day. So if you have any questions, feel free to ask. I hope you enjoyed it as much as I did.
Yes, Mr. Sehgal,
you
covered whole topic very nicely. My question again, like with Dr. Preet, the delegates are asking, how much cost going to establish the lab only for the semen analysis?
Sir, IUI lab, as we call it. Sir, would you like to answer this question, or do you want me to?
Just I want.
You tell the cost of the kit. I mean,
okay.
Is a personal issue, no?
The cost of the lab, as I said, you require 5 equipments, would be less than about 200,000 rupees, depending on which part of the country you are, because transportation is additional there. That is all the 5 equipments. The procedure costs you anything between 200 to about 550 rupees per procedure. A swim up would cost you maybe about 200 rupees per procedure. A density gradient would cost you maybe about 600 rupees a procedure. It includes the plasticware, that is the tubes, pipettes, container, IUI cannula that you'll be needing per patient per procedure.
Actually, Mr. Sehgal, we are anatomist. Now we are stimulated regarding the IVF and the embryology. So yes, I think so. Our delegates are also very much excited there, and all our delegates want to establish lab in our department. If you want to establish lab, whole IVF lab is not able to establish in one time, but this part, embryology and the semen analysis, we can start from here. So for that, for the cost occurring in the establishing the 2 lakh rupees. Only 2 lakh rupees.
Yes.
Okay, thank you very much. Now our delegates are requested if they have any questions with the Mr. Sehgal, with Dr. Sarabpreet, both are here. Please ask the question. Otherwise, you can put the question in chat box. Later on, I will share the question with our experts. They will answer later on. Please raise your hand, by which we can unmute from our side.
So I feel that Rakesh and I were discussing about the possibility of doing a hands-on workshop in March. So Mr. Sehgal, I think you will be also open to going to Lucknow and doing a physical workshop.
Absolutely, sir. Always.
It all depends on our delegates, how interested they are. So Dr. Rakesh, you can take a feedback from
but one request and suggestion I'd like to make, let's not make it a 100 people workshop.
बहुत इजी है, मींस इतना डिफिकल्ट नहीं है, मैं बोल रहा हूँ नहीं कैरियर टाइपिंग हो गई, इससे तो बहुत इजी है।
साहब आपने कुछ बोला भी 100 क्या सुना नहीं।
मैं बोल रहा था कि अगर 100 लोग हैं तो इकट्ठे 100 लोग का वर्कशॉप ना करें, 20-20 लोग का 2 या 3 दिन में डिवाइड करें. We don't mind staying, but then the demonstration or hands-on gets reduced when you have a larger group.
Yeah.
We don't mind our team staying there for 2 or 3 days, because let everybody go back satisfied instead of including us.
How many of them are interested?
So by using this platform, I requested to all the delegates who are interested in the physical hands-on workshop, now group, WhatsApp group, and the email, each and everything with you, kindly share with us. Accordingly, we can plan, as Dr. Sarpreet Singh said, in the March, in the mid-March or the end of the March, we can plan.
So, Sehgal Sahab, how much time do you need to demonstrate the techniques? What we can do is we can divide the groups into 2-3 parts, and the whole session has been recorded today. So we can edit it and we can play the relevant lectures for a particular group. The second group can go for a physical workshop, and then we can switch. We'll try to do it in one. 2 दिन निकालना तो सर बहुत मुश्किल है.
डॉक्टर सरबप्रीत ना बहुत इस वक्त वो हो रहे हैं, मॉडेस्ट हो रहे हैं. हम लोग कोई वीडियो इसके बाद में नहीं होने वाला सर. इसके बाद में जो भी होगा वो hands on होगा. We'll make them do. That's why I said a group of 20s. We need about 1.5-2 hours per group.
ठीक है. So we can have at least three groups in a day.
Yep.
3 to 4 groups. और एक दिन में ही करेंगे. राकेश, आप अपने डेलीगेट से ना एक फीडबैक ले लो कि how many will be keen on doing it in March in Lucknow.
Sure. I will take the feedback from our delegates and take the request, and accordingly we plan what the dates and when we are planning for the hands-on workshop.
We can do it on a Sunday. The whole day we can spend. Sham ko we can go back. You know, that kind of.
Definitely. So with this,
I'm sorry, yes. Sir, Dr. Sarpreet, there are 2 questions I see on the chat. One is the eosin nigrosin tested flight preserved for a long time. Yes, that is the only difference between eosin and eosin nigrosin. When you are making an eosin nigrosin, that like morphology, this light can be preserved and can be recorded and can be even given to the patient. Now, the second question, what will the DNA fragmentation tell? Now, this is an important one. So I thought the clinical side, I'm sure Dr. Sarabpreet would answer, but I'll tell you from the lab side, our perspective. So far, we used to say the success rate in IUI or andrology is only 10 to 15%. What if this was the reason? We say that the carry home baby rate is low. What if this was the reason?
Sarpreet, in chat box, there is one question. You can say one request. Some delegates from South India, they want workshop in their region.
Why not?
We can plan that.
Dr. Sarabpreet is the right person to catch hold of.
We can plan that. Obviously, we need Mr. Sehgal's support. We
have our teams in the South, but we need some initiative from the clinical side.
Kailash Nath Babu, yes.
I'm posting my number with Rakesh. Your permission? Can I share my number?
Sure.
you can get in touch with us for South India, and we can plan a nice workshop in South India also. But we need at least for 40 odd delegates to carry a workshop in South India. उससे कम feasibility नहीं होती है. And rest of the things we can discuss the logistics and all.
Kailash B. Unmute to Kailash B. Kailash B, you are here? We start video later. Video later. No problem. So with this, I think we have reached at the end of this workshop. With the help of the Dr. Saraprit, Mr. Sehgal, Dr. Mona, Dr. Rajinder, Dr. Praveen, Dr. Jyoti, Dr. Anita Pandey, and obviously our team working very hard for this event. Especially Mr. Sehgal, you are ignite to all of us to do something, not hold the IVF, but definitely we can do endocrinology in our department.
Thank you.
Thank you so much, Dr. Rakesh, Dr. Punita, Dr. Rakesh. Thanks for the opportunity. Thank you, Mr. Sehgal, for your support. And so it actually went very well, and we were very happy to see the response. All the lectures, all the speakers spoke very well.
Yeah.
Yeah, it was a wonderful session, and hope to do it physically as per Dr. Rakesh, as per your planning, will execute.
Yeah, definitely we plan.
Yeah, kindly take a feedback from the delegates and.
Yeah, definitely I will take that feedback and plan accordingly.
Right.
So with this, with the permission of the Saraprit, Mr. Sehgal, and our delegates, especially our delegates, if they allow, we can end our session.
Yes, sir.
Unmute to everyone.
So if there are, we can take a group picture if it is okay with you, Rakesh.
Yeah. It is a request to all delegates, please switch on your video by which we can take the screenshot of the group photographs. All the delegates. All the delegates. And he was switch on your video.
Yes, sir.
14 years I have left anatomy.
And you started doing this. Yes, sir.
So, so much everyone for attending, and it was a real pleasure.
So, on the behalf of the Organizing Committee of the 68th NetCon of ASI, now thank you all. Thank you very much. All the delegates, all the speakers, chairpersons, moderators. Thank you very much. And now we are ending the workshop for today.
Thank you very much.
Thank you, sir.
Thank you.
Thank you all. अरे वो अपने पेपर भी नहीं
to start. Thank you, sir.
जब से इन्होंने ये सोका निकाला तब उनको पता चल गया अभी कुछ करा नहीं अपना ये अपना दुकान बंद हो जाएगा तब उन्होंने ये थोड़ा सा
Thank you all. Thank you, Dr. Verma.
Thank you, ma'am. Thank you, Manisha, ma'am.
Thank you.
Dr. Saim, you can unmute karo. I can see Dr. Saim is here. Dr. Saim Hassan. Unmute.
Hello, sir.
Yes, hello.
It's Dr. Sandhya from Brains. You could not let us allow us to open the video. Actually, my video was not getting started.
Actually, we can do again. We can do again.
Yes, sir.
allowed to open video, everyone. Now, open the video, everyone. All the delegates are requested, please switch on your video.
2-3 दिन अपना ये चला है ना, यूट्यूब से डाउनलोड भी कर सकते हैं।
तो वीडियो नहीं आ रहा है।
Now access is given to everyone. Please switch on your video by which we can take the photographs in the last. Saim, if you want to say anything, please unmute. Saim, yes.
No, sir, it is not turning on.
From our side, access is given.
I don't know, but earlier it was on. Later on, it got off.
Astos.
Because hydrology lab they are most college, but somehow we are these will definitely give us a opportunity to explore these areas.
Yeah, now everyone can open your video. Access is given to everyone.
क्या किया है?
YouTube का वो वीडियो नहीं ओपन हो रहा है, तो भी कर रहा है, मैं करके देता हूं।
No problem. Take the screenshot of the.
तो ये दिख रहा है, बस उतना ही देख लो।
Take the screenshot of the which.
अब ले लो।
इधर का एचओडी कौन? ये इनका कॉलेज ना ये है क्या? यूपी का ये किंग जॉर्ज।
Now we can see. Now we can see a lot of the delegates on the screen. We are taking the screenshot of the all of you.
क्या बोल रहे हैं? स्क्रीनशॉट ले लो क्या?
पर ओपन ही नहीं हुआ ना। ओपन होगा तभी तो स्क्रीनशॉट लेंगे ना।
Ma'am, access is given. Please just open your video. Access is given to everyone.
सबको ही दूंगा बोल रहा है ना वो।
I think so. Now all video is on except 1, 2, 3. Dr. Preeti video is not. No problem. So with this, I ending the today's session. See you tomorrow in the CME, and all the best for the rest of the conference. Thank you very much.
Thank you. Thank you so much.
Thank you.
Thank you. Thank you, everyone. Bye bye, everyone.
Hello.
Manisa, bye.
बंद किया, खत्म हो